शुभं कुरुत्वं कल्याणम् आरोग्यं धनसम्पदः शुभं कुरुत्वं कल्याणम् आरोग्यं धनसम्पदः शुभं कुरुत्वं कल्याणम् आरोग्यं धनसम्पदः शत्रुबुद्धिविनाशाय दीपज्योतिर्नमोऽस्तुते दीपज्योतिर्नमोऽस्तुते शुभं कुरुत्वं कल्याणम् आरोग्यं धनसम्पदः 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 शत्रुबुद्धिविनाशाय दीपज्योतिर्नमोऽस्तुते दीपज्योतिर्नमोऽस्तुते शुभं कुरुत्वं कल्याणम् आरोग्यं धनसम्पदः शुभं कुरुत्वं कल्याणम् आरोग्यं धनसम्पदः
Namaste. Good morning everyone. Myself, Dr. Madhvi Dilip Patwardhan, President, Indian Medical Association Sangli, on behalf of all our members, welcome all of you for today's CME. Today, we are very fortunate and privileged to have a renowned faculty who are nationally and internationally known speakers. Although they need no introduction, we will introduce them formally before their talks. I would like to welcome Dr. Lakshman Jesani, Dr. Mahesh Mohite, Dr. Roy Sunil Patankar, Dr. Parimal Laute, Dr. Rahul Kulkarni, Dr. Manohar Inamdar, and our own member, Dr. Govind Kulkarni. I really appreciate all of them for accepting our invitation to speak in today's CME, in spite of their extremely busy schedule. They are all authorities in their own field, and I'm sure that at the end of the day, all of the participants will have very clear concepts about the diagnosis and management of the very common ailments like headache, pain in abdomen, chest pain, and fever. So I think these are the ideal topics for IMA CME. I would also like to welcome Dr. Nitin Patil, our own member, who has accepted to be an MMC observer today. I would also like to welcome Dr. Abhijit Udgaonkar, who is a renowned transfusion medicine specialist who will be coordinating today's CME, and he will be assisted by Dr. Sanjay Kulkarni, a well-known laparoscopic surgeon, and Dr. Anand Malani, who is a well-known physician from Sangli. So once again, I welcome all of you and thank you for your immense response for today's CME. And I am sure that today's CME will be very informative and very useful to all of you. So with this brief introduction, I hand over the proceedings to Dr. Abhijit Udgaonkar.
For last 2 years, whole world was revolving around a 5-letter word, COVID, and all our medical webinars and CMEs across the specialties were covering only COVID, though it was a necessity that time. But again, we have to come to our basics of medical practice, that is differentiating and treating common clinical conditions. Hence, IMA Sangli decided to have the webinar on those ailments we face regularly in our OPDs. Though we have learned about approaching towards febrile illness, treating the pain in abdomen, knowing the etiology of headache, or evaluating and managing the chest pain in our medical college days years back, the science behind it is still getting updated over the years. Today's multi-specialty webinar sure will help us to learn about them again. To enrich our knowledge, we have a galaxy of speakers of national and international repute today's faculty represents not only leaders in their own professions, but also the ones with great oratory skills. Pre-lunch session will cover 4 topics and there will be 4 in post-lunch session too. Each topic will be followed by question and answer session. However, for smooth conduct of the session, I request you all that instead of asking directly, you type your questions in the chat box of the Zoom app. We will ask them on your behalf. So let's begin the webinar without much delay. Acute febrile illness is characterized by malaise, myalgia, and raised temperature. That is non-specific manifestation of infectious disease. Frequently, such fevers resolve without treatment, but fever may also be the onset of severe, potentially fatal illness. I would like to invite Dr. Lakshman Jesani to deliver the lecture on how to approach AFI in adults. Apart from being very busy clinician, he has got an excellent academic career and done extensive work in infectious diseases and infection control. After completing MBBS from Grand Medical College in 2006, he has done DNB in General Medicine, CCEBDM, MNMS, FNB, that is Fellowship in Infectious Diseases from DNB, and also awarded with prestigious fellowship in Royal Society of Public Health, UK, FRSPH in 2015. He is also trained in infectious diseases, Detroit Medical Center, Wayne State University, Michigan, USA in 2015. At present, he is working as consultant infectious diseases and infection control specialist, Apollo Hospital, Navi Mumbai, and associate professor, Apollo Hospital's Educational and Research Foundation. Dr. Jesani has more than 20 index publications in national and international peer-reviewed journals. His areas of special interest are transplant infections, HIV/AIDS, MDR-TB, MDRO sepsis, antibiotic stewardship, and infection control. He has got a number of special awards and recognitions. He is recipient of prestigious Infectious Diseases Fellow Grant and selection in International Infectious Disease Fellow Group at International Infectious Disease San Diego, USA 2015. Also honored with presentation in poster walk titled Challenges in Infectious Diseases, Potential and Existing Solutions in the same conference. Recipient of Sir Dorabji Tata Trust Travel Grant for training in infectious diseases at Detroit Medical Center, Wayne State University, Detroit, Michigan, USA. Recipient of travel agent by Clinical Infectious Disease Society at Level Infectious Disease Conference, SIDSCON 2015, Delhi. He has won many awards as Best Thesis, Best Poster, and Best Paper in various pulmonary and neurology conferences at state and national level, and has been faculty and speaker at various national and international conferences. Actually, this is the summary of his extensive biodata, achieved at very young age too. So Dr. Jesani, please.
So very good morning to one and all. What we're going to talk about is an acute febrile illness. And what I will show it to you is my approach to acute febrile illness, which I'm sure will be helpful to one and all. So I bring you warm greetings from my institute, that is Apollo Hospital, Navi Mumbai. Friends, what I want you to do is look at this picture. What do you see in this picture? So this is not any pathological picture. This is a picture about some group of people who are accumulated here, some group of people who are scattered here. This is just a group of people. So, but what can you make out from this picture? I'm sure you cannot make out anything much from this picture. But what will I do? I will zoom out from this particular picture and see what it appears. And now when I zoom out, you can see what this picture appears, and no prizes for guessing who this personality is. So friends, over the next 30 minutes, my aim would be the same thing, to give you a bird's eye view, how to have a syndromic approach to acute febrile illness. That how do we make a syndromic approach in diagnosis of acute febrile illness? So friends, as we all know, to make an accurate diagnosis, we need a very good history, which is very important. We need a very good physical examination, which is again very important. And third thing is, after the history and physical examination, we need to make a syndromic diagnosis so that we can make up accurate diagnosis, which is possible. So what do you call a syndrome? A syndrome is basically a group of symptoms which consistently occur together, or it is a condition which is characterized by a set of associated symptoms. So this is what we call a syndrome. So now there are various syndromes. There is a respiratory syndrome, there is meningoencephalitis syndrome, which we call as fever with altered sensorium. Then there is fever with jaundice, with or without elevated transaminase syndrome. Then there is fever with leukopenia or thrombocytopenia syndrome. So these are the various type of syndromes which are there, and we should see that how do we classify the infection into different type of syndromes and then look at the differential diagnosis. So let me take you first example of a respiratory syndrome. So these are the various diseases which come under respiratory syndrome, which is acute sinusitis, acute pharyngitis, acute bronchitis. Then if it goes down lower respiratory tract, then it forms a pneumonia with or without bacteremia and lung abscess. So friends, I don't want to bore you, so that's why I have made a case-based approach and I will present you a few cases along with it. So let me start with my first case. So this is a 56-year-old male who was previously in very good health, suddenly presented with 4-day history of cough, fever and pleuritic type of pain. Examination reveals right-sided crepitations and oxygen saturation is 98%. Chest X-ray confirms an infiltrate, and this is his chest X-ray. So you can clearly see this patient presented with respiratory symptoms and fever. He had right-sided crepitations, and when you did an X-ray, it clearly shows there is a right middle lobe infiltrate which is present. So what is the diagnosis? I think it is very simple. The diagnosis is basically a community-acquired pneumonia. So let me show how did we arrive at this diagnosis. So basically it was respiratory symptoms plus X-ray showing a patch. The diagnosis is acute community acquired pneumonia because he is not got exposed to any hospital environment. He directly came in from the community. So why it is important now to important to see now once we make a syndromic diagnosis is the community acquired pneumonia, we can understand what are the pathogens which causes this pneumonia. So when we talk about pneumonia, we can divide the patient into three categories. One is your outpatient, the second is your inpatient, the ward patient, and third is the ICU patient. Why do we need to classify this? Because the type of organism which causes this particular infection are various. For example, if it's an outpatient pneumonia, then the typical cause of the pneumonia is your Streptococcus pneumoniae, but it can also be some of the atypical organisms like Mycoplasma, Haemophilus, Chlamydophila, so on and so forth. But when we talk about a patient who is slightly more sicker, who needs to be admitted in the wards, then the other infections are also possible. For example, Legionella, aspiration, and so on and so forth. And once we talk about a patient who is still more sicker and who needs to be admitted in ICU, we can see the number one cause of pneumonia now instead of Streptococcus pneumoniae now becomes Staph aureus and gram-negative bacilli. So we can see these are the various types of organisms as per the different type of pneumonia which occurs. The treatment of pneumonia is very simple. If it's an outpatient pneumonia, you can just treat with doxycycline or amoxicillin clavulanate acid, or you can go for azithromycin to give for atypical coverage. So friends, this was just a simple example to show that how we make a correct syndrome, and when we make a correct syndrome, we can have the right diagnosis and the treatment becomes simple. Now let us go through some other syndromes and see how can we make the diagnosis. So let me come out with my second case. The second case is a 45-year-old male who is a laborer who presented with high-grade continuous fever, headache, and myalgia for the last 7 days. No history of vomiting, diarrhea, cough, or burning micturition. On examination, he was febrile, 102 degrees Celsius. Tachycardia was there. He had bilateral creps, mild hepatosplenomegaly. And look at his investigations. He had leukocytosis, platelet counts were low, creatinine was normal, bilirubin was slightly elevated, and look at his SGOT-PT. These were elevated, and his urine routine was normal. And when we do a chest X-ray, this is his X-ray. We can see some bilateral infiltrates are there on both sides of the chest. So friends, now let me ask you, what do you think is the differential diagnosis? So now let us go back to the case and understand what are the symptoms he had. He just had fever. He had some crepitations in the lungs. And look at his investigation. He had thrombocytopenia and he has elevated transaminases. So if such a patient comes to you, what do we think as a differential diagnosis? The differential diagnosis at this point would be one, scrub typhus, which is very commonly seen, especially in the rural areas. Leptospirosis is very common. Malaria is another possibility, and hantavirus. These are the differential diagnoses in this particular case. So now we are basically talking about a patient who presents with fever and jaundice. Now, friends, this is a picture of Sir Ronald Ross. And you can see before he approached fever with jaundice, he used to look like this. And after he approached, he became look like this. So this clearly shows that fever with jaundice is an extensive subject and there is a lot of differential diagnosis in this and how do we approach it. So what we want to know is what is fever with jaundice, how do I know about it, and how to approach fever with jaundice. So friends, fever icterus syndrome. This is what we call it as a fever with fever. A patients of presence with fever and jaundice, as demonstrated by the presence of icterus or biochemical hyperbilirubinemia. And this definition is irrespective of the rise in liver enzymes. So fever and jaundice is the thing. The other differential diagnosis for acute undifferentiated fever would be a fever without any localized source of infection of 14 days or less duration, which includes myalgia, arthralgia, headache, altered sensorium, and jaundice, which are not considered to have any localizing values. So why should I know this? Now, if you look into the causes which causes this acute undifferentiated fever, there are various. It can be malaria, scrub typhus, leptospirosis, typhoid, dengue, and so on and so forth. But when we see the liver involvement in these particular infections, so that we can localize the infection to few particular organisms. So when we have liver involvement in the systemic infection, what are the type of organisms? So it can be various viruses, it can be bacteria, it can be parasites, and it can be various type of fungi. Hepatitis, as we know, is one of the conditions which can affect. So the our patient, we consider hepatitis in him? Yes, we can consider hepatitis in him, but in hepatitis, the liver enzymes would be in the value of thousands, not in the value of hundreds. Malaria, yes, malaria we can definitely consider because the patient has thrombocytopenia, patient has raised liver enzymes, and malaria is endemic as we know. And of course, leptospirosis. Leptospirosis is a typical involvement of kidney and liver enzymes, as we can see, and leptospirosis is quite common in our Asia Pacific region. What about scrub typhus? So this was a study which was done at CMC Vellore about the distribution of acute febrile illness. And what they found was almost 48% of the acute febrile illness were due to scrub typhus. The other most common was malaria, enteric fever, so on and so forth. So definitely scrub typhus is also in our list. And since we are Indians, we have to differentiate the causes which are present in the Western country and the differential in the causes in our India. So how do I approach this particular case? So anytime you have a patient with fever with jaundice with liver enzymes, the first thing is basically stabilize the patient. If the patient is having some symptoms of sepsis, you need to admit that patient, start him on broad spectrum antibiotics, start the patient on supportive treatment as well. Then try to identify the focal of infection. Is there any focus of infection like pneumonia, pyelonephritis, so on and so forth? If there is no focus of infection, assess the clinical syndrome. What is the clinical syndrome? If it's a fever with encephalopathy, then you have to approach it differently. But if you have fever with rash, thrombocytopenia, jaundice, you have to approach it in a different fashion. And then when we talk about syndrome, you have to identify the patient into different category of syndrome. So this is a very good take home slide for all of you. So if you have any patient who comes with undifferentiated fever, what are the different diagnoses? So it's an undifferentiated fever, malaria, scrub typhus, lepto, typhoid, dengue. These are the differential diagnoses. If you have a patient who comes with fever with rash and thrombocytopenia, then this is the differential diagnosis. If you have a patient with fever with ARDS, then scrub typhus, malaria, these are the differential diagnoses. And of course, if you have a patient who comes with fever and encephalopathy, then you have to consider encephalitis, meningitis, so on and so forth. And of course, the last thing is the sepsis, in which patient presents with fever with multi-organ dysfunction, then you have to consider these as a differential diagnosis. So any patient who comes to you with fever and he fits into any one of these syndrome, you have to identify what are the microbial pathogens which are responsible for it. The third step then comes is basically have a good history. So any patient comes to you, always talk to the patient, talk to the attenders if the patient can't give you history, go through his old records, look at his occupation, look at his travel history, whether he has any water, farm or forest exposure, what is the drug history which is available. Think about all these pathogens, whether he has been exposed to rodents or wild animals, whether has been recently there has been flooding in that area, whether he is exposed to all these domestic animals. This is very important. Then the next step is basically examine. Always look for the patient whether he has any signs and symptoms which will fit into any particular diagnosis. For example, look for this thing. So what is this? This is basically an eschar. So you can see eschar is a painless lesion which is present in the skin, and it is typically present in areas, covered areas like groin, gluteal fold, breast fold, and external genitalia. So this eschar you should look for very properly in a patient who presents with acute febrile illness. So what is an eschar? As I told you, it's an ulcer which is rounded by red alveoli and is often covered by dark scab, and it is typically found in these particular areas. And when we find an eschar, the most important diagnosis when we find an eschar is basically a scrub typhus. So these are various presentations of eschar. As you can see, it can be present in the gluteal region, it can be present in the chest, it can be present in the abdomen, and very commonly it is even seen among the breast folds and the gluteal folds as well. So these are the common places where you should look for eschar. And when to suspect eschar in a scrub typhus diagnosis, like in our patient, we had a patient who had leukocytosis, who had thrombocytopenia, who had mild hepatitis, the liver enzymes were elevated. We saw that bilateral infiltrates on chest X-ray and atypical pneumonia, and of course, he can also present with a sepsis-like syndrome. So, any of these clinical parameters, if you see in this particular patient, you should definitely suspect whether this patient is having scrub typhus. The next step is what investigations would you like to send? So in such patients, we would like to send the malaria to rule out malaria, IgM scrub typhus that we need to send, wheel Felix test for leptospirosis. This investigation we need to send and rule it out. Empirical treatment, if you ask me empirical treatment, what is the empirical treatment we should start? The empirical treatment would be to start a doxycycline to cover for scrub typhus. So scrub typhus, as I told you, the most important parameter of scrub typhus serology is the IgM ELISA, which has a very good sensitivity and specificity, which we can send, and it is readily available in most of the tertiary care labs. So in this patient, we sent the MP for QBC, it was negative. IgM ELISA was scrub typhus was done and it was positive, and when we did the leptospirosis, it was negative. So the patient was started on doxycycline 100 milligram BD and improvement was started within the 48 hours. So as I told you, the treatment for the scrub typhus would be mainly doxycycline. We can also give chloramphenicol. The other drugs which work against scrub typhus are the rifampicin and azithromycin, but we avoid giving rifampicin because India being an endemic country for tuberculosis. And although there has been some cases of this Orientia susugameshi, which is the causative organism of scrub typhus, has been shown to be resistant in doxycycline and chloramphenicol in some cases in Thailand, but it is not so much what we are seeing. If the patient, there is several situations. For example, if the patient is not able to take IV or oral, not able to take oral, then we can give IV azithromycin. Pregnant females, we can give azithromycin. And if the patient is having scrub typhus meningitis, we can add chloramphenicol to the doxycycline. So the take-home points in this case is scrub typhus is an emerging infection. Look carefully for an eschar. When to suspect? If a patient is having leukocytosis, thrombocytopenia, cholestatic hepatitis with fever, some features of meningitis or atypical pneumonia or sepsis with multi-organ failure, then you have to suspect scrub typhus. And serological tests are available with good sensitivity and specificity. And start doxycycline as soon as the diagnosis is considered. So what have we learned so far? So far we have learned how a patient presents to us. We take a history, we take an examination, and then we form a syndromic diagnosis. The first case we saw there was a respiratory syndrome. Second case we saw basically it was a fever with jaundice syndrome. So how do we approach a case of fever with jaundice syndrome? What are the differential diagnoses? And we identified how to identify scrub typhus, which is present. Now let me come to my third case. This is a 40-year-old farmer who is from Kalyan without any comorbidities. Now again, he presents with fever, myalgia, headache, 2 episodes of vomiting, no history of diarrhea, cough or burning micturition. So again, we have a patient who presents with fever, myalgia and headache. On examination, again, he has icterus. So again, he is fitting into the category of fever icterus syndrome. So we have to consider what are the differential diagnoses for fever icterus syndrome. On examination, he was febrile, tachycardia was there, and except for mild hepatosplenomegaly, there was no other systemic features on examination. And when we do his live examination, we see the WBC count is normal. So unlike in the first case where we saw there was leukocytosis, in this case the WBC count is normal. However, there is thrombocytopenia, and in this case the creatinine is also elevated and the bilirubin is also elevated, with there is elevations of the SGOT-PT enzymes, and if we do a CPK level, his CPK also is elevated. So definitely this patient is slightly different from our previous patient because this patient's creatinine is elevated, bilirubin is severely elevated, and also there is raised CPK enzymes. So in such a case, what would you consider as a differential diagnosis? The differential diagnosis again would be malaria, scrub typhus, leptospirosis. Now, leptospirosis is very typical, what I showed you in this particular case, where CPK is elevated, liver enzymes is slightly elevated, bilirubin is elevated, and of course, dengue fever can also be one of the differential diagnoses. So, what further investigation would you like to do? So friends, if you ask me to one investigation which we should do, the investigation should be an ELISA for IgM leptospirosis. Because if you're suspecting leptospirosis, this serological test is very diagnostic and very much confirmatory. So these are the various diagnostic investigations for leptospirosis. A culture which can be done, but which is not done everyone. It is done only in a reference lab. PCR is not very widely available at every place. MAT for leptospirosis can be done, and it is one of the very good examination. But the titers peak late, so you cannot do it immediately. You need to do it at a slightly later time. But a simple test like IgM ELISA for leptospirosis gives you a very good and rapid diagnosis, which is easily available. So as I told you, a dark field examination can be done, but it is not seen very done very particularly in most of the labs, and it gives you lots of false positive. The MAT test is can be sometimes unreliable, and the sensitivity of PCR is only 51%. So if you think of the diagnosis of leptospirosis, don't be in a this thing to see whether leptospirosis is there or not. If you think of the diagnosis of leptospirosis, start the patient on penicillin and doxycycline, because if you wait for the accurate diagnosis, it can be too late. So in this particular case, we did malaria, which was negative. We did a hepatitis A IgM, which was also negative. And when we did a leptospira mat, it was positive with titer more than 1:100. And of course, we did a leptospira ELISA IgM, which was also positive. So this was a case of leptospirosis, and then you can see leptospirosis in the first week of illness. The leptospirosis presents with fever, and then it goes into a convalescent stage, and later on it can have complications of leptospirosis. And if you look at the antibodies start appearing after the first week. So if you do an IgM leptospira too early in the illness, it may come as false negative. So you have to send an IgM leptospira during the second week of illness. So these are the various reasons why leptospirosis, because there is contact with flood water, there is contact in the farms, there is contact with the so leptospirosis is spread through the urine of the rodents. So if you get exposed to the urine of the rodents, like during flooding or during farming, there is a high chances that you can develop leptospirosis. So in short, basically, if you're suspecting leptospirosis, send the investigation, but don't delay in the treatment. What is the treatment of leptospirosis? The treatment of leptospirosis can either be penicillin, crystalline penicillin, IV, or IM, which needs to be given. If you cannot give penicillin, then you can give ceftriaxone, especially for moderate to severe cases. But if it's a mild cases of leptospirosis, you can just start with doxycycline, either oral, or you can start with IV doxycycline. So this was a trial which looked into the treatment of leptospirosis, and they found that doxycycline or cefotaxime or ceftriaxone is a satisfactory alternative to penicillin G in the treatment of severe leptospirosis. So what is the take-home message from this case? Always have a high index of suspicion, which is depending on the epidemiological criteria of the patient. MAT is the gold standard test, but needs to be interpreted appropriately. And you need to interpret the IgM ELISA, which needs to be sent during the second week of illness, for which it will come positive. And doxycycline or ceftriaxone is a satisfactory alternative to penicillin for severe leptospirosis. So we saw a second case who presented with fever with jaundice, but unlike the first case, which turned out to be the scrub typhus, the second case was more of leptospirosis, because it was more involvement of the renal involvement was there, bilirubin was elevated, there was thrombocytopenia. So these are some subtle differences in the clinical manifestation of leptospirosis as compared to the scrub typhus. So friends, when we talk about these tropical infections which can present in the similar fashion, so these are the top 5 infections we should always keep in mind in any patient who presents with these particular illness. That is malaria, dengue, leptospirosis, hantavirus, and scrub typhus. So to remember this as a mnemonic, the mnemonic is Leptang-Mushi syndrome, which if you see is basically leptospirosis, hantavirus, and Orientia susugamushi. Orientia susugamushi is the causative organism for scrub typhus. So if you remember this Leptang-Mushi syndrome, you can always know the differential diagnosis of leptospirosis, hantavirus, and Orientia susugamushi. So these are the differential diagnoses we should always keep in mind for any patient who presents with fever and jaundice. Now, let's moving on a slightly different case. The next case is basically a 22-year-old male who presented with from Mumbai, who presented with high-grade fever with chills and sweating since the last 4 days. There was no other localizing signs of infection. He was hemodynamically stable, but if you see this case, he had pallor and he had mild splenomegaly. Now, these are two differential features as compared to other different cases. What would you consider as a differential diagnosis? The number one differential diagnosis in which such a patient which presents with mild splenomegaly, mild pallor and fever would be malaria. That you should always keep in differential diagnosis. The other differential diagnosis can be dengue, enteric fever, influenza, non-specific viral illness as well. So what would you do? Would you confirm malaria first with rapid diagnostic test, confirm malaria with smear, or would you treat empirically? So what would you do in this particular case? So friends, let me show you that if you have a case of malaria, you should always go for testing first and then consider treatment. Because if you look into all the clinical criteria which has been established, all clinical criteria lacks the sensitivity and specificity to diagnose malaria. So just on the basis of clinical features, you cannot diagnose malaria. You need to prove malaria and then start the detection, start the treatment. Because malaria misdiagnosis is usually very common. So always test for malaria, and remember there is no rule for empirical therapy. If you're suspecting malaria, always do smears. What smears you should do? Always do thick smear and thin smear at least 12 hours apart. So if a patient presents with fever, send him for malarial smear, then repeat another malarial smear after 12 hours. If you have two smears or two or three smears which are negative, there is no need to start the anti-malarial treatment, and there is no role of empirical treatment. Okay. So once you have diagnosed that it is a malaria, you need to see what type of malaria is this. So you have to consider two things. One, whether it is a vivax malaria, or second, whether it is a falciparum malaria. Second thing which you consider is a complicated malaria or an uncomplicated malaria. So this was our study which we did at Apollo Hospital, where we found that most 68% diagnosed malaria by clinical method rather than confirming with microscopy or rapid tests. Chloroquine was used correctly for malaria, vivax malaria in 81% of the cases, and chloroquine was used for falciparum malaria in 45% of the cases. So friends, you should remember that this is wrong. For falciparum malaria, chloroquine does not work. You should remember that. Chloroquine works only for vivax malaria, and that also for uncomplicated vivax malaria. So if you have a malaria which is vivax malaria, if it is uncomplicated, treat with chloroquine. If it's a complicated vivax malaria, treat with artemisinin combination therapy. Similarly, if you have a vivax, if you have a falciparum malaria, always go for artemisinin combination therapy. So there are various rapid antigen tests for malaria. As we can see, the Plasmodium falciparum malaria, which is based on the histidine-rich protein. Then there is the LDH-based rapid antigen test, and there is the aldolase, which is present as a rapid antigen test. So rapid antigen test is quite effective if you don't have the facility of malarial smear, but it can miss low-level parasitemia, and it is reasonable if you are practicing a situation where microscopic lab is not present or the lab support is poor. But if you ask me what is the gold standard test for malaria, you should always go for smear. And the smear, what you should go for is by QBC technique, which is the quantitative buffer coat. So if you have a smear slide which is done by quantitative buffer coat, that is always preferred over other tests of malaria. So going back to our case, you can see in this case, patient's HB was slightly on the lower side, bilirubin was elevated, but his transaminases levels were normal. So we suspected this could be malaria. We sent malaria by QBC method, and it was found to be having a P. falciparum malaria. So because the patient did not have any complications of like black water fever or other complicated features of P. falciparum malaria, he was diagnosed as uncomplicated falciparum malaria. But if the patient presents with malaria and with any of these symptoms, like example, impaired consciousness, respiratory distress, pulmonary edema, jaundice, severe anemia, hypoglycemia, acidosis, then this turns into a complicated malaria, which is a complicated severe falciparum malaria. Now, once we know it's an uncomplicated falciparum malaria, what would you treat with? Would you treat with chloroquine, primethamine, sulfadoxime, artemisinin, or mefloquine? Well, the answer is you need to treat with artemether and lumefantrine, because you need to treat with artemisinin combination therapy. So when we look at the smear, you can see this typical banana-shaped gametocytes. This typical banana-shaped gametocytes are your P. falciparum malaria, for which you should treat with artemether and lumefantrine. If it's a severe malaria and it needs to be given IV treatment, then you need to go for IV artesunate. So what is the treatment of uncomplicated falciparum? As I told you, there is a rule of 50 which applies to India. 50% of all malaria is falciparum. 50% of all falciparum is resistant to chloroquine, so we should not give chloroquine. And another 25% of falciparum is resistant to sulfamethoxazole and pyrimethamine, which you should avoid. So most common and combination of treatment in an anti-malarial should be basically your artemether and lumefantrine, which is most widely used. And friends, along with that, you also need to give a gametocidal treatment. So we give a single 0.75 milligram per kg body weight of primaquine, which comes to around 45 milligrams of primaquine that you have to give basically in the second day of malaria. In this cases, even just because you're giving a single dose, even if you're not tested for G6PD, that does not matter. Unlike Vivax malaria, where you need to give it 14 milligrams of primaquine for 14 days, then like this thing in this falciparum malaria, just a single dose of 45 milligram of primaquine on day 2 of illness is sufficient, even if you do not do the G6PD levels. So that was about falciparum malaria. What about uncomplicated Vivax malaria? As I told you, if it's an uncomplicated Vivax malaria, you can treat with chloroquine. But there have been some cases of chloroquine resistant Vivax, which is seen in Southeast Asia and Cambodia. And there in those cases, you need to go for artemisinin combination therapy. So what are the WHO guidelines for severe falciparum malaria? As I told you, if it's a falciparum malaria, complicated or uncomplicated, you need to go for artemisinin combination therapy, either IV artesunate or artemether lumefantrine. If you have a Vivax malaria, see whether it is complicated or uncomplicated. If it's an uncomplicated Vivax malaria, you can give chloroquine. But if it is a complicated Vivax malaria, then again you need to go for artemisinin combination therapy. And of course, as I told you, for the hypnosite treatment of IVAX, you need to give a 14-day course of primaquine. And for this thing, you need to check for G6PD deficiency, because if the patient is having G6PD deficiency, then you need to probably skip the primaquine. So that was about a brief overview about malaria. Let me take you to my next case. So this is an 18-year-old male who presented from Navi Mumbai. Now he had fever for 3 days. He presented to the OPD on the third day of fever with myalgia, arthralgia, and rash. No other localizing symptom. He was hemodynamically stable, but he had petechiae, which was present. As you can see in this picture, there's a lot of petechiae. So once you see petechiae, I think you get the diagnosis immediately what is there. And if you look into the blood picture, that there was slight leukopenia and there was some thrombocytopenia which was present. So what is the differential diagnosis? So no prizes for guessing. The differential diagnosis, the number one differential diagnosis would be dengue fever, but there are other infections also which can present with similar infections like chikungunya, infectious mononucleosis, Coxsackie, rickettsial infections, and malaria. But the number one diagnosis would be dengue fever. But now the question arises, how would you like to confirm dengue fever at this particular stage? Now remember friends, the patient presented to you on day 3 of illness. So if you present on day 3 of illness, if you do dengue IgM and dengue IgG, it will come negative because the antibodies are not yet formed. The test of choice we should do in dengue at this particular stage is basically dengue NS1 antigen. And why do I say that is because you can see as in this picture, up to first 5 days of illness, the dengue NS1 antigen will remain positive, and after day 4 or day 5 of illness only is where your dengue IgM starts becoming positive. So that is why if a patient looks like dengue in the initial part of illness, only do dengue NS1 antigen at that particular point of time. And of course, then we need to classify the dengue infection. So this is the modern classification of dengue infection. It is dengue with or without warning signs. The dengue warning signs. So if you have a patient with dengue with warning signs, the warning signs are like abdominal pain, vomiting, clinical fluid accumulation, mucosal bleed. If any of these warning signs are present, you should be careful because the patient may go into dengue shock syndrome and with severe bleeding. And of course, the third category is a severe dengue where there is already plasma leakage and severe bleeding and liver multiple organs are involved in these particular cases. What is the treatment? When to transfuse platelets? How much to transfuse platelets? Is steroid helpful? And whether there is the use of antibiotics? So friends, the treatment of dengue fever is basically only giving IV fluids and supportive treatment. When should you consider platelet transfusion? If a patient's platelet count is less than 10,000, you should consider platelet transfusion. Or if the patient's platelet count is less than 20,000, but the patient has some bleeding manifestation, then only you should consider giving platelets. Is there any role of steroids? No, there is no role of steroids. But in some patients of dengue fever, we see there is secondary HLH, secondary hemophagocytosis lymphocyte histocytic syndrome. So in those patients who have dengue fever and secondary, they develop this HLH, only in those patients steroid would be useful. But otherwise, routine use of steroids to increase the platelet counts should not be done for dengue cases. The treatment of dengue is pretty simple. Just give symptomatic treatment, give him good hydration, which is very much important. And if you're seeing for warning signs, then shift him to a tertiary care center and manage appropriately. So we saw a case of respiratory syndrome, we saw a case of scrub typhus, we saw leptospirosis, we saw malaria. Now let me come to another type of infection which you very commonly see in your practice. This is basically a 35-year-old male person who comes from Malegaon and who has high-grade fever since the last 4 days. And he presents with severe arthralgia. Now see, he has severe arthralgia. So a dengue patient can also come with fever and arthralgia, but the patient will have typically have a petechiae. Now, this patient has fever, he has arthralgia, and he has rash, and there is no other localizing sign of infection. And when you look at his clinical picture, there is a maculopapular rash which is present, and there is polyarticular involvement of joints with swelling and tenderness. So, this is polyarticular joint involvement with swelling and tenderness. This is the one feature which differentiates it from dengue, and no prizes for guessing. This basically looks to a case of chikungunya. So what are the investigations? Again, the platelet count is normal. ESR is elevated. That is very striking feature which is present. So differential diagnosis at this point of time would be definitely chikungunya. It could be other rickettsial infection. Dengue you should consider, but platelet count being normal, no petechiae, dengue is less likely. Coxsackie and other enteroviral infections can also present similarly. There can be some rheumatological conditions which can present with this picture. And of course, parvovirus B19 is also very, very commonly seen. Now the question comes, how do you confirm chikungunya? The chikungunya confirmation should be done by IgM antibody test. So in the absence of widespread availability of diagnostic test, the diagnosis is predominantly clinical. So if you have a patient who presents with fever, joint pains, who has this typical maculopapular rash, the diagnosis is pretty simple. Although if you prove the diagnosis, you can always do an IgM antibody ELISA, which gives the reliable and safe mean for diagnosis. But again, the antibody IgM ELISA should be done basically in the second week of illness, otherwise it will be a false negative test. What is the treatment for acute chikungunya arthritis? Chloroquine, steroids, NSAIDs or DMARDs. The treatment is basically, it's chikungunya is not a life-threatening infection, you should remember. Symptomatic treatment with anti-inflammatory drugs alone should be enough. Convalescence can be prolonged and persistent joint pain may require analgesic and long-term anti-inflammatory therapy. So remember friends, if you have a patient who is having an acute chikungunya, steroids are not indicated. If a patient has a chikungunya which is in the recovery phase and lasts for a long time with the joint pain, then probably you can give the steroids. But for acute chikungunya arthritis, steroids are not indicated. Only NSAIDs are sufficient for this kind of treatment. So what is the take-home message? In these particular cases that we learned, always test for malaria first before treatment. Don't go for empirical malaria treatment because majority of the times it is not malaria. If you have a good lab and experienced technician available, MP by QBC technique is the best thing which is preferred over light microscopy. Dengue IgM is negative in the first 5 days of fever. Always do dengue NS1 antigen if the patient presents early in the fever. Transfuse platelets only if there is bleeding or count is less than 10,000 and no benefit with steroids. Detection of IgM antibody for chikungunya is very specific for chikungunya, but it has to be done in the second week of illness. And treatment of chikungunya is mainly supportive. So these are the clinical points that we learned from our last few cases. So this is one very good take-home slide for all of you to see what is the, when you talk about fever with jaundice, what are the different type of manifestation. So if you have a hepatocellular type of jaundice, we will see the elevation of raised liver enzymes which will be present. Bilirubin will be raised slightly. And if you have an obstructive jaundice, for example, a surgical jaundice, in those cases, you will see the alkaline phosphatase will be elevated severely and the bilirubin, total bilirubin will be elevated. So if you have a pre-hepatic jaundice, you will see only bilirubin being elevated. Pre-hepatic type of jaundice is always malaria. Hepatocellular type of jaundice will be hepatitis, dengue, and typhoid. But if you have a more of an obstructive type of jaundice, the diagnosis will always be leptospirosis, scrub typhus, and cholangitis. So this is another good take-home slide for all of you that to differentiate between these four common infections: dengue, typhoid, lepto, and malaria. So look in the picture. If you have suspecting dengue, the total count will be low, the platelet count would be low. When you talk about typhoid, again the total count would be low, and there will always be eosinopenia, which would be present in the typhoid. When you talk about lepto or scrub typhus, look at the WBC count. It will be positive. There will be leukocytosis, unlike other pictures, and there will be more elevated of alkaline phosphatase and total bilirubin. And when you talk about malaria, it will be drop in hemoglobin, but with normal count, WBC count, but a drop in platelet count. So this good take-home slide gives you some indication when you present a picture of this acute febrile illness, what are the differential diagnoses and how we differentiate between the two. So this is a good slide for you. And now if we have time, we can go for another few cases. So I'll just take you to few more cases. So this is a 20-year-old male who was staying in his hostel and who presented with intermittent fever without chill for the last 8 days. And he presented with rash all over the body since the last 1 day. So he was treated with antibiotics by a local physician. He had some sore throat but no cough. On examination, he had insignificant cervical lymph nodes and he had a rash. And this was his rash which was present. Now, when you look at this particular rash, there was some lymph nodes present, there was fever, there was sore throat. And what are the differential diagnoses would you consider? Let us look at his counts. He had leukocytosis which was present, his malaria was negative, liver function showed there was slight elevation of SGOT-PT enzymes, but bilirubin was completely normal, RFTs were within normal limits. So what is the differential diagnosis? You would consider these differential diagnoses at that point of time. But if you ask me a patient presenting with lymph nodes, sore throats, rash, what is the differential diagnosis? The differential diagnosis would be infectious mononucleosis. So if you do all these tests like dengue, leptospirosis, measles, and blood cultures, these all tests would come out to be negative. So what is the differential diagnosis? Young individual with fever, sore throat, lymphadenopathy, elevated liver enzymes, and rash after giving antibiotics. This is very typically seen in infectious mononucleosis, which is caused by Epstein-Barr virus. So this infectious mononucleosis is very commonly seen in adults. It's caused by Epstein-Barr virus. It's a very classical presentation of lymph nodes, sore throat, and rash. And typically, this rash occurs after the patient has been prescribed some antibiotics like amoxicillin or ampicillin. The diagnostic test is basically do a IgM VCA, that is vascular cascade assay of the Epstein-Barr virus, and usually it's a self-limiting disease. So, do we still have time? Can I take a couple of more cases, or should I stop it here? Hello.
I think we'll stop here. We have a few questions for you.
Yeah, okay. So I won't go further. There are a few more cases which I would like to say, but due to want of time, I will not give. I'll just conclude it by saying, friends, antibiotic consumption is increasing in the developing countries. There are, as you can see, in all over the world, the consumption is increasing, antibiotic consumption. And if you look at it over our India data, you can see as we move from South India to North India, the resistance in the community is also increasing. So because of incessant use of antibiotics, we are seeing a lot of antimicrobial resistance, which is seen, and this antimicrobial resistance is spreading all over the world. So just a few points on the right antibiotic selection. Always remember the 4R, give the right drug at the right time, at the right dose, and for the right duration. And always determine your local sensitivity. So whenever you are there in your local area, look at your local antibiogram, discuss with your microbiologist what are the common infections which you're seeing, and give your local antibiotics as per your local sensitivity areas. And always remember, when you see when you select an empirical antibiotic selection, there is not a magic bullet. Every ID has a problem. Like we said, always look for the syndromic approach. Once you make a syndrome, then you look at the microbiological etiology and then decide it, and always know the local sensitivities. Call the ID specialist if you have any difficulties. We are always there to help you. And finally, I'd like to conclude with this slide. So this is basically a heartbreaking image by an Iraqi artist which was taken in an orphanage. So this little girl had never seen her mother. So she drew the picture of her mother on the ground and she fell asleep with her. So what does this picture tell you? Is appreciate what you have, since you don't know what you have got until it's taken away from you. And that is it is when it is too late. So same is the condition with our antibiotics. If we don't use the antibiotics rationally, for our future generation, there will not be any antibiotics left and it will be too late. With that, I'd like to conclude the session. I'll be happy to take any questions and answers. Thank you.
Thank you very much, Dr. Lakshman Jethani sir, for an excellent talk on approach towards fever. So let us take a few questions on this topic. I'm asking on behalf of my audience.
Yes.
First question, what are the commonest causes of fever in patients coming to outpatients of family doctors? What are the commonest causes?
The most common cause of fever which comes to family doctor would be a viral infection. And now in the current endemic of COVID which is going on, we should always consider COVID. But the most common cause of fever in a patient who comes with to a family physician would be basically a viral infection. But you should always look out for common infections like dengue, malaria, leptospirosis, scrub typhus, and the hantavirus. These are the other causes, but these are not very common. The most common cause, if you ask me, would be a viral infection. Second would be malaria and dengue. And in the current endemic of COVID, you should always rule out COVID infection in any patient who is presenting with fever.
Yeah. Thank you, sir. My next question. Whenever a patient of fever attends OPD, do we always have to proceed with some investigations? If yes, which are those?
Yeah, so I would suggest that look at the duration of fever. If the patient presents with fever in the first 2 to 3 days, don't go for any investigation. Just give symptomatic treatment and observe. But if the fever is not decreasing up to 48 to 72 hours after infection, then you should go for investigation, and the investigation should be going as per the clinical picture. For example, if you examine a patient, the patient has sore throat, patient has lymph nodes, patient has rash, you know that it is a diagnosis of infectious mononucleosis, then you don't need to do any further testing. You can just give supportive treatment. Similarly, if you have a patient on examination, you find that the patient is having severe joint pains, patient is having petechiae, you know that patient is going to have dengue, then you can do a dengue NS1 antigen in the first 3 days. But in general, if a patient comes to you with fever, look at the clinical picture, like have a good physical examination, have a good history, and you don't need any investigation in at least in the first 2 to 3 days. Just give symptomatic treatment and observe. But if the patient is not improving in the first 48 to 72 hours, then you should go for investigation in a stepwise manner.
Thank you. My next question: how to differentiate clinically between a bacterial cause of fever or viral cause of fever?
Yes. So typically viral cause of fever will be multifocal. So a patient who has a viral infection, he will have respiratory symptoms like running nose, sore throat, cough. He may have gastrointestinal symptoms like loose motions. He may have rash. He may have joint pains, severe myalgia. So viral infection will mostly have a diffuse picture. Whereas if you are talking about a bacterial infection, the bacterial infection will be more specific, it will be more localized, and the patient would be more toxic. That would be clinical. So clinically, bacterial patients have more localized infection, more toxic look. Viral infection would be more less severe, but it will be multifocal in origin. Then next step is basically you can do investigations. Bacterial infections invariably will have leukocytosis. Viral infections will have leukopenia, and except for dengue, typhoid fever, where these are the two bacterial infections which will present with low counts. Otherwise, usually the viral infections will have lower counts. Then of course you can always check for other markers like CRP or basically procalcitonin. So CRP and procalcitonin will be more high basically in patients which we have with bacterial infection. Whereas procalcitonin and CRP would be normal or slightly on the lower side in the cases of viral infection. So these are some of the differential diagnoses which you can distinguish between bacterial and viral infection.
Yeah. Next question. When will you think that the fever could be non-infectious one?
Yes. So non-infectious fever you should only label once we have done a thorough investigation of all the infectious causes. So as I told you, when you approach a case of fever, do a good history, clinical examination, do the basic test. After doing basic test, if you still can't find the cause, go in a step ladder wise fashion. If you after extensive investigations and fever is still persisting for more than 7 days, and if there is some other features, for example, a patient with SLE presenting will have a rash over the face, would have severe joint pains, will have mucosal ulcers. In these patients, then you can send for ANA and you can see whether this patient is having a non-infectious cause of fever like SLE. So non-infectious cause of fever should only be labeled after a thorough investigation of all the infectious causes has been ruled out.
Okay. Last question, almost similar. In the real world scenario, when will you label a patient of fever as fever of unknown origin, and after how many days and after how much investigations?
Yeah. So if you look at the definition of fever of unknown origin by Petersdorf and Beeson, who had made the first definition of pyrexia of unknown origin, They said a patient who is having fever after 3 weeks of extensive investigation can be labeled of pyrexia of unknown origin. But now the present definition of pyrexia of unknown origin is different. Pyrexia of unknown origin in the current definition would be a patient who is having fever and after investigation thoroughly for up to 1 week. If 1 week you have evaluated the patient, you have done a thorough investigation, all the investigations have been unsuccessful, then would you label the patient as pyrexia of unknown origin. So I would suggest any patient who comes to you with fever, you do a good history clinical examination, try to treat the patient symptomatically. If there is no improvement, go and do the investigation as per the clinical syndrome in a stepwise fashion. Still there is no improvement, then you go for higher investigations, for example like doing a 2D echo, doing a PET scan. Still the in which there is no cause of fever which is found out, then you can go for do a bone marrow aspiration. Still the fever infection is not found out, then probably you can consider it is a pyrexia of unknown origin. So I would suggest at least 1 week of extensive evaluation and no cause is found out, then we can label the patient as pyrexia of unknown origin.
Thank you, sir. That's all from me. Over to Dr. Abhijit.
Thanks, Dr. Jesani and Dr. Anand. Moving to our next topic, approach to fever in children. Just now, we listened to very informative lecture on fever in adults. However, fever in children needs special understanding, and it is one of the most common presenting symptoms of pediatric illnesses. To learn about it, may I request Dr. Mahesh Mohite to deliver his speech. Dr. Mohite is honorary pediatric intensivist at Bijay Wadia Children's Hospital, Mumbai, and director and owner of Sai Child Care Clinic, a tertiary care exclusive pediatric 70-bedded hospital at New Panvel. He is MD-DCH from Grand Medical College, Mumbai, and now in clinical pediatric practice for last 31 years. He has special interest in pediatric and neonatal intensive care. Apart from vast clinical experience, Dr. Mohite has a lot of contributions in academic and social fields too. He has been teacher and examiner for pediatric postgraduate and fellowship courses. He is council member of IAP Intensive Care Chapter. He has been faculty for many state and national conferences for last 20 years. In 2018, he has been faculty for World Federation Pediatric Critical Care. He has chaired many organizations like Raigad IAP, CIAP, and Intensive Care Chapter. Dr. Mohite is founder trustee of Bharatiya Manav Vikas Trust, which runs a school for mentally handicapped children for last 20 years in Panvel. He is also member of Rotary International and NGO. Dr. Mohite, please.
So I think Dr. Jasani has given a brief overview from the adult point of view, but there are subtle differences when it comes to fever in pediatric. In fact, we run regular postgraduate teaching programs in Mumbai along with my mentor, my godfather, you may say, Dr. Y.K. Ambedkar, many of you may be knowing it. And what we do in that is basically we just analyze any case, not only fever, any case, just on the basis of history and clinical examination. And that we have been doing for last sir has been doing for last more than 25 years. I'm in that group for last more than 10 years. And what we realize, almost 80 to 90% times, you can crack a diagnosis just based on a proper detailed history and clinical examination. And what I'm going to elaborate in my talk about fever is a clinical approach more than the lab-based approach. So just now, my adult counterpart gave you a lot. I could not join the initial part, but I could hear the Q&A session. So I may be repeating few of the things which he said, and perhaps few things may be something different from the pediatric perspective. So scope of my talk is understand the fever mechanism. That's what we do in any kind of a case, any kind of clinical case or pediatric case that we see here. We always try to understand why the thing is happening first, and then accordingly we can find out it's rather understanding the pathophysiology of a disease followed by a particular kind of based on that a clinical presentation, and subsequently the management also connected to that. So we'll try to understand why the fever happens, then understand the patterns of fever, pattern recognition from which whether you can come to some conclusive diagnosis, and finally maybe few applications clinically, we may take few case scenarios. So why one gets fever? It can be either because of high ambient temperature, like we classically see in summer season in hot like Nagpur, Vidarbha, heat stroke, the outside temperature goes high. And this we see commonly in pediatric patients, especially in the neonate in the early summer months. Second, of course, the internal cause. The external cause is ambient temperature, and internal causes is resetting the hypothalamic thermostat. There is a thermostat in the hypothalamus. Apart from his appetite, sleep, and kind of a function, temperature control is major function of hypothalamus, and that is reset due to certain inflammatory cytokines. And these cytokines are released if it is infective inflammation or non-infective inflammation. So this why I'm telling you, because there is some reason when it comes to therapeutic application. And then direct neurological injuries. So there could be a cytokine mediated resetting of the hypothalamus, or it could be a direct neurological injury which can reset the hypothalamus, giving rise to fever. And last, occasionally drug fevers and toxins. Now, how does the common cause is a inflammatory fever, the resetting of hypothalamus? How does it really happen? Any inflammatory insult, whether infective or non-infective, that will lead to cytokine release. And I'll not go into details of the IL-6, IL-1s, and TNF, alpha, and interferon. That will give us a release of cyclooxygenase 2, we commonly call as COX-2. That will give rise to hypothalamic endothelial release of prostaglandins. That will cause higher resetting of hypothalamic thermostat. That will lead to vasoconstriction and increased heat production through maybe muscle contraction. And this is what will give rise to fever. Now you understand this whole mechanics. Anywhere inflammation in the body, release of cytokines, that will cause resetting of the hypothalamic cell, and will give rise to fever. And how the fever is caused? That is caused by increasing the heat generation by muscle contraction, which we commonly, if it is very rapid onset, severe muscle contraction, that give rise to chills, that give rise to rather rigors. At the same time, whatever heat is being generated by this contraction should be retained in the body to create the fever. For retaining this heat, there will be autonomic stimulation to give rise to vasoconstriction, and this will cause surface cold, which patient classically describes as chills. So mind you, fever with chills and rigor doesn't mean malaria always, doesn't mean some high infection always. It only tells that the hypothalamic resetting has happened very acutely, and body need to urgently create that heat. And these two, the rigors by muscle contraction and chills by vasoconstriction, are just two mechanisms to generate and retain the heat in the body so as to achieve the fever. Now, why this important? Because at these two levels, COX inhibitors, the common paracetamol NSAID that we use, they work at either production of this or release of this cyclooxygenase or for the prostaglandin. At these two levels, they work. That also tells you only the inflammatory, infective, non-infective fevers, the COX inhibitors will work. If it is ambient temperature related, so heat stroke, your paracetamol NSAID won't work. Direct hypothalamic stimulation due to maybe encephalitis, the central neurological fever, your paracetamol and inflammatory, anti-inflammatory drugs will not work. So this is the basics of fever. Now, common terminology, as I already mentioned, rigors and chills doesn't mean malaria. It only tells you that hypothalamus has given the order, an acute order to reset the temperature at high levels, and its body's effort to generate that heat by severe muscle contraction, which gives rise to rigors, and body's effort to retain that heat in the body by causing vasoconstriction, which gives rise to chills. Now, range of fever. Is there any again analogy? Now, these are all physiological understanding. There is no double-blind controlled study whether it works like this, but yes, they do explain and they do make us understand and make us wise in understanding the fever. So range of fever is usually proportionate to amount of cytokine release, which is proportionate to severity of inflammation and tissue damage. So whenever there is tissue damage and inflammation, that will release the cytokines. Now, more severe the damage and inflammation, higher the fever because higher level of cytokine release. So more severe inflammation, multiple loci of inflammation, which will collectively generate more interleukins and cytokines, and generalized inflammation. This is exactly what happens in early phase of viral fever, early localized bacterial infections, or even your cytokine mediated, immune mediated disorders, the connective tissue disorders, where there's severe inflammation and very high grade fever. Malaria, sudden spike of fever because of breakage of RBCs, load of RBCs are broken, and very high spike of fever. We say this a low grade inflammation, some kind of a immunological fever which is localized to a small part of the body, may not give rise to very high grade fever. Tuberculosis, a low grade inflammation, subacute inflammation may have very low grade fever in the evening. So that explains higher the inflammatory marker load, higher the tissue damage, higher the fever. At the same time, it's a body response to its inflammatory markers which will determine the fever. So high inflammatory markers, but the body is not responding to that. So proportionate to body's ability to generate inflammatory response, high load of bacterial infection, but there is reduced inflammatory response from the body. However this happens, so if the fever in a healthy child, which is having nice immunological system developed to a smaller infection also or milder infection also, he may mount a very high grade fever. We say this in a neonate where the immunological system is not well developed, we may not have fever at all in a severe infection and sepsis. In an immunodeficient child, we may not have fever at all. Low fever in the malnourished child, who is again kind of an acquired immunodeficiency. So understand fever. Fever is because of inflammatory marker release. And I'm talking about not about a central fever and not about a ambient temperature fever. I'm talking about the inflammatory fevers. The grade of fever depends upon the amount of inflammation, the amount of tissue destruction, and also upon body's ability to respond to these inflammatory markers. And both will have a total kind of a combination effect on how high the fever can be in a given patient in response to given infection or inflammation. Now, normal body temperature. The first step in evaluation of fever is whether the fever is documented. This is very important in pediatrics. Mother comes, sir, डोकं गरम लागते आणि कायम गरम गरम राहतं. मग ताप कधी मोजलाय का? हो सर मोजलाय. 97 and 98 असतो. Apprehensive mother, head always remains warm for various reasons. I'm going to take one case on that. So document the fever. Ensure that it is documented, especially when it is a low grade fever. Tell them to document fever. Normal body temperature, normal range is 97 to 99 degrees Fahrenheit. Fever is more than 100.4 degrees Fahrenheit for all practical purposes. Don't give paracetamol if the fever is less than 100, definitely. Where to record it? Oral is the best, but it is risky in children. The child may bite the thermometer. So tympanic membrane or forehead thermometers are available, which are accurate. Armpit is safe, but may not be accurate. But perhaps that's the best recommendation for a common practice. And all the practitioners, I will suggest to use an armpit for all your pediatric patients. Which thermometer? Now WHO has clearly recommended that mercury thermometer should not be used. It's a digital thermometer which is to be used for day-to-day use. Various patterns of fever. So when I'm going to discuss, I will be taking this one by one. The viral fevers have their own pattern. Localized bacterial infection, non-localized bacterial infections, complications of the bacterial infections, erratic fevers like malaria, connective tissue disorders like or immunological fevers, leukemia and malignancy, and rare recurrent infections, which could be abnormal immunity or abnormal anatomical structure which gets infected recurrently. This I may not be taking a separate course. So just to enumerate, when there is abnormal immunity, you have multi-system, multifocal, deep-seated, significant bacterial infections. Usually, though at times, in case of T-cell immunity, you may have recurrent severe viral infection, which are actually opportunistic factors, or they could be fungal infection, which are opportunistic infection. Abnormal anatomy. You may be seeing occasional child coming with recurrent severe pneumonia, and you may find to have maybe a bronchogenic cyst causing recurrent infections in that. And so you may have a theofistula, H-type theofistula coming with recurrent pneumonia, and which may be coming every periodically once in 2 months, pneumonia kind of a C lesion. So when you get this kind of a recurrent infections, deep-seated bacterial infections in an otherwise normal healthy child, especially in first 2 to 3 years of life, think of underlying abnormal anatomy. Our age-old teaching, is it still right? So we have been teaching how does the viral fever look, and this is how usually it looks. It's a multi-system. Dr. Jasani has stressed adequately on that. It's a multi-system or multi-loculated prodrome, and this is non-localized. So you have cold, cough, fever. Now, as our teacher says, cold is an upper respiratory infection. Cough is usually a lower respiratory infection. Both coming together is actually a multi-system infection. You happen to do a chest X-ray, which is showing multi-loculated picture. Very likely it's a viral. So that's what I mean. So multi-system doesn't essentially mean respiratory, neurological, cardiac, and multi-system. It could be in the same system. You got multi-loculated, which again is usually viral. High spike from start usually, and it's a remittent. because it's a multi-generalized kind of a viral infection, high load of cytokines, and it's a high spike to begin with, and it's a remittent. Responds quickly to antipyretics. That's very important. That's extremely important to differentiate between the severe bacterial infection from virus. Response to paracetamol is very good. During the interfever also, child is not so toxic. For that matter, a child may be playing even sometimes during fever. That's viral. In children, usually some family contact history of a viral fever is very there and subsides by day 4 or 5 with a clinically recovery of symptom. And generally when the fever starts subsiding on day 4 5, child has already started playing on day 4 itself or day 3 itself. That's what is a typical virus. How does a bacterial fever look? When it is a localized bacterial, by that I mean to see, say, acute tonsillitis or a pneumonia patch or an otitis media or a UTI, usually there is high grade fever from the beginning. It's a localized severe inflammation with a destruction of the tissue. So that is high load of cytokine release, high grade fever usually. And I'm talking about these classical cases in an immunocompetent child. I'm not talking about a malnourished child. I'm not talking about immunodeficient child. The rules are different there, which I already mentioned in the initial slides. So the localized will have high grade fever from beginning, localized or single system usually. So you have a classical patch in one kind of a segment of a pneumonia. It could be just acute tonsillitis, that too usually on one side tonsil. So bilateral tonsillar infection, less likely to be bacterial. I mean, in fact, as Dr. Jasani mentioned, it could be just a EB virus which is behaving. So generally it's a one side more prominent than the other side. Clinical localization within first 2-3 days. So child may come with fever high grade without any symptom on day 3, day 4 or day 2, day 3 starts coughing and then become, this is what I mean to say, localization to respiratory infection. Some child may come with fever, second day headache, third day altered sensorium seizure. It's localization to neurological symptom, neurological system. This is why I meant the clinical localization would happen in case of bacterial infection within first 2 to 3 days and may get complicated by end of first week if not treated appropriately. So pneumonia may get into an empyema by usually 5th or 7th day. And what I mean to say by non-localized, something like enteric or maybe a tuberculosis, where initially bacteremia followed by some localization later. So till the time bacteremia, there is minimal destruction of tissue, minimal cytokine release. So low fever to start with, which progressively increasing spikes, which we typically described as step ladder. Interfever, child is still sick because that low grade inflammation persists and systemic constitutional symptoms may continue. So decrease appetite, lethargy, मुलगा खेळत नाही, खात नाही, बसून राहतोय, नेहमीसारखा ऍक्टिव्ह दिसत नाही. This is what the mother typically will complain, and with the intermittent spikes of fever. So when the interfever period is not really comfortable, think of bacterial infection, which may localize in due course of time, or which may never localize, as in case of enterics, which fever continues as a PO. Malarial fever, we classically describe the erratic pattern, though we have those tertian, quartan patterns, but it's actually an erratic pattern. And usually it's because of the sudden loads of RBC broken because of the parasitic load coming up. So spikes from day 1, the first spike itself will be very high because it is again because of destruction of RBC and release of cytokines. Intermittent initially, but later on it may become continuous. So Vivax typically may continue to be alternate day for maybe at times weeks. But a falciparum can come with a continuous fever right at the beginning. That's because of multiple generation. We call it as multiple broods, which keep breaking again and again regularly. And you may have a continuous high grade fever, may get complicated, not treated, usually within first 5-10 days. It may become continuous and may complicate by first week. Connective tissue disorder, just now Dr. Jasani mentioned about connective tissue SLE and all. We in pediatric also do see connective tissue disorder, though the load is not very high. In a PO category, it may make about 7 to 8 days. And as he said, PO is something beyond 1 week with appropriate investigation done by that. In that, usually connective tissue make about around about 10% of the cases. They start with high spikes in the beginning. Why high spikes? Again, the same analogy. This is a systemic inflammatory disorder, very high release of cytokines. The fever spikes are very high right from the beginning, but in between, as the cytokine being immunologically mediated, it's acute onset and acute offset of the inflammation. So suddenly inflammation goes down in between for few hours, sometimes a day. Child may be absolutely all right, just to come back with another spike. So typically describes as quotidian fever, maybe 2 spikes a day, very high spikes, but in between the fever is absolutely, child is reasonably comfortable. And this spike, this kind of pattern may continue to be there Beyond at times, even 1 week, 2 week, without any localization, unless you look for the subtle signs of a connective tissue disorder. Leukemia and malignancy is something one would never like to miss. If you miss it, then the next moment could be a catastrophe. It's a commonest malignancy in children is leukemia. Almost 80 to 90% of our malignancy are not organ malignancy, they are other blood malignancy. So the subtle features we need to pick up. They may start with a PO, which is non-specific fever pattern. The progressive sickness and constitutional symptoms are extremely high in this child. The lethargy, the apathy, the decreased appetite, fatigue, these will be there. And symptoms of cell line depression, so fever due to infections will be there, hemorrhagic rashes will be there, fatigue due to anemia will be there, and then subsequently you'll get a signs of cell line depression. Labs here definitely help you, but on the background, one should be very vigilantly and carefully look at the lab report. At times you may have pan, all the cell line normal, and still you may have leukemia. So lag is not sacrosanct, but yes, most of the times, I would say 90% times, you will get a reasonably good clue on plain simple CBC about the diagnosis of leukemia if you look at it carefully. On the 5th day of fever, if the child comes to you on 5th day of fever, I can tell you many times with a reasonable certainty, I would say to 80 to 90% times, you can reasonably guide yourself to what kind of fever you are dealing with. So in a case of viral fever will start subsiding and child has started become active, normal, comfortable on day 5 of fever. What will happen to biphasic viral like dengue? The fever has subsided, but child has started becoming sick because started leaking now. He may be getting into the shocky stage, especially if it is a secondary dengue. Then he may have a second spike, which is low grade fever, but here the shock symptoms and signs will predominate. Localized bacterial infection. Now you have a pneumonia. On a 5th day, he's progressively sick, unlike viral. He started becoming more and more sick and may land up with complication at that point. He may suddenly become breathless, may develop an empyema. A non-localized bacterial infection, which fever continues with the same intensity and may progress though without any complications. So an enteric on a day 4, day 5, unlike virus, his fever starts spiking more and more. And this is what is non-localized bacterial infection. A malaria will almost follow, Vivax will almost follow the same pattern till the end of 7th days with maybe once a day or once alternate day fever pattern with the intrafebrile almost normal pattern. Vis-a-vis a falciparum may fool you at times with a continuous high grade fever right from the beginning. So again, what I'm telling you is this will take you to almost 80 to 90% of diagnosis. 10%, 20% is a wisdom which you need to develop, a sixth sense which you need to develop over your experience. I'm sure most of the listeners are quite senior to me as well. So this is not advice. This is what I'm stating is my experience over last 25, 30 years of practice. Connective tissue, typically, we do see a SOJI, we do see a rheumatoids, we do see a Kawasaki's, we do see HLH of late. And those are the ones, if you look at a fever pattern, right from the day 1 of the disease, there is high grade spike, 1 to 2 spikes, and that pattern may continue long unless and until there is some complication. And you may be looking for some subtle rashes, lymph nodes on the course of the disease. Let's go through case scenarios, which will make us more averse to what I'm saying. So this is a 2-year-old boy brought with high grade fever for 2 days, which is remittent, responds to paracetamol, interfever, he's playful. There's mild cough with cold since 1 day, vomiting on day 1. Elder brother has fever 4 days ago. Now whole set, this is a multi-system, this is cold cough, so 2 system, there is vomiting, so some GI affection as well. There's a family contact of some fever. This is typical viral, and you really don't require any brains to diagnose this. So febrile, this child is febrile, is having rhinorrhea, conjunctival congestion, some dehydration due to vomiting. So this is typical viral. Tecom is multi-system or multi-loculated, short duration, high fever from the beginning, usually is a virus. You may wait for another 48 hours. Don't jump onto any investigations, or definitely not for any antibiotics. 3-year boy brought with fever since 4 days. Fever decreased today on the 4th day. Interfever, the child is active. Appetite is better today. Activity improved since today. Mild cold cough persists. Rash appearing on the body since yesterday. So on the 4th day, he has got cold cough, fever right from beginning, and 4th day appears with a rash, but child is looking comfortable and he started playing and eating also. His active child, Fever is just about abnormal, alert, responding well to mother, generalized macular rash, and rest is normal. And this is typical rash. This is typical exanthema sabitum. Certain viruses will give rise to this rash, not all the viruses, but this is very common. And this is definitely not measles. Here the child's fever has started subsiding and rash appeared. In the measles, once the rash starts appearing, the fever spikes and will continue for 3 more days, very high grade fever with a severe extremes increase in the cough. So commonly, general practitioners label this as measles, but mind you, look at the pattern and progress of the fever. In measles, you have cold, cough, fever spiking on day 3, day 4. You may happen to see a coplic spot in the mouth. That's the time the rash, external rash starts. Rash will continue to appear from top to bottom in next 3 to 4 days. And those 3 to 4 days, fever will be very, very high spiking. Unlike this case, where the fever started subsiding and the rash appeared. This is typical post-viral rash, exanthema sabitum. 7-year-old girl, fever since 5 days, initial 2 days high grade, then subsided by day 4, but are not active yet and not taking feed. Unlike the typical virus, you expected the fever to come down and the child to become active. Here, this child is not being active. Rather, he don't want to eat. Rash on the trunk and limbs from day 2 to 2 of fever still persisting. Irritability, body ache, temporarily responds to paracetamol. So that's kind of a pattern, looking like a viral pattern. But why the child is not recovering on day 4 when the fever starts stabilizing? On examination, the child is irritable. She wants to sleep. Macular rash, unusual, dark brown. Liver is 3 centimeters, cold extremities, feeble pulse and heart rate in a case of 7-year-old girl, 140, certain tachycardia, all features of shock coming up. This is a typical pattern, and you can see those typical islands in the Red Sea pattern. This is a typical dengue rash. And mind you, this pattern is extremely important. You normally in a viral infection expect the child to be happy, playful, comfortable, eating well on day 4 with the subsidence of fever. In a dengue, unlike that, this child will start becoming sick. So mother may call doctor, आता ताप उतरला है पण अजून बाळ झोपून राहते, खात नाही हो. Be careful. Call him immediately to examine and get hospitalized. You may be missing this dengue, and if you miss this for 12 hours, you may lose the child. 5-year-old male child, fever for 2 days, high grade remittent with chills and rigors from the beginning. So right from beginning, he's having very high grade fever. Difficulty in swallowing from day 1. So you already got a localization, difficulty in swallowing, occasional vomiting and nausea. So some systemic symptoms, no other complaints. So no generalization. What is the impression? High grade remittent fever from beginning with localization, febrile toxic looks, submandibular lymph nodes, large tender on the right side, right tonsil large, congested with white patch, typical acute tonsillitis. Now, even before opening the mouth, I know this is a localized bacterial infection and very likely acute tonsillitis from the first 2 lines. High grade fever right from the beginning with throat swell and pain. This is localizing. That's what my initial understanding the pattern of the fever has taken me to, and this confirms. And again, I said, when you get kind of a unilateral, it's usually bacterial. Happen to get similar picture bilaterally, be careful. It could be EB virus, it could be diphtheria, it could be any other viral. So generally, bacterial is a localized unilateral one. Smaller, similar obvious localized infection present in the first few days of life. First few days of fever, you may have UTI, especially upper UTI coming like this. Otitis media, pleurus, typically a pleuropneumonia will come with high grade fever. Initial 1 or 2 days fever, 3rd day starts coughing, which is again a localization. A deep-seated abscess or a cellulitis. When you get this kind of high fever, don't forget to look at the back, commonly missed part in a pediatric examination. You may find some paraspinal abscess, you may find some paraspinal cellulitis, that area. So certain black spots or dark spots in pediatric patient. This poor child cannot tell you where is it paining. He keeps crying. So look at the scalp, look at the neck, look at the back, look at the perineal areas, look at the genitals. These are the areas which are hidden, and you miss out on some subtle infections in those patients. Sorry. Just a minute, just mute it. Sorry for the interruption. Yeah. So look at all those areas to not to miss any sudden subtle infection. 6-year boy, fever 6 days, gradually increasing, irritable with 2 times vomiting since today on a fourth day, headache increasing with fever but present interfever. Now this is very common, sir. ताप येतो आणि डोकं दुखतं. मग ताप उतरल्यानंतर पण डोकं दुखतं का? हो सर, तरी सुद्धा डोकं दुखतं. Classically, with fever one can get headache, routine fever, viral fever, but once you give paracetamol, fever subside, headache subside. If this headache continues to be there in between the fever, with child toxic, with or without vomiting, think of intracranial infection. One single 2-liner good history can take you to the diagnosis. This child turned out to be a pyogenic meningitis. So persistent headache in fever, especially with no past signs suggestive of headache. So this is not a child who used to get recurrent headache in the past. Mother is having headache, father is having headache, migraine or whatever. So those things to be ruled out. This child persists to get headache in between fever, may or may not be with lethargy, vomiting, suggestive praise ICP. Think of bacterial infection or intracranial infection otherwise. 5-year-old boy brought with fever, high grade since 4 days, no associated symptoms. Decrease intake, passes urine regularly. He's having toxic look, he's tachycardic, of his febrile, tachypneic. Now, here is a high grade fever since 4 days, no associated symptoms. So it's progressive. And now I don't have any localization. So on day 4, day 5, I happen to do my first test, which tells me there is a marked leukocytosis, neutrophilic leukocytosis. This could be a bacterial infection which is not clinically localized, but still he is having a localization and a classical presentation of a bacterial pneumonia. So if I get this kind of a case 2 investigation, I definitely do a chest X-ray and UTI, and believe me, this is scientific and proven. Even an up-to-date you search and you get this. 60 to 70% of this kind of presentation will turn out to be a bacterial pneumonia in a pediatric age group. Pneumonia is an alveolar disease, may not cough at all in first 3 to 4 days. The cough may come late. So pneumonia or a high UTI may come without in localizing symptoms. You may have a deep-seated abscess, a liver abscess, or sometimes a sinusitis coming presenting like this. 6-year girl, fever in 7 days, initially low grade, intermittent on day 1 and 2, later spikes, increases, and now remittent high grade. Typical non-localizing fever progressing on to get maybe some localizing symptoms. This is typical non-localizing. Now this child don't have any generalized symptom at all. He's got vague abdominal pain, vomiting, loose motions occasionally. He has a traveling history and hoteling 15 days ago. So non-localizing fever progressively increasing, or forefathers have told us a step ladder pattern. Once I attended a conference and the faculty said, I don't believe this pattern. But believe me, we have been following this for last 30 years, and a pattern recognition still holds as much importance. All those patterns were initially defined in the pre-paracetamol era. But believe me, even with proper application of our knowledge and understanding, even after paracetamol era, we can still localize those, or we can still recognize those patterns of infection and can diagnose a condition reasonably well. So this is non-localizing fever. Most of the bacterial infection will localize the system by 3 to 5 days. If non-localizing bacterial, think of enteric, UTI, endocarditis, which is hidden, Cox, and rarely sometimes brucella. 1-year-old boy, fever since 2 days, mild cold with cough, irritable, taking lesser feeds. A febrile, alert, intermittent cries and goes to sleep. Pulse well felt 170 per minute, but mind the tachycardia. Certain 2 important features I always never want to miss is tachycardia and intracranial infection. If you miss them on the first visit, second visit could be a disaster. So this child has got tachycardia, cold hands and feet. Enterofontal is normal, no rash. Rest is general and systemic examination, insignificant. So this child has not come with anything, but we need to look at those subtle critical findings to avoid any miss. So what are those critical alarming features? So for shock to recognize, one must recognize the lethargy, irritability, seizures, altered behavior, cold extremities, mottling, decreased urine output, tachycardia, delayed capillary refill time, and hypotension is a last phase of shock. So far before that, one should recognize shock, because if you miss it in the first visit, you may face a disaster. The respiratory distress, all of you can easily make up. Rapid breathing, increased work of breathing. Cyanosis is a last phase or late phase of respiratory failure. Lethargy and abnormal mechanics. The stridor, all of you must have heard the child having inspiratory difficulty, something like so that's stridor. That suggests of upper airway obstruction. The wheeze, the small airway obstruction, which will typically seen in asthma, like and then that's a exhalation difficulty. And the grunt, which is typically seen in alveolar disease, alveolar collapse, loss like in pneumonia, ARDS, pulmonary edema, something like karnhana आपण त्याला म्हणतो. So those things are serious symptoms and signs which should be picked up early and guided. Neurological alarming symptoms are very obvious: persistent headache, vomiting, headache persisting between fever, lethargy, seizures, abnormal neurological signs, acutely appearing paresis, involuntary movements, etc. Now, important of all is not to miss the shock. Focus on that, those initial first slide. This is a 3-year-old boy brought with low, moderate grade fever since 3 days, cough since 2 days, breathless since 1 day, history of osteomyelitis treated 6 months ago, liver abscess treated 3 months ago, father died of sudden heart attack when child was 1 year old, tachypnea, tachycardia, compensated shock, he had lobar concept. So multiple things in a very short lifespan, all significant infections in the body. Father has some vague, unusual history. Such kind of presentation and present episode of septicemia and low consultation. This kind of a thing, think of an abnormal host. This is immunodeficiency. Now, is that all? So recurrent significant infection, especially deep-seated, think of immunodeficiency. Don't keep on bombarding antibiotic. Don't keep on treating one single infection. Look at the broader picture and you may not miss something. This child turned out to be HIV positive. Father actually had died of HIV. Though many times they come with them, they don't want to tell it's HIV. There's a heart attack. So look at this suspicious history when they come. 8-month boy brought with fever off and on since 15 days. Head always remains warm. Now these are things which may be missed in general practice. They come up with multiple antibiotics being bombarded. No other complaints. He's a playful, active child, good weight gain, no clinical findings. His all investigation done at least 3 CBCs, X-ray, everything has been done and referred to me. What more investigation? Only one investigation. Have you recorded the temperature? Have you documented the temperature? Commonly, this poor mother with the first baby don't have experience, puts her hand on the mouth and tummy on the head. She said it's warm. This is physiological. So first step of it is to record, document the temperature. Head commonly remains warm in a small infant because that's a time. This is again a physiological postulation. That's the time brain growth is maximum and almost 25 to 30% of your blood supplies to the brain. That's an exposed area that looks always warm. So first and foremost kind of a step of recognizing the cause is to confirm the fever is there by documenting the fever. So document the fever. This child turned out to be physiological, no fever at all. Another child, his Nikhil completed 1 year on 22nd of May, brought on next day of birthday with fever for last 15 days, decreased feeds, occasional nausea, no other complaints. He is active, playful, comfortable, no positive findings, clinically bang normal, but 15. So is this a non-localizing fever? Now there are subtle histories and markers in this history. I purposefully put 22nd May and note that. Investigation screens were normal. What next? This child typically was coming from one of the warmest zones of Raigad, the Khalapur belt, which occasionally documents almost 40-42 degrees fever temperature in the summer May. And this child was actually an ambient temperature related kind of an environmental fever. I'm sure Sangli area also must be seeing those kind of a temperature patterns. So once you have done reasonably investigation, you have confirmed the fever is there, child is quite stable at the end of 15 days, all your investigations are normal, give a trial of keeping this child in some cooler places. I'm sure you may be having some AC rooms, just keep him there for 48 hours and fever goes up. Hydrate him well, give all the feeds well, keep in a cooler room, fever case. So don't forget this environmental fever. So ESR, CRP, all can be erratic, believe me. They can take you towards, even the Procal for that matter, there are a lot of debate going on whether that gives you a bacterial diagnosis, viral diagnosis, this, that. There are still limitations to that. There is no clear-cut kind of a guide. You have to take a good history, good clinical examination, decide what you are expecting from your labs, and then interpret the labs. Don't go to the labs directly. 4-year boy, healthy, chubby, completely immunized, brought for fever for 4 days, high spikes 2 to 3 days per day, irritable red eye on day 2, day 3 of fever, breathless since 1 day, abdominal pain since 1 day, a GI symptom, irritability, breathlessness, high grade fever on day 1, multisystem. He's tachycardic, he's hypotensive, he's febrile, he's tachypnic, basal crepes are there, liver is 5 centimeter, S3 gallop, so he's in cardiac failure. Now 4 days, on day 4 in cardiac failure with a multi-system presentation. This is a typical phase. You can see the conjunctival congestion, you can see the strawberry tongue, perianal rashes, typical connective tissue presentation. And we have these Kawasaki disorders. Till last year or till maybe early this year, we used to have even a lot of MIC post-COVID, and that's how they are presenting. So connective tissue disorder is a big kind of a chapter. How do you recognize them? High grade fever right from the beginning. In between, fever may have a transient short normal period, very typical pattern, acute onset, acute offset. Now this can be a standalone disease to start with, or this may be kind of a complication on a bacterial disease, like we do see at present nowadays HLH, which complicates a dengue subsequently, or even an enteric subsequently, where suddenly child starts severely sick on day 7, day 8. So think of connective tissue disorder patterns in those kind of scenes. So this child, we did an echo and confirmed to be having a dilated coronaries. You can similarly get the MIC picture, subtle differences. I will not go into details on that. Fever due to connective tissue disorder is not common, but when do we suspect? Prolonged fever, no obvious localization. Later, we may have multi-system presentation. Subtle transient rashes may be there, especially during fever. Typically, we call it as evanescent rash, or evolve over 6 weeks to 6 months with musculoskeletal and generalized systemic manifestation. Early lab clues may be there. So typically, these children will have high inflammatory marker. They have got neutrophilic leukocytosis, thrombocytosis, high ESR, CRP without any localization. There are exceptions to the rule, but I would say 90% of them will follow. The exception could be SLE and those kind of things where you may have cytopenias. Otherwise, all connective tissue disorders generally have cytosis. When do we investigate a febrile child? In my case, if no focus after 3 days in a high grade continuous fever, I will definitely investigate, at least with the basic KBC inflammatory marker and urine. Rapid deterioration early phase. Child comes sick, toxic, shocky on day 2. I will not wait for day 3. I'll investigate on day 1, day 2 itself. And early investigation are essential when we have a known case of immunodeficiency, underlying systemic disorder, like somebody is with cardiac failure, somebody with chronic cardiac disease or renal disease. I may be not going to the 3rd day. I may even investigate day 1, day 2 itself. Known case of a repeated UTI, where I may be catching up UTI right on day 1 if I know the source, and a proven context to serious infection. So somebody is coming with meningococcal infection in the family, and other child comes with a fever on day 1. I will not wait for day 3 because this can be a killing disease if I wait till then. So those are the investigation guidelines. Should fever be treated? Maybe a last 1 or 2 slides. Studies suggest antipyretics increase the mortality in mammals with severe infections. Now, antipyretics prolonged illness in influenza, chickenpox, malaria, and measles. These are all evidence-based statements. You can find them in Harrison's textbook also. Antipyretics increase viral shedding and diminish antibody response. And paracetamol does not prevent febrile seizure. Rather, it just reduces those, as I take COX-2 inhibition, reduces the fever spike. You don't expect a fever. Why do we want to give paracetamol? It should be given only to reduce the discomfort. सर ताप कमी आला पण जात नाहीये, ठीक आहे, बाळ कसं आहे, बाळ खेळतंय सर, दूध पिते, ठीक आहे, मग दॅट इज व्हॉट आय एक्सपेक्ट फ्रॉम पॅरासिटामॉल. मग सर त्याला मी मेफ्टाल देऊ का, सर मी त्याला आणखी काय एबिजोसिक देऊ का, कशासाठी? दे आर स्ट्रॉंगर ड्रग but they have stronger side effect also. Paracetamol is still the safest one. Thank God the nimesulide is already out of market. That's another dangerous drug which have gone through. So in nutshell, at least we doctors should understand a fever is a friend. It's very difficult to convince parent that it's a friend, but if we are convinced ourselves it's a fever is a friend, which is protective response of the body to any infection or inflammatory method, then we can over the time convince our patient that fever is a friend. So friends, to summarize, first step in analysis of fever is first to confirm documentation of fever. If it is especially low grade, high grade fever, yes, it is fever, but doubtful fever, confirm it is fever itself by documenting it. In short fever, try to diagnose from the history, the onset, duration, progress, multi-system or single system, localized or non-localized. Send the investigations when you are in doubt. When you are sending the investigation, write down what you expect from that. Don't make your diagnosis solely on the basis of investigation. You should have a differential diagnosis already in mind Based on that, interpret the report and then make your diagnosis. Seek specialty opinion when it is needed. Diagnose before specific treatment. Empirical treatment is almost getting out of market. Once upon a time, when I was trained, AKT empirical was kind of a thing, was a trend. Today, we don't give empirical AKT, almost don't. I would say 80% times you have a bacterial diagnosis. Rest, leave about the bacterial. Yes, we always have a diagnosis now before starting antibiotic. Viral, we don't have to. Once we say virus, it's a benign virus, and most of them, except maybe herpes and few of them, there is no treatment. Even the dengue don't have, even your COVID don't have a definite antiviral, still proven without doubt. Empirical antibiotic can do more harm than help. No role of empirical steroid. Suppose I should have put it in red and blank. No role of empirical steroid in any of your febrile patients. Thank you very much for the hearing and the opportunity.
Thank you, sir. Thank you very much, Dr. Mahesh Mohite. One request to all the audience: if you have any questions, please type in the Q&A box in the window. Please don't type in the chat box. So let us proceed with few questions, sir. First question: what are the common causes of fever which last for more than 7 days in children?
Excellent question. Now, most of the pediatric fever, as Dr. Jasani mentioned, still 70 to 80% of our fevers are viral, and almost all of them are over by 4th or 5th day. So when it goes beyond 5th day and there is no localization of fever, up to maybe up to 2 weeks, I may think of non-localizing bacterial fevers. So when I say non-localizing bacterial fevers, it is enteric commonest. Cox in a scenario, in a pediatric patient, we want to generally have a contact history. Third, it could be a UTI, which is still missed. Fourth, it can be occasional brucella, which may be picking up. And not to forget a bacterial endocarditis, which may be missed initially, and especially if there is underlying cardiac disease. So these are about 4 or 5 infections which I may consider till maybe 2 weeks. Once I cross that limit of 2 weeks, after that, the chances of this being bacterial disease or infective disease, yeah, not to forget occasional virus like EB virus. Now, beyond 2 weeks, my chances of this being a bacterial or any infection becomes lesser, and my more non-localizing diseases like connective tissue disorders. So we do see SOGI, we do see JDMs, many vasculitis syndromes or arthritis syndromes. So they may be becoming more and more common. And then it could be immune mediated fevers, which may become, it could be post-infective immune mediated fevers. And in latter part, not to forget a malignancy, the leukemia, which by and large at this time become toxic, many of them, but occasionally you may be still kind of a silent. And once it goes beyond again a month fever and still on very strongly on a connective tissue disorder, as I said, and then occasionally you may have recurrent fever. The fever goes off in 1 or 2 weeks time, again comes back again after a month or two. I may think of underlying immunodeficiency, or occasionally it could be an anatomical defect which gets reinfected after 1 or 2 months to come up again with fever. So this is a gross pattern recognition of those fevers beyond 1 week.
Next question, sir. This is from the audience. What is your take on the use of non-touch devices to measure temperature?
Use of
non-touch devices to measure temperature.
On a community basis, they are not really required. I would say you're going to a mall or you're going to these kind of things, fine, it's a screen test more of. Reliability not as proven. When you're using at home, what is standard recommendation today is a digital thermometer in a pediatric patient, smaller infant, maybe up to 3 years, auxiliary. Beyond that, one can give sublingual. So no touch devices, not so reliable.
Thank you. Next question, sir. When will you treat fever? What is the best drug to treat fever? And what is your call on using NSAIDs or Meftal for fever in children?
If there are 7 drugs to use for fever, the first is paracetamol, second is paracetamol, third is paracetamol, fourth is paracetamol, fifth is paracetamol, 6 could be ibuprofen, and 7th occasionally mefenamic acid. So what I mean to say, paracetamol is time tested, safest, and still the most effective You look at what you expect from an antipyretic. That is not going to treat the disease. You want to give comfort to the patient without harming him. That's exactly what paracetamol does. I think what is lacking here is the proper dose and the interval. You can go up to 20 milligram per kilogram. It is quite safe. Safety margin in 8 hours more than 150 milligram per kilogram. That's a huge safety margin. You can comfortably use 20 milligram per kilogram, and that's very effective in a children.
If you are using in a very high dose for an extended period, will you use NSC along with paracetamol?
Not at all. So again, what is toxic dose? I had already told you, 150 milligram collective dose in say 24 hours. You never cross that limit. You never cross. And unless and until you have, so some patient comes with accidental consumption of, a small baby comes, at home, there are drops kept and a mother has given that as a 5 ml. So each ml in a drop contains say 100 milligram, and she has given 500 milligram to say an infant of say 4 months instead of giving 1 ml. Now this is the catastrophic situation, which the dose may cross 100 mg per kg or more than that. There, this is a toxicity proven. So give a lavage and give NAC. Otherwise, NAC, because you are giving for prolonged period, no, it gets washed out after 24 hours. Why you want to give NAC to that?
Sure. Thank you, sir. Next question. When you will start using antibiotics, after what duration of fever, and after ruling out which things?
So you are talking about empirical antibiotic, perhaps.
Yeah, right.
Because if you diagnose it clearly, it's a virus, no need of antibiotic. It's a bacteria, it could be on second day. I get a UTI report. I have a known case of UTI who had previous 2 episodes of UTI. On day 1 of fever, an infant of 4 months, I send a urine and that shows pus cells 40 to 50. I send a culture, I start empirical antibiotic. This is justified. Now I have another child which is on day 4. Fever pattern is still not confirmed. It's non-localized, but this child is becoming now more and more toxic, hyperpyrexic, and maybe early signs of shock. Here I send all my investigation, my CBC, CRPs, maybe a blood culture, a chest X-ray. I try to still localize it in first few hours. If I can't, then here I will start antibiotic. Empirically, yes, I am justified, because at the end of another 48, 72 hours, I may get my culture, which may turn out to be salmonella. Then I de-escalate to salmonella coverage. If it don't show and a child is recovering, I may continue the same set for maybe 7 days and get it off. So my approach is very, very rational, that I'm not compromising the life. My life value is very important. Rationals are important, but they're irrational if it is too rational. Too much rational is also irrational.
Yeah.
Life is more important. So we should be following that.
Certainly. Thank you, sir. Last question from my side. What about use of biofire panels in really sick children when admitted to ICU or IPDs?
Very important question, and that's a future, but it is in the phase of refinement. We should be confident, we should be expertise in reading the report as well. At times you get multiple organisms coming them, and that confuses you. Many times this is useful in viral. So for example, I get a pneumonia. I start antibiotics, but before that I'm having strong suspect it's a viral pneumonia. I send a nasopharyngeal biofire, and on a third day it comes influenza. I know I don't have to escalate my antibiotic even if the patient deteriorates in 72 hours. I just have to support him, and after 96 hours, child will recover of its own. So major important use of biofire is to avoid irrational use of antibiotics. It does help you in diagnosing maybe an infection as well. So I have pyogenic meningitis and I get biofire positive for strep pneumonia. Again, I can de-escalate it, but know the limitations. It can no way be compared to culture report, which gives you the culture sensitivity pattern and tells you which antibiotic will be the best in the given scenario. Biofires may give you the diagnosis of an organism, but that organism may be sensitive to something and resistant to something, which make a huge difference in a critical scenario where culture will always score. So the biofire cost today is anywhere 10 to 15,000.
Yeah.
But if you send a blood culture in a suspected septic patient and you send 3 sets of blood culture, which may cost you about 4 or 5,000, that has yield of almost 95% scientifically. So I would say in a suspected septic new antibiotic new patient, blood culture saves or kind of scores far more than biofire.
Thank you, sir. Thank you very much. That's all from my side. Over to Dr. Sanjay Kulkarni sir for next proceedings.
Now, the session on fever is over. Now we move ahead to session on pain in abdomen.
Thank you very much.
To start with, the first lecture is on acute pain in abdomen management by none other than Dr. Roy Patankar.
Wonderful talk by Dr. Mahesh Mohite, who I respect a lot as a very astute clinician in Panvel. But looking at the panelists, I have realized to be a successful doctor in Sangli or anywhere else in India, you need three things. You need gray hair, you need a big paunch, and you need very big files. If you have gray hair like my friend Dr. Sanjay Kulkarni, people think you're a wise man and they trust your judgment. If you have a big paunch like me, they think you're a prosperous man and you won't fleece them. And if you have large piles, you have a permanent look of pain on your face and the patient feels you're concerned for him. Thank you, Sangli IMA and Dr. Sanjay Kulkarni for calling me here. And it's a pleasure being back in Sangli IMA. I think I have very close links to Sangli. My father was from Sangli, Gaon Bahate Wadle Hote, and I still come to Sangli several times a year. We unfortunately lost a very close friend of mine, Dr. Ashok Dhonde, who was also a member of your IMA recently. And I'm going to speak to you on the Pandora's box, acute abdominal pain in a patient. I think whether a general surgery, a medical gastroenterology, or a GP's practice, acute abdominal pain does remain the backbone of your practice. More than 1,000 causes exist, and non-specific abdominal pain is about 1/3 of these patients. Between 20 and 40% will need admissions, and almost half will have an inaccurate initial diagnosis. And this is very relevant. It's like fever. Many causes of fever, many causes of abdominal pain. You may have a referred pain, you may have a parietal pain or a visceral pain. I'll go on to this a little bit more carefully. These are the various quadrants of the abdomen, and this is just a suggestion that when a patient comes to you with this, and I'll actually look at each of these quadrants a little bit more carefully along with some case scenarios. Does the progression of pain tell you? Certainly in ureteric colic versus small bowel colic, the frequency of pain and the intensity of pain can give you some clue. So these are the quadrants that you must keep in your mind. And the first and most important thing is the history. I have 5 post-MS fellows working with me in my hospital in Zen. And the first thing they'll tell you is, sir, we'll get ultrasound or a CT done. This is unfortunately modern medicine. It is unusual for a fellow in my unit to sit with the patient and take a detailed history. But believe me, more than 2/3 of time, you can have a working diagnosis. And it's good as a GP, if you train your mind that when you see a patient, write down your differential diagnosis before sending the patient for ultrasound or a CT. Write down 1, 2, 3. And I'm always happy to be proved wrong in my diagnosis because I believe then I have gained something from this examining this patient. Where is the site? What is the duration? Was the onset sudden or gradual? What is the nature of pain? Colicky, dull versus burning. It gives you a lot of clue. A colicky pain is small bowel colic, ureteric colic, biliary colic. A burning pain more likely to be peptic ulcer disease or neurogenic pain. Is there a radiation to the back or the shoulder? Radiating to back, I think in terms of cholecystitis, pancreatitis. Shoulder means diaphragmatic irritation. Is there a pleural pathology? Is there a basal lobe pneumonia? What is the timing and what are the exacerbating and alleviating factors? Does a patient get up at night with pain? That to me is a very, very important history. Is he better after food or worse after food? This is again very, very, I always make it a point of asking, have you had a similar pain in the past? So these associated symptoms must be explored a little bit more in detail. When was the last bowel opened? Do you have diarrhea, constipation? Have you had bleeding in the stool? Have you had a black colored stool? Do you have dysuria, hematuria, or frequency? Is there an accompanying fever, appetite, weight loss? So this is part of my format in my mind when I see a new patient of acute abdominal pain. The second thing I ask him is, have you had this pain in the past and have you been investigated for this? Extremely important to look for associated drugs. Many patients are on steroids. Many patients are taking non-steroidals, which could give you an important part of the clue of acid peptic disease. Remember, many pancreatitis may be drug-induced. Even common drugs like ARBs, etc., can cause pancreatitis. So this is very, very important, and you must never forget that. Examining the patient, look for scars, because say a midline scar or McBurney scar gives you an indication that this may be adhesive obstruction. Is there any distension? Is there any point of maximal tenderness and any features or localized or generalized peritonitis? Percuss and auscultate routinely. Believe me, I find most surgical residents don't carry stethoscopes because examining bowel sounds has gone out of fashion. Asking for ultrasound CT, PET CT has become more common. Many times you can make your diagnosis based on this. I'll now go on to the different quadrants of the abdomen and tell you my thought process when I have a patient coming to me with this. What about patients who come with generalized severe abdominal pain? A perforative peritonitis, pancreatitis, bilateral pleurisy, maybe mesenteric ischemia are common in the causes. Central abdominal pain could be part of early appendicitis. Remember, many patients will come with periumbilical pain or pain just above the umbilicus, and then the pain goes down to the right iliac fossa after 24 to 48 hours in appendicitis. It could be gastritis, could be pancreatitis, and mesenteric thrombosis. In our country, ruptured aortic aneurysms are not very common. Coming on to epigastric pain, if you have a patient above the age of 40, please also think of ischemic heart disease. I've repeatedly seen patients coming to casualty treated with IV pantoprazole, antacids, and then after 24 hours found to have an inferior wall infarct or ischemic heart disease. So in epigastric pain above the age of 40, particularly with comorbidities, please rule out ischemic heart disease. Obviously, acid peptic disease, pancreatitis, and cholecystitis are very high on the list of diagnosis. Right upper quadrant pain to a surgeon, cholecystitis, duodenal ulcers, pancreatitis, subphrenic abscesses or lower lobe pneumonias will present with right upper quadrant pain. Look at the anatomy of the patient. This is where logically it could be. You then get clues about history of alcohol, history of drugs, history of pain radiating to the back, similar pain, dyspeptic symptoms. But believe me, this age-old concept of fat, fertile female of 40 no longer holds true. We see gallbladder stones in much younger patients, in males and thin patients. So it's helpful when that's there, but not very, very common. Suprapubic pain, acute retention urine, UTI, cystitis. If in women of age-bearing group, pelvic inflammatory disease, ectopic pregnancy, and diverticulitis. Remember, the sigmoid colon can actually present with diverticulitis also. Left upper quadrant pain, pneumonias, acute pancreatitis, perinephritis, and subphrenic abscesses. And one of the commonest problems that we face in clinical practice is people coming with right iliac fossa pain. Now, acute appendicitis, as I told you, may begin with periumbilical or epigastric pain for 24 hours and then shift to the right iliac fossa. Mesenteric adenitis in young children. Perforated dues because fluid tracks along the paracolic gutter and comes to the RIF. Diverticulitis, and then the gynec issues, the PIDs, the salpingitis, particularly between women between 18 and 45 years of age. Ureteric colic, typically the pain will be radiating to the back. They may have strangury or some urinary complaints, but it is difficult to diagnose Crohn's or Meckel's diverticulum. Remember, a big distended mucocele or empyema of gallbladder can also present with this kind of pregnancy, and ectopic pregnancy must be kept in mind in any women of age-bearing group. I'll now run through some common cases that we see. The first patient is an 18-year-old girl, RIF pain for 2 days, no fever, vomiting, LMP less than 15 days, was given a broad-spectrum antibiotic by a family physician and then referred to us. The pain was persisting despite antibiotics, PPIs, as well as painkillers. She was tender in the RIF. There was no guarding, no rebound, no rigidity. Accounts were normal. Hemoglobin was okay. We asked for a urine routine, which showed 2 to 5 cells, but no occult blood. So what next would you ask for at this point? So the next investigation of choice would remain an ultrasound done by a good person. I think who does the ultrasound is as important as the ultrasound itself. Fluid in the RIF, fluid in the pouch of Douglas may be seen physiologically at the time of ovulation. So the wonderful report that I get is probe tenderness in RIF, clinical correlation indicated. So that puts the entire onus of responsibility on the family physician and the treating doctor. So this is a situation where patient says diagnosis काय माझे already 2,000 रुपये खर्च झाले, count normal, urine routine normal, ultrasound only, probe tenderness. So what have you got? Not a lot. So at this point in time, you need to take a decision whether you will investigate this further. You do not do a barium follow-through or a barium enema in acute phase. In fact, I don't think there is much role for barium follow-through in diagnosis of appendicitis at all. I'm not a great believer in this concept of chronic appendicitis. To me, it is acute appendicitis or nothing. Chronic RIF pain rarely leads to chronic appendicitis. I don't think I've asked for a barium follow-through in my practice in several years. CT, no CT versus MRI. I think if there is a diagnostic dilemma and the pain persists for more than 72 hours, or the patient has signs of SIRS or sepsis, as in tachycardia, hypotension, raised WBC count, the next investigation of choice, if the creatinine is normal, is a contrast-enhanced CT abdomen pelvis. It is one investigation that will give you clues of appendicitis, tubo-ovarian masses, ectopic pregnancy, ureteric colic, as well as small bowel pathology. MR is not terribly helpful in this situation. A CT is the investigation of choice. Beware of appendicitis in pregnancy. A pregnant uterus displaces the appendix to the right upper quadrant and to the epigastrium. So in pregnancy, appendicitis does not cause right iliac fossa pain. Pregnancy, even with a perforated appendix, will not lead to guarding or rebound because the muscles are stretched because of pregnancy, have a very high index of suspicion. Appendicitis can be troublesome in pregnancy and old age. Why is that? Because in old age, the omentum doesn't cover this, and appendicitis in old age needs early intervention. On the other hand, in this kind of patient, a young female with appendicitis, even if she deteriorates a little bit, it's very easy to manage them. In pregnancy, remember the WBC counts are naturally raised. You can't do X-rays or CTs, so that is one indication of doing an MRI to diagnose appendicitis. And if you have full-blown appendicitis in pregnancy, I would advise doing an early laparoscopic appendicectomy. This is safe in all trimesters of pregnancy and should be done early. So appendicitis in pregnancy and old age, intervene early. Have a high index of suspicion. In a young adult or female, it doesn't matter if you conserve. So this is a patient who came to us 3 days after being diagnosed with appendicitis, was being conserved, not settled, but there was no lump clinically felt. Nowadays, this concept of lump is not, see, the whole appendix is necrotic. I think what happens if you feel a lump preoperatively, then definitely you will conserve the patient with what is called the Ochsner-Sheren's regime and do an elective appendicectomy later. When I was a resident, after giving GA, when you felt a lump, you would back out and not operate. But with laparoscopic surgery, even if you feel a lump after anesthesia, not preoperative, but during anesthesia, you feel a lump, you can still go ahead with surgery like you're seeing in this patient. But appendicitis in pregnancy, and these are 2 pregnant patients where we did appendicitis, can cause early sepsis, has a high morbidity. So I recommend that if you to diagnose it, use MRI, abdomen, and intervene early. What about patients who have severe abdominal pain, but no gross signs? So chronic mesenteric ischemia, and I'm sure Lavate sir will cover this. The second is acute intermittent porphyria. The third is lead poisoning, and the fourth is sickling. Patients who come with severe pain, and आपला general rule असतो की जेव्हा आपल्याला diagnose करता येत नाही, तो patient वेडा आहे किंवा psychosomatic आहे. But before you label any patient functional, these 4 things must go through your mind. And I'm telling you, patients who don't have guarding, who don't have rebound, who don't have tachycardia, who don't have distension, but severe pain. Patients have visited many doctors, taken painkillers, intramuscular injections, and then come to you. So before calling them functional, please rule out sickling. Look at family history, look at the peripheral smear on the CBC, explore the history of complementary medicine. Nobody tells you he's got lead poisoning. Ask them whether you're taking Unani medicine, Zhad Pale, Bhasma Geta Eka. Particularly diabetes city Bhasma Getlani, we see at least one patient of lead poisoning every year who only presents in the early stage with acute abdominal pain without diagnosis or rarely with chronic obstruction. The third illness is acute intermittent porphyria, for which you need to do a urine porphobilinogen and you have the diagnosis. Here again, patient has excruciating pain, he rolls about in bed and in 1 hour becomes totally normal. In between episodes is totally, and the fourth is chronic intestinal ischemia, different from acute ischemia, which I will be covering. But keep this in mind when you have a patient with severe abdominal pain who has intermittent severe pain. The next case I want to discuss is a 34-year-old healthy male, sudden onset left flank pain with a 4-hour history, nausea, vomiting, no previous complaints, no fever, chills, difficulty urinating, no hematuria, but has strangury. He feels like urinating but can't pass urine. He has a tachycardia, has blood pressure, he's absolutely writhing around on a stretcher, moving from side to side. So remember, the first thing is no peritonitis or appendicitis will be rolling about in pain on your stretcher. If on your examination table in your dispensary, he's rolling about with pain, you can pretty much be sure this is not peritonitis. It is some kind of colic. When I say colic, it's biliary colic, ureteric colic, intestinal colic. Look at this patient carefully. In your mind, let's try and make a differential diagnosis. Ask for urinary complaints, ask for hematuria, ask for pain radiating to the back, and ask for strangury. Strangury is the urge to pass urine, but they're unable to pass urine. Typically, if you do a plain X-ray abdomen, you will see nothing. So my suggestion to you is, unless you suspect peritonitis and you want to look for free gas on a diaphragm, do not do a plain X-ray KUB, because in acute abdomen, there is some ileus and you will not see even a stone if it's there. Obviously, the correct investigation is ultrasound, but often stones are not seen. You'll only see hydroureter or hydronephrosis. And that gives you a clue that there may be something below in this, as you see in this sonography plates. A urine routine will be very helpful, because seeing RBCs, occult blood and urine routine will point towards a renal pathology, and you can safely treat these patients conservatively. Should you do an X-ray KUB and IVP? I've already told you, acute phase, never do X-ray KUB. IVP never to be done in acute phase, because I've seen patients coming to me from family physicians with IVP showing a non-functioning kidney, and there is panic among the patients. Remember, when you have acute renal colic or ureteric colic, the kidney may not pick up the dye, and fallaciously you will see it as a non-functioning kidney. The investigation of choice is a CT urography, which will tell you not only the details of hydroureter hydronephrosis, but also of a stone below. When I saw this topic of acute abdominal pain, this is a sign I saw in Hong Kong when I visited last month for a workshop. And this man, this Chinese practitioner, claims to cure abdominal pain by giving acupressure on different parts of the sole. So maybe in the years to come, podiatrics may be a part of our teaching curriculum. This is a patient who was a widow, a known family to us. 40-year-old lady, severe abdominal pain for 12 hours, no vomiting, diarrhea, no urinary complaints, but tachycardia and hypotension, severe lower abdominal pain. Ultrasound done 2 months ago showed a complex tubo-ovarian mass. So what should run through your mind? First is no leading history, acute onset pain, hypotension and tachycardia. That is your red flag. There is something going on. Is it peritonitis? Is it because biliary colic or intestinal colic or ureteric colic will never cause hypotension? It can cause tachycardia, but never this. It is not an intermittent pain. It's a continuous pain. So are we dealing with a perforative peritonitis? Are we dealing with something else? This young widow had an ectopic pregnancy. So quietly what we did in the casualty was send her beta HCG, and the beta HCG was 3000. We took her to OT from casualty. We had about 1.5 liters of blood in the peritoneum. This was a ruptured ectopic. In front of her in-laws or her children, you can't ask the history of being sexually active. So do a UPT or a beta HCG, lower abdominal pain, hypotension in any woman, please rule out ectopic pregnancy. This is extremely, extremely important. Another situation, young male, burning pain for 6 months, but acute pain in RIF and central abdomen is now come with high WBC count, predominantly polymorphs, tenderness and guarding in the right iliac fossa. And this was actually, ultrasound was done, which is normal. We took him up for surgery because of the high count and no response to, and this actually was a perforated Meckel's diverticulum. See, Meckel's diverticulum will present rather insidiously, similar to appendicitis. My also suggestion to you is, if you have appendicitis and you find an incident Meckel's, go ahead and remove the Meckel's, do a laparoscopic Meckel's diverticulectomy, because this is a condition which is extremely difficult to diagnose unless you do a CT. The presentation may be periumbilical or RIF pain. It may mimic appendicitis. So this is how the Meckel's will present. Sometimes you will get on-table surprises. This is a patient that was taken up for a diagnostic laparoscopy for acute abdominal pain, and you see what we are seeing is florid miliary tuberculosis. This patient came with suprapubic pain only, no fever, no weight loss, nothing. So diagnosis of PID was made. She was given extensive antibiotics, but consistent fluid in the right iliac fossa and fluid in the pouch of Douglas. And you can see me using a 3 millimeter scope. This is done under local anesthesia with sedation, and we are taking a peritoneal biopsy. You see, I'm using only one instrument because I have only one port in this. We do this as daycare procedures, but we take a large chunk of peritoneum for not only histopathology, but I think it's extremely important that we take a biopsy, also send a gene expert to look for rifampicin resistance, and also do AFB culture, because we do see drug-resistant TB in abdominal cocks as well. So I think just doing histopathology is not good enough. Always add on a gene expert or a AFB culture. The next patient we have is a 48-year-old obese lady, upper abdominal pain after eating, no radiation, intermittent cramping type of pain, no surgical or medical history, no alcohol, tobacco, or drug abuse. She has a mild temperature. BP respiratory rate is normal. She has a positive Murphy's. What would you do and what investigation would you ask for? So clearly the investigation of choice is an ultrasound scan. Do not jump to CTs and MRs. Remember, a CT scan in gallbladder disease should be done only when you suspect cancer or perforation, never upfront. A good ultrasound by a good trained sonologist gives you more information in cholecystitis than a CT scan. The pericholecystic fluid, wall thickening, CBD size, IHBR dilatations are all important clues in treating cholecystitis. When would I do an MRCP? I would do an MRCP only when the LFT is deranged. When I seriously suspect a bile duct stone or a gallstone pancreatitis, that is the only time I'll do an MRCP. I will do a contrast enhanced CT when I suspect a perforation, when I suspect a gallbladder cancer, never otherwise. 50-year-old family physician, epigastric pain coming on suddenly at 2 in the morning, ECG showing inferior wall STD changes. So the problem is minor changes can be also seen with GI pathology. It doesn't mean the patient is got ischemic heart disease. So in the casualty, we did a TROP-T. We loaded him with aspirin and clopidogrel because he was a hypertensive diabetic. His 2D echo was done in the casualty. We have a person who will do echoes even at night, but his pain persisted. His ultrasound abdomen showed a bulky pancreas with stones in the gallbladder with gallbladder wall edema. So what I'm telling you is there can be an overlap between inferior wall changes as well as cholecystitis, pancreatitis, and acid peptic disease. Repeat the ECG after 4 hours, and in any person, and this age of 50 is gone. We have had 26 and 28-year-olds who come with acute infarcts. So my rule is epigastric pain which doesn't fit a pattern, please do an ECG, repeat ECG at 4 hours. Also do a TROP-T, which you can do in your dispensary as well if patient doesn't want to go to hospital. Extremely important. In this patient, his alk phos is 350, SGOT, SGPT were normal, but his bilirubin was normal. What are you suspecting? This is the typical story of probably cholangitis with a CBD stone. So this is very, very important. Charcot's triad is extremely important. Cholecystitis, gallstone pancreatitis, and cholangitis must run through your mind. And believe me, cholangitis is probably a surgical emergency which needs an early MRCP and draining the system by doing an ERCP. For epigastric pain, let's run through all these investigations. Understand the difference between amylase and lipase. See, amylase is sensitive but not very specific. So if you have availability of lipase in your center or and every town, Sangli certainly has it, please recommend a lipase rather than amylase. Remember, the amylase goes up later but comes down later. It is as sensitive but less specific. When do we do an ERCP? Now, ERCP is not a diagnostic tool. It has its own morbidity, particularly in non-dilated CBDs, and should be restricted as a therapeutic tool when you have a CBD stone or a cholangitis or a malignancy. If you want to look at gallbladder stones or a CBD, CT is not a good investigation unless you're suspecting malignancy or perforation. MRCP, in fact, a CT may not pick up stones. Ultrasound may show stones, but the patient tells you, doctor, CT scan with the stone nahi hai, sonography chukle, ulta hai. CT does not pick up radiolucent stones, while ultrasound will pick it up and MRCP will pick up those stones. Many times, a good ultrasound gives you a lot of information. You're able to see the cystic duct, as you see here. You see the neck of the gallbladder. You see the wall thickening. Any wall thickening more than 3 millimeters is significant. If you have a rim of fluid around the gallbladder, like you see here, what we call pericholecystic fluid, it clinches the diagnosis of cholecystitis. You can see the CBD size. The normal CBD size is between 6 and 7 millimeters. In elderly patients, you may have some dilatation, what we call senile dilatation of CBD, or post-cholecystectomy patients may also have a dilated CBD. But if you have a young patient with the 8 millimeter CBD, even if you don't see a stone, please ask for LFT amylase lipase if they are high points towards CBD stone. Because remember, the retroduodenal part of the CBD is behind the duodenum. When there is gas in the duodenum, the sonologist is not able to pick up a stone in the lower end of CBD. So ask for MRCP. So again, similar to what I told you earlier, this is a patient who came to us in pregnancy with what is called a Mirizi syndrome. She had high jaundice. We could not do an ERCP because she was obviously pregnant in the second trimester. And we actually had to do emergency cholecystectomy to evacuate a stone in the gallbladder. Another case of mine, I think it is 12. Dr. Sanjay Kulkarni, tell me if my time is getting close and I will stop. The next case is a 72-year-old male with history of coronary artery disease on aspirin, dull upper abdominal pain, now severe pain, not able to move. He's hypertensive, diabetic, congestive heart failure. He's on aspirin, beta blockers, and Lasix. Denies alcohol, but smokes 1 packet per day. His blood pressure is 90/45. He's looking sick. He's distended and has a rebound. What is your differential diagnosis? So with this going on through your mind, he has IHD and congestive heart failure. We knew his ejection fraction was low, but guarded abdomen. Now, guarded abdomen, this patient on aspirin or NSAID, the first thing you'll think of is a perforative peritonitis due to DUPERF. You'll also think in terms of mesenteric vascular thrombosis, particularly in somebody who has atrial fibrillation. So the history of AF, they're known to throw emboli into the small bowel, and this is this patient's X-rays showing a free gas on a diaphragm. So even in sick patients, what I want to tell you is sicker the patient, better they are for laparoscopy. On the right side video, you're seeing an ileal perforation. On the bottom left, you're seeing a duodenal perforation. I think 20 years ago, if you had asked me this question, I'd say in sick patients with hypotension, open surgery is better. But now, unquestionably, with modern anesthesia, laparoscopy has a lower morbidity and patients tend to do better. You see 2 large perforations. In ileal perforation, what I'm doing here is excising the edge of the perforation to take a biopsy and then closing the perforation primarily. In due perforation on the left side, I'm actually giving a good wash, and look at how the wash is given. You can see the perforation in the duodenum, and we can actually close this. You can see the material coming out, and then the perforation is closed and a omental patch is placed after putting a drain on this. The next patient is a healthy male who comes to our casualty with nausea, vomiting, generalized abdominal pain, no medical surgical history, no alcohol, tobacco, no family history. So what investigations will you ask for? Just to run you through what are various investigations possible. Obviously a blood count, a low hemoglobin, high WBC count, predominantly polymorphs will tell you a lot. Urine examination will tell you about occult blood in the urine, RBCs in urine, also UTIs. A liver function test in patients who have obstructive jaundice, cholecystitis, pancreatitis. ABG to be done when a patient is sick. What do you gain on ABG? Suppose you have a patient who has tachycardia, tachypnea, then an ABG is done to look for acidosis. If your pH is low or your bicarbs are low, it gives you a clue that this patient needs intensive care management. You have, for example, patient who is cold, clammy, tachycardia, hypotension. The first thing I will ask for in casualty, apart from resuscitation, is to get an ABG done to decide whether he goes to ICU or goes to the ward. Any lower abdominal pain in any childbearing age, please get a beta HCG done. Get an abdominal X-ray and a chest X-ray, ECG for all epigastric pain, and an early ultrasound. Remember, endoscopies have no role in acute abdominal pain. CT and MRI are justified, provided you can justify why you're doing this. Let's look at what a simple abdominal X-ray tells you. You can see where the liver shadow is. You can look at the kidney shadow, look at the psoas, look at the bladder. So many times you can get some clues by looking for gallstones, renal stones, foreign bodies, or any changes of the bone that you see in this X-ray. An X-ray of a generalized concertina appearance, which you see in jejunal obstruction. When would you get air in the abdomen? I think X-ray abdomen and X-ray chest must be emphasized. You not only look for free gas on a diaphragm, you can see air in the CBD. You can sometimes pick up abscesses also. You can have this sort of situation when you have a colonic obstruction, when you are very distended. The next and the last part of my talk is acute abdominal pain in the very elderly. Remember, mortality rate can be significant. There can be altered reporting of pain because stoicism, fear, or communication problems. Common causes are cholecystitis, appendicitis, obstruction, diverticulitis, perforation, but also rule out mesenteric ischemia, myocardial ischemia, and aortic dissection. Remember, severe pain without explanation, a patient is deteriorating in front of your eyes, getting tachycardia, hypotension, looking pale, particularly pain in the flank going to the back. Please rule out aortic dissection and ruptured aortic aneurysms, but mesenteric ischemia must be ruled out. Evaluate for the history of recent infarct, atrial fibrillation. If his pulse is irregular, his pulse is 130, 140, you have atrial fibrillation, patient is known to have cardiac issues, hypercoagulability, prior DVT, liver disease, mesenteric ischemia is very high on the list of probabilities. These patients have severe pain out of proportion and usually don't respond to normal analgesics. When they come to you early, the abdomen may be soft. It may not be guarded, except the systemic signs a lot. Your abdomen is okay, but he's got tachycardia, he's tachypnea, he's got uncontrollable pain. Please also think of mesenteric ischemia, as I told you earlier. Some of them will actually give you history of bloody stools, but an ABG showing metabolic acidosis almost always clinches the diagnosis, and we will do a CT urgently on these patients, even with high creatinine, because that's what clinches the diagnosis. We don't want to have situations like this. When you have a CT showing early mesenteric ischemia, we take the patient in the CT to the cath lab, remove the embolus. We can do actylase, we can do many things using interventional radiology. But when you have a situation like this, when the entire small bowel is ischemic, then you're left with resecting 10, 15 feet of bowel and doing double barrel stomas, which is really, this is another patient like this, where you see multiple clots in the mesenteric ischemia, 3-day history, and these patients have a mortality of upwards of 90%. So mesenteric ischemia must be diagnosed early. Look for unusual patient who's very, very sick without abdominal signs. Look for patient with atrial fibrillation who have cardiac disease, and there is nothing worse than missing a mesenteric ischemia. I'll end my lecture by saying there can be nothing more magnificent than the art of alleviating human suffering. And I think acute abdominal pain is one such suffering we can certainly alleviate. Thank you very much. And I appreciate the invitation by Sangli IMA.
Thank you very much, Dr. Roy. As always, very crisp and informative lecture on your favorite topic, acute pain in abdomen management. I have one question from audience. How to manage acute pain after second dose of Covishield? Is it a side effect of vaccine or IBD? And in relation to that, if you can show some light on post-COVID management of abdominal problems, this is what we are facing a lot, and people have lots of questions about that.
Very, very relevant today. I think there are two parts of this question. One is Covishield and one is COVID. So in the first and second, one of our older hospitals, Joy Hospital, was a COVID center. So I think in that 1.5, 2 months of that peak when Mumbai was going through a COVID wave, I have done at least seen patients, 12 patients of mesenteric ischemias, 9 of which died. In those days, getting a peritonitis with COVID, patients in the Delta variant were post-op going into myocarditis and failure. So I've had young patients with ileal perforations who on day 2 had drop in ejection fraction to 10 and 15%. We had to put a IIBP and yet lost those patients. So not only COVID, but even Covishield is known to cause mesenteric thrombosis and generalized clotting, even in young adult female patients. So CNS clotting, abdominal clotting, peripheral clotting is all known after Covishield and COVID. So we must have a very high index of suspicion. So when you have a patient post Covishield who gets severe abdominal pain, I would do an early LDH, occult blood account, arterial blood gases, and do an early CT abdominal angio to look for any mesenteric ischemia.
Yes, I think that answers the question. I think, yeah, how to diagnose mesenteric ischemia?
So mesenteric ischemia is difficult to diagnose, and very often we get patients coming late. Like I told you, when you have minimal abdominal signs, but severe pain, not responding to analgesics. You have a patient who has tachycardia, tachypnea, his WBC count is high. He looks very sick. That is the time that I will ask for a LDH and arterial blood gases. This will show early acidosis, where pH goes down, bicarbs go down, and the way of diagnosing it is by doing a mesenteric angio, by doing a CT angio. Do not do an oral contrast, because once you give oral contrast, then the vessels are not clearly seen. And we have a situation where from casualty, they go for a CT angio. If there is ischemia, they go straight to the cath lab if they're in early stages. What we also look for in that is looking for bowel edema, looking for air outside the bowel, or any signs to show that there is already infarcted bowel. If there is already infarcted bowel, then I would do a laparoscopy. If laparoscopy is showing the whole small bowel infarcted, we do nothing and let the patient die. If there is patchy gangrene, then I would resect that and do a double barrel stoma. For all the young surgeons who are watching this, never do anastomosis in acute ischemia, because the ischemia may progress and you land up with a leak. So always do a double barrel stoma. You can always go back later and do it. So this is important to pick up these patients early and intervene aggressively.
Thank you. Just a comment. You raised a very valid discussion on CT, MRI, and USG, especially in hepatobiliary situations. Most of the times, patients come to us with a CT report, and when we tell them to go again for USG, so USG is never done. There is a question, Dr. Sahib, CT करून झाल्यानंतर USG कसं सांगता तुम्ही? So it becomes very difficult to convince them.
The second problem, Dr. Kulkarni, is sometimes they come with pancreatic tumors with a 2-slice and a 4-slice CT. And then you actually you can't comment on the resectability of the tumor. And they feel that doctor ne naveen CT scan machine टाकले ना, म्हणून सगळ्यांचे परत CT करायला लावतात. So you know, it is difficult to make a patient understand that having a good quality ultrasound or a good quality CT is so important to your diagnosis.
Yeah. So it is not better, but it's a different investigation. And sonography gives, as you rightly said, much more information in good hands, especially in hepatobiliary situations.
Sure.
Yeah. If there are any more questions, I'll just check. And appendix swelling. Okay. For urinary calculi, which is better, USG or CT scan?
So like I said, in the acute phase, doing an ultrasound will only give you a clue. So it's a good screening tool to start with. It will only show you hydroureter hydronephrosis. You may or may not pick up a lower ureteric stone because of gas shadows. So if you're showing a hydroureter hydronephrosis, then in select patients, I would ask for a CT urography to confirm where it is. But a lot of patients you can just treat conservatively, and most of them settle, and you can do a follow-up ultrasound after 2 weeks, will give you information. But the rule is never do an X-ray KUB in acute phase. Never do an IVP in acute. I have recently seen a patient who was sent to me with a non-functioning kidney because IVP was done on the day of acute pain, and the vessels are in spasm, and it's fallaciously seen as non-functioning kidney. I see one question saying that in a female of 75, should a silent gallstone be treated? I think definitely asymptomatic gallstone should be left alone. I think the rule is if your stone burden is more than 3 centimeters, or you have family history of gallbladder cancer, that is the only 2 times I will intervene in asymptomatic gallstones. Otherwise, definitely leave them alone.
Yeah, I think that seems to be all the questions. Thank you very much, Roy, for a very informative lecture. Thank you. I now invite Dr. Parimal Lavate. Dr. Lavate, he has done his MBBS and MD from BJ Medical College, Pune, and did his DM from prestigious CMC Vellore. He's hello, can you hear me?
Yes, sir, we can hear you. Please go on.
Yeah, there's some background sound. Yeah, he's a fellow of GI Endoscopy Society of India and a very prestigious fellowship of American Gastroenterology Association. He is a director of Department of Gastroenterology and Liver Diseases at Jahangir Hospital, Pune, and he is a consultant gastroenterologist at Dinanath Mangeshkar Hospital, Pune. He is a member of various associations like Study of Liver Diseases, GI Endoscopy of India, and he has got multiple international memberships also like American Gastroenterology Association, American Association of Study of Liver Diseases, and then European Association for Study of Liver. He has multiple presentations in national as well as international journals. Now I invite Dr. Lavate to present his lecture on chronic pain in abdomen.
Yeah, so when I was requested to give this talk, actually, and I started preparing it, by about midway, I started feeling it is going to sound more like a postgraduate lecture, but I am very happy to find that all the lectures before me were completely clinically oriented and hardly any investigations were discussed. So I think I'll keep the same perspective. Outline of the talk is introduction to this topic of chronic abdominal pain, basic understanding of abdominal pain, common causes for abdominal pain, clinical and laboratory cues, evaluation of the patient, and some causes of pain we'll discuss which are common and some uncommon, and some talk on the treatment of pain. So if you look at what has evolved, when we were undergraduates or maybe even early postgraduates, acute abdomen was a diagnosis which was often written on the paper. And chronic abdomen also was a diagnosis. So a patient who had long-standing pain was labeled as chronic abdomen. It generally meant that these patients had to go to a physician, while acute abdomen generally went to surgeons. The other thing was the simplicity of diagnosis. So if anybody had upper gastrointestinal symptoms, it was just labeled as gastritis. If there was a patient who came with lower gastrointestinal symptoms, it was labeled as colitis. So in those days, I think gastroenterology was pretty simple and making and writing diagnosis was simple. Today, what has happened is ultimately we lead to the same diagnosis only after a host of investigations. So if you look at chronic abdominal pain in 2022, there are various things which have actually evolved. The first thing is the Rome criteria, where you have criteria with which you can diagnose functional disorders and make a positive diagnosis, in the sense that based on the patient's symptoms, you can make a diagnosis of IBS or whatever. The second is there are a lot of investigations which definitely aid you in diagnosing these patients. And there has been a lot of understanding in pathophysiology of pain and various other mechanisms by which you can target treatment in chronic abdominal pain. So today we are not going to go into all details. Like I said, it is predominantly a clinically oriented lecture. Now, how do you define chronic abdominal pain? So by and large, if you look at the literature, there's no definite definition. But if anybody has pain for more than 4, 8, or 12 weeks, it is considered as chronic pain. Generally, you will find that isolated chronic pain means only pain in the abdomen is not a common symptom. It is generally associated with some alteration in bowel habits, some bloating and whatever. You have to remember that disease is an uncommon cause for chronic abdominal pain. So a lot of patients who come to you and you evaluate, you will rarely find disease as a cause for abdominal pain. And that is why you do a lot of investigations and you find that the results are normal. There are, of course, newer modalities which can yield surprise diagnosis and help you in diagnosing certain patients. And therefore, clinical examination and history taking still remain paramount in treating and evaluating these patients. Now, if there are various articles on chronic abdominal pain, but they are a little different from what I will try to discuss today. So from a personal standpoint, if you have a patient with chronic abdominal pain, These are four main kind of things which I would like to answer before going in for further investigations. So first thing we like to answer is functional or organic. The second is what could be the source of the pain, what could be the mechanism of the pain, and then lastly, of course, what is the location of the pain and what is the pain pattern. So we'll dwell a little on these four aspects one by one. So the most important, like I said, is whether it is organic or functional. So this, for a lot of practicing physicians, may be very basic, but basically it is very important because you can decide and tailor as to which patients require further investigations and who do not. So if you have associated alarm features, which I don't need to list out, like anemia, vomiting, black stools, etc., it is generally due to disease. Nocturnal pain which awakens a patient. So the patient is sleeping and the patient is awakened from sleep. These are patients who need investigations. Needless to say, they will have abnormal laboratory features and abnormalities if they have come with imaging reports on. In disease, I think you need a definite diagnosis so that you can tailor the treatment for that particular disease. For instance, if you have diagnosed a peptic ulcer, you can treat it with PPIs or anti-H. pylori treatment and so on. And the important thing is if you miss out on a disease, it can be harmful to the patient. In a functional disorder, the patient may suffer a lot, which we of course don't want him to. But if you don't treat this patient also, it is not going to cause bodily harm to the patient. It may lead to a lot of suffering, deterioration in his psychological status, in his morale, and loss of quality of life, but it will not lead to body deterioration. So these things are very important to decide when you're looking at. Now, what are the sources of chronic abdominal pain? Now, this is just a broad list kind of. So you can have it arising from so many structures in the abdomen. You can have it arising from the gastrointestinal tract, from the genitourinary tract, from the vascular system. Then there can be systemic disorders, there can be retroperitoneal disorders, and other disorders which include metabolic disorders, neurogenic disorders, and so on. So generally, when you have a patient who comes to you, we try and first see if you could broadly specify which of these systems it is coming from. And by and large, I would say that most of these come from the gastrointestinal tract. The other thing, like I said, the third thing I said was what is the mechanism of pain? So there are various mechanisms by which people get pain. And these are certain examples which I've put in this table. So inflammation is a very common finding which can lead to pain. And this can be either infectious like in tuberculosis, or it can be non-infectious like in inflammatory bowel disease, peptic ulcers, vasculitis, eosinophilic enteritis. When you speak about ischemia, you talk about large vessel ischemia, arterial, not very common for chronic, unless of course the patient has a celiac narrowing. You find superior mesenteric vein thrombosis, and like it was just discussed, we do find these patients after COVID or after the vaccine. And you have to also think in terms of small vessel vasculitis. The other mechanism of pain is obstruction. So you can have adhesions, fibrosis, or strictures leading to obstruction, and the obstruction causes pain. Neurogenic pain is common in pancreatitis. So if you look at a patient with chronic pancreatitis, it is always said that there are two groups of patients. One in whom the plumbing is abnormal, that is, there is an obstruction in the duct. So here you can relieve these patients by doing an ERCP. And the other group of patients is where the wiring is defective. That is, their ducts may be normal. They have a small duct disease, but they have neurogenic pain. And of course, you can have it in porphyria, in herpes, and so on. The most common cause for chronic abdominal pain is visceral hypersensitivity. So there is a concept which we won't go into called as allodynia. So it is like if you prick a pin over here, everybody is going to get pain. But if you just touch a feather here, only those who have a hypersensitivity are going to get pain. So that is called allodynia, or enhanced sensitivity of pain. And that is commonly seen in functional abdominal pain. The fourth thing is, where is the pain located? So this I won't go into because this is practically undergraduate teaching. But this gives the precise location and what you should think of as per the location of pain. Here we'll discuss patterns of chronic abdominal pain and some causes which fall into these categories. So if you have a patient coming in your clinic with chronic abdominal pain, there are three patterns of pain which you generally see. There can be others and there can be an overlap. So one is chronic intermittent pain. So this is quite common. So for instance, if you have a patient with irritable bowel syndrome, he will have intermittent pain and then he may be all right. If you have a patient with duodenal ulcer, he may have remissions and exacerbations. Then there is a group of patients who have chronic persistent pain. So 5 years, my pain has never disappeared. I have gone to so many doctors, I have taken medicines, but the pain is always there. And I have had lot many patients of this type who have come to the clinic almost every week. Each time they tell me, doctor, my pain is not better, but they keep on coming. So basically, I think they just want a patient hearing and your kind of what you could call as healing touch. And then there's a group of patients with undiagnosed pain. Here again, the large majority is functional disorders, but you can have the rarer causes of abdominal pain. So these are not exhaustive lists, but some of the common causes I have put here for recurrent abdominal pain. Functional disorders, again, very common. Peptic ulcer, biliary pancreatic pain. If you have a young diabetic patient who comes to you with abdominal pain, you can occasionally pick up a patient who has not had an ultrasound and his diabetes is pancreatic in origin. And you find that the pancreas shows calcification in the duct and the parenchyma. Small bowel pain is a very elusive type of pain. It's always central. It is always ill-localized. It is often related to food intake. And you have to have a high index of suspicion for evaluation of the small bowel by special means to diagnose these patients. Like Dr. Roy said, colic, biliary, ureteric, intestinal, neurologic disorders like porphyria. And as I do believe that in peripheral areas, you have parasites as a very common cause for pain, and it can be an overlooked cause for pain in urban areas. Sorry. So if you have a patient who comes to you with chronic persistent abdominal pain, like I said, relentless pain, more or less relentless pain, chronic pancreatitis, malignancy, intra-abdominal abscess, somatoform disorder. I've seen two patients with Munchausen syndrome who ultimately had their surgery done. They had it done by their own way and put the surgeon to have it done. And then, of course, it was normal. But surprisingly, on day 2 of surgery, they said that my pain has completely disappeared. And then, of course, functional or abdominal pain syndrome. This is something which we'll discuss a little because by and far, that is what we find in practice. There are certain pain causes which are peculiar to the tropics. I think hookworm is pretty common in Sangli Mirrors area, and I have heard presentations from doctors and gastroenterologists on hookworm duodenitis in endoscopy forums and so on. Tropical pancreatitis, and all these are basically causes which are important in the tropical countries. There are certain myth causes of abdominal pain. So these, I think, are very important to give up. So I'm sure Dr. Roy will also agree with me that don't think of chronic appendicitis, don't think of chronic cholecystitis, and don't think of chronic amoebiasis. These are entities which are there only through generations of what is told, but it is never found in textbooks and they don't exist in patients. There are two reasons why you should not do it. Like I said, scientifically, it is not really very valid. And more importantly, you may get led onto a wrong track. And then you find that you have missed on certain diagnosis. Now, if you look at all these causes which we discussed, this is a paper from clinical gastroenterology and hepatology. You look at the causes which have been shown here in bold, and as they become less and less common in smaller text size, food is a very common cause for chronic abdominal pain. No cause found, very common, even for gastroenterologists, and most of these fall into the functional group. Gas is another, then food allergies, and you find that all these organic causes are low down on the list. So very important to have a good history of diet and all that we'll discuss a little later. These are two pictures which I have put, and I'm not going to read each one of them, but I would like you to focus on the right side. So this gives some rarer causes of abdominal pain, and we do come across these types of pain on and off. So if you start from here, you have people with familial Mediterranean fever, and I have seen one of them who came from Jordan as part of medical tourism. And you can have henoch-Schönlein purpura, you can have vasculitis causing. Then one thing which you have to remember is for people who have angioedema, they can have angioedema involving the bowels. The peculiar thing about this condition is two. One is always check for the drug history, because drugs like enalapril can sometimes cause angioedema. And second is, when the patient has pain, they have a lot of findings on CT scan. And once the angioedema disappears, the findings may come completely normal. So you can ask for this history. Then you have, like Dr. Roy said, things like lead poisoning, very common. We had a patient who presented with abdominal pain, what looked like an iron deficiency anemia. And we felt that it is probably some sort of ulceration, IBD, or malignancy. But all the tests turned out to be normal. And then, of course, he was tested for lead. Lead level examination is pretty simple, and it should be done at a relatively early stage if you have a patient with undiagnosed chronic abdominal pain. In females, I think one diagnosis which you have to consider is endometriosis. So lower abdominal pain. If you are doing a colonoscopy, we have found extrinsic compressions on the colon, and that is due to endometriosis. And that is something which can be a pretty troublesome problem to manage in clinical practice. So these are certain rarer causes of pain. We are not going to discuss them. Now, what about undiagnosed abdominal pain? Because this is a very common finding in clinical scenarios. So you have functional pain, again, like I said, diet-induced pain, irritable bowel syndrome, abdominal wall pain, and of course, any of the rarer causes of abdominal pain. Now, how do you evaluate a patient with abdominal pain, chronic abdominal pain? Standard history, examination, and then further evaluation. And I think we should dwell on this, because a lot of times you can make a diagnosis of the cause for abdominal pain just on basis of all these basic things. Pallor, think of neoplasm, IBD, TB, hookworm, lead, very important, and gastric or duodenal ulcers. These are not comprehensive lists, so there would be some other diagnosis coming to people's mind who are listening to this lecture. Icterus and pain, biliary obstruction. Only icterus may not be very common, but of course you have painless progressive jaundice because of biliary obstruction. But if there's pain in a jaundice patient, think of biliary obstruction. Two situations where a physical examination is important. A lot of people with eosinophilic enteritis have urticarial rashes on their arms and their body. Looking at the patient's legs is important, because a henoch-Schönlein purpura can typically get missed just because you have not looked at the patient's legs properly. Then think of vasculitis if there are certain necrotic rashes or ulcers. And urine color, very important, dark in porphyria and obstructive jaundice. How does the abdominal examination contribute to these patients' diagnosis? Scars, adhesions. Important thing is to get past surgery details, because then you know it is not always adhesions which cause pain. You have to get history of past surgery details, because there can be some post-surgical anastomosis which has got fibrosed. There can be recurrence of post-surgical disease and so on and so forth. Hernia, actually, we have had at least one patient a year who has been evaluated thoroughly with a lot of investigations. It is more common in females because we may not properly expose the patient. And you find that when you see the abdomen by proper exposure, there is just an umbilical hernia, which is the cause for the pain. So proper exposure of patient when you are examining, very important. Looking at the peripheral pulses, very important, because if they're absent, you can think of chronic ischemia. Ascites, very simple in a way. You see whether the patient has pedal edema or no pedal edema. If the patient has never had pedal edema and he has had ascites, there are three causes. One is tubercular, second is malignant, and third is pancreatic. So if you have a patient presenting with ascites, no history of pedal edema, always think of these three possibilities. Visible peristalsis is, of course, intestinal obstruction. We don't see it very commonly because most of these patients are pretty well nourished. But the important thing is to not forget the stethoscope. I sometimes jokingly tell a cardiologist friend of mine says that we really don't need the stethoscope. So I say that probably gastroenterologists still need it, because the important thing which is diagnosed on putting the stethoscope on a patient's abdomen is two. When you have increased peristalsis, it is either a subacute obstruction or some form of enteritis, and it's a very simple bedside, not even few seconds to listen to it. And the typical sounds of a subacute obstruction is found, and you can make a diagnosis and ask for an X-ray. A lot of these patients come with basic investigations. Now, can these really help? So this, again, the answer is yes. So if you find a low hemoglobin, of course, needless to say, you think of inflammatory bowel disease, tuberculosis, and so on. But the important thing is to think of lead poisoning. So if you have a low MCV and you have a normal MCH, MCHC, think of lead poisoning. And like Dr. Roy said, you ask for history of alternative medicines. We had a doctor who was a Unani practitioner, and he presented with what looked like a malignancy in the stomach, and he was vomiting and whatnot. And then we found that he was taking his own pathy medicines, which did him, of course, more harm than good. And then we found that his lead levels were very high. Say around anything more than about 45, you should have your antenna up, and anything more than 80, definitely, yes, think of it. Increased eosinophils, three causes. One is eosinophilic enteritis, second is Church-Strauss syndrome, which we find occasionally once in 4 or 5 years, and strongyloidosis. Increased platelets, very important. From a gastroenterologist's point of view, platelets have now become very important. Low platelets, think of chronic liver disease, B12 deficiency, and of course, hematological disorders. High platelets, think of inflammatory bowel disease. The others are, of course, pretty self-explanatory. We won't read them out. So these are when a patient comes to you with chronic abdominal pain, especially these 3 or 4 items are something which you should focus on, and you may have a clue to the diagnosis. Plain X-ray abdomen is often a forgotten test nowadays. In fact, I am sure Dr. Roy will agree that even in an acute abdomen, when you get a call from the emergency, you say that, sir, we have done his CT scan. But when you ask them, have you done a plain X-ray abdomen? They say, no, we haven't done it. So even in a chronic abdominal pain, you can have all these causes which I have enlisted here. Air fluid levels, chronic volvulus, fecal loaded colon, pancreatic calcification, and ureteric obstruction with an enlarged renal shadow. So there should be a good eye for the person who is reading the X-ray also. And it is especially common in people who have chronic recurrent abdominal pain, because something which can get missed out is subacute obstruction, is often adhesive in nature. Okay. How do you investigate these patients? There are a large number of tests which are available for investigation, and you can either go to either ways. I mean, you can investigate all patients with all types of investigations. Of late, I think one factor which has led to this is the availability of insurance. So a lot of people, especially from certain professions, they will say, doctor, I have an insurance, why don't you admit and do all the tests? And unfortunately, this trend has become a little common. So you have a patient with chronic abdominal pain who is evidently an irritable bowel syndrome. But for the reason of insurance, he gets admitted, he gets an upper scopy, lower endoscopy, CT scan, and whatnot. And finally, you say that, yes, it is irritable bowel syndrome. The other thing important here is that if you go by the medical records department diagnosis charts for assessing what was the diagnosis, very often you find in the insurance papers, these people are labeled as acute intestinal colic or something like that. So this thing is really causing a lot of problems as far as true medicine is concerned. And you do these tests assuming that he has an insurance. So we should avoid doing it really. Now, which are the tests which you should do in all patients? Of course, the laboratory, which includes the tests which we mentioned, ultrasound abdomen, very important thing which we always tell our residents is when you are sending a patient for ultrasound, there's no point in just writing ultrasound, abdomen, pelvis, KUB. You write your differential diagnosis or you write as to what you are specifically interested in. Then, of course, an upper endoscopy, a lower endoscopy. Although it is believed that every patient coming to an endoscopist or gastroenterologist clinic has an endoscopy, it is not really true. And I think the endoscopy percentage probably is just about 10 to 20% of patients who come to us with chronic abdominal pain. When do you take biopsies? Obviously, if there is something abnormal, you take biopsies. But if you have a normal mucosa, there are two or three situations where you take biopsies. The first is if you are suspecting eosinophilic enteritis, and the second is celiac disease. In selected patients, you can do tests for vasculitis, lead, porphyria, C1 esterase deficiency. CT enterography is a very useful test. So there are things like multiple strictures, then ileocecal tuberculosis, then ileocecal Crohn's disease, and you can have hyperemia in the walls of the small bowel, which can tell you that it could be some form of Crohn's disease. Another test which you should ask for is Doppler for the celiac, SMA, and portal splenic. So a complete Doppler examination of the abdomen, especially if you are suspecting a vascular cause. Tests which have doubtful significance. So endoscopic ultrasound done for chronic abdominal pain. Again, you do see patients who have had it for whatever reason. Capsule endoscopy. We have done about 450 capsule endoscopies in Pune. And our indication has predominantly been obscure GI bleed. And that is why our yield of capsule endoscopy abnormalities to a tune of 90%. But there are some series where you have a yield of capsule endoscopy of about 70%, 60%. That is because all these patients with chronic abdominal pain have got included. A diagnostic laparoscopy today for a patient who has all other normal investigations is generally not going to be useful. Celiac workup for people who present only with isolated pain, again, is not really very, of course, very easy test to do, but it may not really be. Now we'll discuss some causes of abdominal pain with a focus on functional abdominal pain. Now, if you look at functional abdominal disorders which cause pain, there are three which are very important: functional dyspepsia, irritable bowel syndrome, and centrally mediated abdominal pain syndrome or functional abdominal pain. The other thing which we commonly find is if you have a patient who comes to you, and it is very common that he says that I am having pain over here or here, and he points with one finger. Earlier days when we were taught, the pointing sign was specific for duodenal ulcers. But today, this is a very commonly overlooked cause for abdominal pain, which is called as chronic abdominal wall pain. How do you diagnose it? So if you look at the patient's gestures, it is basically a specific point where he shows with a fingertip. Generally 2 or 3 centimeters area. It is increased by doing this thing which is called as Carnet sign. So this was a sign which was described quite some time back, but it has come into vogue again. So here what you do is first determine the site of maximum tenderness. Then you ask the patient to contract the abdominal muscles. You can do it either by raising the arms. You don't support them. They have to do it themselves, or raising the head. And then you see what happens. So the test is positive, tenderness becomes more severe or is unchanged. So this is a simple way of diagnosing abdominal wall pain. Now, what is the differential diagnosis in these patients? Abdominal wall hernias, especially in obese patients, and unless you have asked the patient to stand up, asked the patient to cough and check properly, you can miss abdominal wall hernias, especially the epigastric ones, umbilical hernias in an obese patient. Abdominal wall endometriosis. Slipping rib syndrome is something which I have not really very commonly seen. Here, what you have to do is you have to hook your fingers below the rib, and you get a kind of sound and the pain increases. Thoracic radiculopathy common in people who have diabetes, and post-herpetic neuralgia, where you have to ask for history of herpes. Intercostal impingement syndrome is a very peculiar syndrome, and it is a spot diagnosis. You have people who have kyphoscoliosis who say that I have pain over here, And there it is the iliac crest and the ribs which press against each other. And this. Now, how do you investigate these patients with chronic abdominal wall pain? First is, I think, to be aware of this diagnosis. So if you have a patient who says the pain is localized, shows with a finger or a small area with 4 or 5 fingers, unrelated to food, unrelated to bowel movements, generally no associated bowel complaints, and increased on movement. So this is extremely common in people who are in the IT field and who are sitting throughout the day in a particular posture. So you examine the patient and you make a diagnosis with those criteria which I showed. Then you can either treat with local anti-inflammatory drugs and oral anti-inflammatory drugs, or you can refer to a pain specialist if the patient is not doing too well, and think of a TPI, which is a trigger point injection. So these patients do get relieved very well. And these are certain situations where now the role of pain specialists and anesthetists who are into pain management has become important, and they get very good relief after doing these procedures. I, of course, do not know the exact way they do it, but they do it in their own wisdom and knowledge, and patients do get better. Like I said, 3 causes of functional pain which present with pain as one of the symptoms. One is functional dyspepsia, second is irritable bowel syndrome, centrally mediated pain syndrome. Again, think away from this thing called as chronic amoebiasis, and please avoid giving repeated antiamoebics to patients who come to you with abdominal pain. It is wrong medicine clearly, and one should not be doing it. So how common are functional disorders? Now look at the map of India here. If you look at US, this is a dark blue somewhere here, but India is not far too behind. So it is somewhere to the tune of about 10%, 15%. So which means that about 1 in 10 or 1 in 8 people would be having functional abdominal pain. Now there are 3 categories, like I said, and one of them is functional abdominal pain syndrome. So this is something which is a little different from IBS, little different from functional dyspepsia. Continuous or nearly continuous pain. Generally no relation or occasional relation to GI events like eating. Some loss of daily functioning. The pain is not feigned, or it is not a malingering. The patient is really suffering, and insufficient symptoms to meet the criteria of IBS or functional dyspepsia. So this is a very common cause for abdominal pain. And this is a symptom related behavior which I have kind of modified from a review article which is pretty old. So expressing pain of various intensity by verbal or non-verbal means urgent reporting of severe symptoms. So they would call you and say that it is there for 10 years, but they want to see you urgently right away, right now, in your consulting or casualty. They generally deny the role of anxiety, depression. So if you ask them, is there any situation where you have any of this? So they'll say, no, doctor, there are none of these which I have. They'll insist on having diagnostic tests, even if he or she has had an endoscopy just about 15 days back. Their focus is on complete relief rather than disease adaptation. And these are 2 perspectives. Obviously, the patient is going to want relief, but we know that in functional abdominal pain, we may not be able to always offer it. So we always try and educate the patient about disease adaptation. I'm sorry. Taking limited responsibility of, say, pain management. So they come and tell you that, doctor, you do whatever you want, but I want relief from this pain. So the onus is completely on you. So you have to be a little careful with these patients and how you kind of do the counseling. So they are demanding, they want drugs, treatments, and they would rubbish certain treatments which have been given by earlier doctors and so on and so forth. The second category is functional dyspepsia, where the pain part is the epigastric pain syndrome. So here, bothersome epigastric pain after eating, bothersome epigastric burning after eating. This we will not discuss today because this is more of a bloating and early satiety syndrome. The third syndrome is irritable bowel syndrome, which you can make a diagnosis by Rome 4 criteria. So we won't go into all this, but earlier Rome 3 predominantly it was discomfort. Now they have changed it to pain. So that is why it comes in the realm of today's lecture. Related to defecation, associated with the change in the frequency of stools and associated with the form of stools. So you have a Bristol stool scale and so on, but there's no time to discuss it. And this is predominantly a lecture on pain. So we'll focus on it. So how do you make a positive diagnosis of IBS? So what we showed in the first slide about the Rome 4 criteria, you have to have defining symptoms. And there are two, like I said. One is pain and second is alteration in bowel habits, be it constipation, be it diarrhea, or both. So whichever type of IBS you are dealing with, pain has to be there. Then you have to have features which are supporting the diagnosis. So pain is generally relieved more often than worsened by a bowel movement. You can have associated abdominal symptoms, which I have listed here, and multiple or a plethora of non-GI symptoms. So this you have to listen to, and there will always be a list of these symptoms which the patient will give you. So you can do this diagnosis of IBS without doing tests. But now, overall, what should be the approach to all these functional disorders? Okay. So first thing is you have to look at the symptom severity. You have to look at if the patient has a hidden agenda, as it is called, in his consultation. So at the back of your mind, of the patient's mind, if the agenda is to make sure that there is no malignancy because people in the family have had, these are patients whom you may choose to evaluate, show that the tests are normal because that may give them a form of treatment relief by knowing that. The second thing is for mild symptoms, pay stress on lifestyle and diet. And for severe symptoms, of course, you have more and more drug therapies. In general, if you look at therapies for functional bowel disorders, there are peripherally acting treatments which act predominantly on the acid, on H. pylori, on motility, laxative, and so on. Or you have brain-directed treatments. And then there are certain combinations available in India. The other thing is, if you look at the pathophysiology, it is either motility or it is pain predominant. So you have to look at patient overall. And as you are seeing the patient, formulate all these things in your mind and decide as to what you're going to do for this patient. Like I said, dietary and lifestyle factors are very important. And we'll discuss a little about diet in a short while. So these are the older and newer therapeutic targets which are emerging for treatment of these patients. We have a host of drugs and a lot of them can give very good relief. These are some newer concepts which we won't go into, and some slides on the diet related to this I have put. So suppose you have a patient with functional dyspepsia, which is epigastric pain syndrome. How do you treat them? Suppose you have done an endoscopy and you have found that H. pylori is positive. You can think of doing H. pylori eradication. There is a wide debate on this, whether you should do it or not do it. But for the moment, we'll consider that you consider H. pylori eradication. Then you see what happened to the patient. If you ask me, about 20 to 30 patients would do well after this. And then you can check as to what has happened to the patient. For frequent symptoms, you can put a short course of proton pump inhibitors and then put them on on-demand treatment. You may choose to give a small dose of drugs like SSRIs or whatever, the neuromodulators. Acosamide is a drug which is very helpful for people with postprandial distress syndrome. Gastroparesis per se is a close mimic of functional dyspepsia, and one has to be careful. And the clue is, if you're doing an endoscopy in a patient who has had an overnight fast and you find that there is solid food inside the stomach, then you think of gastroparesis. Mind you, gastroparesis is not always diabetic. It can be non-diabetic also. Now, this is a slide which I suggest that you can take a screenshot. I don't think there's any point in reading through this. But actually, if you look at it, there are, so this slide is, I think, a more practical slide. So if you ask me as to how I look at IBS, I look at it as an ABCD disease. So what I mean by ABCD is people come with abdominal pain, people come with bloating, people who come with constipation or they come with diarrhea. And of course, there can be a combination of A, B, C, D. So this shows the drugs which we use in patients with irritable bowel syndrome as far as the symptoms are concerned. Now, how do you treat pain in IBS? So there are 3 or 4 groups of drugs which we use in practice. One is antispasmodics. The second, which was very useful actually, but for some reason has been withdrawn from the market, is peppermint oil. And this was a very useful preparation. A lot of our patients with IBS did get relief from their pain. The third is tricycline. So these are the centrally acting and these are the peripherally acting drugs. So how do you use antispasmodics in IBS? Multiple molecules are available, combinations with anti-anxiety, anti-inflammatory agents, generally helpful in treating pain, but some patients with diarrhea may also be benefited. In older patients, you avoid those with anti-muscarinic, anticholinergic action. Colon-specific drugs like pinavarinium or mebeverine or otilonium, they are predominantly calcium mechanism and should be used in IBS. And always assess what the patient has received earlier, because otherwise he'll say, Doctor, ye to maine liya hai, I have no relief with this medicine. So you should be not caught unawares. This is all the drugs which I have just mentioned here. This is again available in India, which was transiently withdrawn. And these are doses of neuromodulatory or central drugs which we use in these patients. The drugs which we use as gastroenteritis might sound a little hilarious to people who are into psychiatry, but it is better to start with what we can manage, and then if required, have this patient referred to. If I have a few minutes more, Dr. Kulkarni, I can continue. A little about diet
Yes,
and
please.
functional disorder. Sorry.
Yeah, you can continue.
So in diet, I think this is something which we have to use, because this is finally, like I said in that earlier slide, food is amongst the commonest causes for chronic abdominal pain. Timing, content, variation. Think of beneficial foods. There are 2, probiotics and fiber. Foods to be avoided, generally spicy food. Supplementation to avoid deficiencies related to. So if suppose you stop lactose, you have to make sure that calcium, etc. And you have to have a reintroduction plan. This slide again is for a screenshot. This is not to be read, but basically what this shows is a pyramid by which you can have, and this is very useful to give to patients as well in clinical practice, because IBS patients are generally very loyal about their medicines and they want to get better. So if you give a chart like this, they generally do well in dietary fiber. What are the recommendations? So for pain in IBS per se, it is not really very helpful. But the important thing to remember here is, if you have an IBS-C, you can give soluble fiber and whatever. But in an IBS-D, insoluble fiber such as wheat bran should be avoided. There's a lot of talk on FODMAP as dietary advice, and it's a topic by itself. So basically, what you have to do is you have to avoid this. Again, you can have a screenshot, because this gives as to how these FODMAPs really act and cause symptoms. So basically, in very simple terms, these are carbohydrates which are not absorbed. They reach the distal small intestine or the colon, and there they are acted upon by the bacteria, and that leads to formation of excess gas, and that leads to flatus, distension, abdominal pain, and so on and so forth. So if you look at the lists of FODMAP diets, there are not many which are available, and a dietitian is generally required for treatment of this. There are 3 phases of a FODMAP diet. The first is restriction. The second is you have to do a re-challenge, and then you have to have a reintroduction one by one and go into a situation where the patient is tolerating. There are 2 new concepts in irritable bowel syndrome. Like I said, there was a small slide which showed mast cells and bradykinin and things like that. So there is a concept nowadays that there are certain foods which are histamine rich. And if you have a select group of patients who are not really responding to most of your treatments and dietary, these are things which you could consult with your dietitian and advise. And the second group is sucrose as a symptom precipitant. Now you find all these mega stores opening in all cities in India, including towns and etc. So you have all these off the shelf foods which are available. and they are being consumed. So this again is a very important thing which you can miss out in people who have IBS. So that was about functional disorders. It's impossible to discuss in detail each and every condition in this lecture. But the last few slides are on what we call as vascular causes of pain in the abdomen before we end. Now, there are three types of vascular causes in the abdomen which you have to look at. One is stenotic or atherosclerotic, celiac or SMA narrowing. This generally presents as postprandial pain, weight loss, anorexia. All tests are normal. It may look like a malignancy, but when you do a Doppler or ask for a Doppler, you find that there is narrowing. And then you have to have a CT scan triple phase with a sagittal view as well. The second is thrombotic. So SMV thrombosis is the most common. Portal splenic Doppler is the thing which you have to ask. They can be primary or they can be secondary, like for instance, in a patient who has cirrhosis or who has pancreatitis. And then there are certain compressive syndromes. These are not very common, so I thought I'll just have a slide or two on each one of them before ending. So one is, if you look at this slide, it shows these three syndromes. So basically you have the celiac, the aorta here, and you have the celiac artery, which is almost going here like, and you have the SMA over here. So what happens is this is the normal, of course, you have this. And if you have a very acute angle here, the duodenum can get compressed. And that generally leads to what is called as a SMA syndrome, with recurrent pain and vomiting, more common in thin people, more common in females, and more common in younger children. The other syndrome, which is also described, is the median arcuate ligament syndrome. So if you look at this picture down here, you find what is normal, and you find that how this median arcuate ligament syndrome is. So the treatment for both is quite different. So if you have an MALS, which is called as Dunbar syndrome, you have mainly role of Dr. Roy and all the surgeons to relieve this. And needless to say, even in the superior mesenteric artery syndrome, who present with vomiting, duodenojejunectomy is what is recommended. If you have a patient who has celiac stenosis, then of course stenting is extremely beneficial and you should think of it. And also, of course, have a risk assessment of other involvements with atherosclerotic heart disease. So this is the treatment plan for median arcuate ligament syndrome. I won't go into details, but basically this is not something like a celiac artery stenosis. This is a completely different condition. And SMA syndrome also is a different condition. There are many rare causes like porphyria and so on, but we won't go into it. We'll conclude by saying chronic abdominal pain is the commonest symptom which draws a patient to a gastroenterologist clinic. Most patients have a functional disorder. Normal evaluation is the rule rather than an exception. So tailor the investigations as per the patient's clinical capsule. Multiple consultations, evaluations is very common. History and clinical examinations still remain paramount. I'll end by showing two slides. So the first is medicine is an art which is practiced as a science and it is enabled by technology. When you have a disease, technology is important, science is next important, and art is little less important. What I mean by this is, if you have a patient who has been diagnosed with a duodenal ulcer, anybody writes a PPI, the patient is going to get better. Anybody writes a H2 receptor antagonist. In functional disorders, it is the reverse order. So technology has little role. Science has a role, but art is the most important thing. So functional disorders basically ensure that we still remain as caring physicians, where the art of medicine takes precedence over the science of medicine and technology. So with this, I think I'll end my talk. And in case there are any questions, I'll be very happy to answer them. Thank you very much.
Thank you very much, Dr. Lavate. Excellent, informative talk. There are a couple of questions. First is, what is the rule of stool examination in chronic pain in abdomen? If you can, already you have covered this point, but if you can
But I
elaborate
think
more.
the important point which I would like to make here is that stool routine is very commonly done, but stool occult blood is generally overlooked. So always ask for a stool occult blood. Having a stool routine really has no meaning in people who have chronic. You should do a routine and an occult blood.
Yes. There's one more question is, can we do H. pylori eradication in every patient pain in abdomen without doing gastroscopy? It's a very controversial topic.
Yeah, it's a controversial topic. My policy is to not really do this without doing an endoscopy. There are two tests by which you can do it. One is you can do a breath test or you can do a stool antigen test because they are pretty simple to do. But just by doing that, I don't think I would treat these patients. And when you are treating, make sure that you are treating it with a proper regime for 14 days and so on and so forth.
There is a question in PPIs, which is the best PPI? And which is better, estrogen receptor antagonist or PPI?
I think if you want to do acid suppression for symptomatic relief, both are equally good. But if you're going to treat something like a duodenal ulcer or an esophagitis, which is erosive, then you need to give a proton pump inhibitor. As far as clinical effects are considered, all the PPIs are practically similar. There are certain differences, like if you look at rabeprazole, it has a less of CYP2, C19 pathway and more of enzymatic pathways. So if you have some concern about using it with like clopidogrel, you could consider using rabeprazole. Then the pKa of rabeprazole is the highest, is around 5. So it's the fastest acting. But actually, little of it really translates into clinical practice. One thing I generally avoid doing is using the combinations of proton pump inhibitors and domperidone or whichever medicine, especially lesuride in levosulfuride in younger patients, because that can lead to extrapyramidal syndromes, and they can in fact remain undiagnosed for years unless one looks at the patient's drug history.
What is your take on long-term use of PPIs? Patients keep on taking on their own long-term PPIs.
There are three things in this. One is there's a thing called the auto mode of PPI. So most likely what happens is once a patient has started taking PPIs, they'll keep on taking PPIs, which is an auto mode. The second is understanding the side effects of proton pump inhibitors. So there are some which have been really proven, which is increased gastrointestinal infections. Second is B12 and iron deficiencies. And third is osteoporosis. And the third thing is de-prescribing of PPIs is a concept which you have to try and educate the patient and try and get him off the PPIs. So there is a schedule for it, which we won't go into here.
Yes. Right. I think there are no more questions. Thank you very much, Dr. Lavate, for your wonderful presentation.
Headache is one of the most common pain conditions in the world. Up to 75% of adults worldwide have had a headache in the last year. Headaches are a major cause of absenteeism from work and school. They also take a toll on social and family life. I would like to invite Dr. Rahul Kulkarni to enlighten us about its neurological perspective. Dr. Kulkarni is MD, DM, DNB, FAN, and got trained in neurology at TN Medical College, Mumbai. He was very famous as an extremely intelligent student amongst his teachers and seniors too, even since his UG days. At present, he is serving as head Department of Neurology at Dinanath Mangeshkar Hospital, Pune. He has a lot of achievements in the field of neurology. He is convener, Tropical Neurology Subsection, Indian Academy of Neurology, ex-secretary of Maharashtra Association of Neurology, member of many international and national neurological organizations, faculty in many international, national, and regional meetings, principal investigator in more than 25 multi-center trials in neurology. As an academician, he is actively involved in training practitioners and students and has 23 publications and 4 book chapters on his name. His special interests are CNS infections, neuroimmunology, and neurology education. So, Dr. Kulkarni, please.
It's a disease with a lot of myths. This is a very typical scenario. You see a lady who comes to you in the afternoon. She says that she's getting the headache since morning. She has vomited twice. She presents after 7-8 hours with a persistent headache. She's getting similar headache once every week, which is always relieved with vomiting. What is done many times by doctors who are busy in OPD, who don't take, who have a lot of patients in sitting in the OPD. What is typically done? Patient is examined. She's asked question. If she says that there is a lot of nausea and vomiting, it is thought that the headache is because of acidity. If the blood pressure is high, it is thought that the headache is because of blood pressure. If none of these are there, then it is thought that the headache may be because of refractory error. She's asked to check her eye numbers. Headache may be because of sinus. The patient is asked to go to ENT specialist, or sometimes patient is also asked to do a CT scan. Then an analgesic with an antacid is given, and patient is called back after 3 days. If the headache is relieved, good for us. If the headache is not relieved, then probably the drug is changed, Sometimes she's asked to go to ENT specialist to get a sinus is getting punctured, or then she's asked to do a CT scan. If the CT scan is done, then she's asked to do an MRI. And if everything is done, then probably it is hoped that patient will go to some other doctor. So headache has got lots of myths. It's a disorder with many myths. Headache is thought to be because of acidity. Headache is thought to be because of refractory error. Headache is thought because of sinusitis. Headache is thought because of blood pressure. It is thought that CT scan is going to be the investigation of in all headaches, where it is going to decide, or it is going to tell us what kind of headache the patient is suffering from. And analgesics, of course, are used in the treatment of headache. Over next 20 minutes or so, I would try and change some of these myths, and I would tell you what are the facts about headache. Remember that headache is a very common disease. The annual incidence of headache is 90% in men and 95% in women. And the lifetime prevalence of getting headache is 99%. So practically everyone will get headache except for those who do not have head. Medication wise, all the patients have been treated. Majority of them would take self-medication from the counters. So they won't, headaches are caused because of refractory error. Headaches are caused because of cervical spondylosis. That is why they visit so many doctors. Only 10% usually would go to physician. And headaches have many causes, more than 300 causes. Broadly, we divide them into two types: primary headache and the secondary headache. Primary headaches are the headaches where there is no underlying cause. You do CT scan, you do MRI, you do investigation, everything comes normal. Even the medical examination, this patient is all normal. And there are certain headaches which are secondary headaches where we have identifiable cause, like brain tumor, like meningitis or glaucoma. But mind you, these are rare causes. Headaches are also divided as primary and secondary headache by International Headache Society in further subgroup. And there are more than 12 or 13 subgroups. This is a very complicated classification, which many neurologists even fail to understand. Remember that, as I said, the commonest headache are primary headaches. This was a study done in 3,000 patients where they found that more than 90% of headaches are primary headaches. Only 1% headaches or 2% headaches were secondary headache in this study. And amongst the primary headache, the most common causes are tension type headache, which is seen in almost 70% of the patient, and migraine, which is seen in 15% of the patient. These two headaches, tension type headache and migraine, are the most common headaches which are seen in general population. If you see secondary headaches, this was a study of secondary headaches of around 3,800 patients, where they found that about 6% headaches were secondary. And amongst the secondary headache, the causes were sinusitis and the post-traumatic headache as the most important causes. See here that sinusitis is seen as a cause of headache in only 1.7% of patients. So less than 2% headaches are because of sinusitis. Trauma sometimes may be seen in about 1.5% patient. These are rare causes of headaches, less than 2% of the cases. If I get a patient of headache, how do I manage it? First, I try and classify headache in 4 categories, depending on the history. Whether the headache is acute, whether the headache is episodic, where patient is getting similar headaches again and again, whether the headache is chronic, which is been there for more than 6 months in a year, and whether the headache is progressive, whether the headache is progressively worsening. And amongst the acute headache, sometimes we also have a sub-classification, which is called as worst headache, where patient gets the severe kind of headache, the worst kind of headache for the first time in his or her life. And amongst the episodic headache, which are coming again and again, there is a phenomenon which is called a short-lasting headache, where the headache lasts for less than 1 hour and it comes again and again. These will be 6 categories in which usually we divide our headaches and then treat them accordingly. When I see a patient of headache, I usually ask the question always whether the headache is happening for the first time or whether the headache is coming again and again. If the headaches are frequent, similar headaches in the past, then I ask frequency as well as duration of each attack. If the headache has come for the first time, I ask whether this is the first time in the life whether the patient has such severe headache. We also look at the site of pain. We also look at the characteristic of the pain. Throbbing headache is the most important category, which is worth mentioning, because usually the throbbing headaches are the ones which may have sinister cause in it. The non-throbbing headache, the pressure, tingling, burning, itching, are always the headaches which are associated with tension type of headache. What are the associated symptoms with headache? We always ask this question: whether the patient is vomiting, whether there is nausea, whether he or she has got intolerance to light as well as to sound, whether they are also getting chakkar with it, whether there is any fever, loss of consciousness, etc. Whether there are any aggravating factors with the headache, whether the headache is relieved by certain factors, whether patient has any past history. Important disorders worth mentioning is HIV and cancer. If the patient has got any of these two, and of course we are worried about the kind of headache that patient may be suffering. And family history of headache can occur in migrainous patient. where mother can have migraine, father can have migraine, and the child also can have migraine headaches. We always look at whether the patient has got fever. We also check the blood pressure of the patient. We do a local examination, look at head and face, eyes, look at sinuses, ears, see whether there is any neck stiffness, and do a detailed neurological examination and to see whether the patient has got any signs to suggest that there is certain structures involved or uninvolved. Investigation, as I said, may be normal in most of the headaches because more than 90% of headaches are primary headaches. Their investigations are normal. So CSF, blood investigation, and scans are rarely required as far as headaches are concerned. CSF we do if the suspected meningitis or hemorrhage, and blood investigations are not done in any of the headache. We do ESR and CRP if we suspect a disease which is called a giant cell arteritis. So most of the times the diagnosis is clinical. Imaging wise, I would do imaging in a patient. The headaches are progressively worsening. If the patient has got this first headache, the headache is always on one side. If the headache is associated with other features like fever, neurological deficit, or the headaches are there in a patient who has got pre-existing HIV or cancer, if the headaches are in elderly people, or if the headaches are not responding to treatment, then I usually would image the patient. And I also image if the patient asks for it. If the patient says that, doctor, I'm worried whether I'm suffering from brain tumor, please do a CT scan or MRI. I never say no. I always allow the patient to do imaging because a normal imaging also helps to be a therapy in the patient. Then he or she thinks that the headache is not severe and it starts improving. So I would do imaging in all these indications, not otherwise. And if we do scan, sometimes we see these kind of tumors, the big tumor in one of our patient, meningioma, there is a subdural hemorrhage in one of the patient, and there is a venous sinus thrombosis in one of the patients. So these kind of abnormalities can occur on the scan in a patient who is suffering from headache. An important mnemonic to remember called SNOOP. These are the headaches where one has to worry, where S stands for systemic symptoms like patient who has got fever, weight loss, or if there are secondary risk factors like HIV, systemic cancer, then you should image the patient or you should worry about the patient. If the patient has got neurological features like confusion, impaired consciousness, etc., then one should investigate the patient. If the headache starts sudden, as I said, split second, or whether suddenly or rapidly, then one should investigate the patient. A new onset headache in elderly above 50 years of age, one should do imaging of the patient. And if the headaches, patient had a previous headaches and the headaches have now changed its character, then one would image the patient. So remember this mnemonic, very easy to remember, SNOOP, where there are systemic symptoms, secondary risk factors, neurological features, onset of the headache, elderly headaches, and change from the previous nature of the headache, and one should investigate the patient. So remember this mnemonic where one can find out what are the worrisome headaches. As I said, clinical classification of headache is acute headaches, where there is a category called as first headache, episodic headache, short lasting headache, chronic headache, and a progressive headache. I'll be talking about these in brief detail. So if you see acute headache is a very common scenario. Many of the practitioners would see these kind of headaches in OPD. There are multiple causes of it. There can be first attack of migraine. There can be other primary headaches. Or there can be other secondary headaches also, like headaches associated with other infections, ENT diseases, or with tumor or glaucoma, or etc. There are many conditions which can cause acute headache. Usually, if the patient has got neurological features, if there are systemic features, if the patient has got underlying fever, the headache is very severe in onset, headache comes after trauma, headache that worsens after exercise, or headache that occurs at night. These are the headaches where usually I would investigate in acute headache. Remember that if you have a doubt in acute headache, it is always better to investigate because acute headache is a condition which can occur because of number of causes. Talking about first headache, as I said, it is a worst headache for the first time in the life of patient, where the most important cause is subarachnoid hemorrhage, where there is hemorrhage which occurs from an aneurysm that ruptures and patient gets hemorrhage in the brain. This is a phenomenon which is called as first headache. First headache can also occur because of various other conditions, where there can be intracerebral hemorrhage, venous sinus thrombosis, there can be dissection of the arteries, there can be vasculitis, there can be colloid cyst, there can be pituitary disease. So there are many other conditions which can cause headache. Remember that all these conditions which have been mentioned here are very serious conditions. So first headache, usually the causes are secondary. If you get these kind of patient, it is always better to admit this patient, preferably in ICU, and investigate all of these patients by doing a CT scan or an MRI of the patient. Many of the patient would also require MRI or CT scan angiography or venography, because many of these disorders are also associated with disorders of the brain blood vessels. And many times patient may require to undergo, sometimes patient may require to undergo CSF examination as well. So first headache is a serious disease. It should not be managed on OPD basis. This would require admission. Talking about episodic headache, which is one of the most prevalent headache in the community. Usually it is because of primary headache disorders, which include migraine, episodic tension type headache, and then other rare conditions like idiopathic stabbing headache, cluster headache, and other primary headaches. Secondary headaches are rarely episodic, like sinusitis or pheochromocytoma, but these are very rare conditions which can occur again and again, repeatedly. So if a patient says that I am getting headache for last 10 years, I get headache once every 15 days, and then it is because of sinus, it is never because of sinus. It is almost always because of migraine. So migraine is one of the most common condition for which patient would visit doctors, which is worth knowing and worth knowing how to treat it as well. So it's the most common cause of headache. Usually it starts within first 2 to 3 weeks. More than 90% of the patient would get their first attack before 40 years of the age. More common in females. Prevalence rate in community is 6% in males and 20% in females. Family history is present in 70% of the patient. How do we diagnose migraine? Usually the headache lasts between 4 hours to 7 to 2 hours. So headache may go up to 3 days. The pain is usually unilateral. That is why it is called as ardhashishi in Marathi, or hemicranial headache, pulsatile or throbbing kind of headache, moderate to severe, and it worsens by doing physical activity, improves by taking rest, associated with nausea and vomiting, and both, or photophobia or phonophobia. These are the features with which migraine is diagnosed. Usually patient will get more than 5 attacks or more than 5 attacks of these features, then one would diagnose migraine. Diagnosis of migraine is on the basis of history. It takes less than 1 minute for diagnosis of migraine. Migraine typically would start with a prodromal phase. Before headache, patient may get some prodromal symptoms where patient thinks that he or she is going to get this attack. Then there is an aura, then there is a headache phase, and following headache phase, there is a postdrome or a post-headache phase. This is how the migraine usually would, an attack of migraine would occur over the time. So prodromal symptoms would occur in 60% of the patient. They may occur hours to days before onset of the headache attack, where patient may be irritable, there may be physical overactivity, there can be yawning, there can be food craving, increased urination, or there can be physical or mental slowing, difficulty in concentration, constipation, etc. This will be followed by aura, which is one of the best described feature of migraine. But remember that aura will not occur in all migraine patients. It would occur only in 15% of the patients of migraine. When there is an aura, it was called as classic migraine in earlier days. In aura symptom, patient get this typical visual symptom where he or she gets some skimmering or glimmering lights in front of eyes, which gradually increases, and then it may involve half of the head, half of the hip field of the head, eyes, or it can spread to the other side as well. Typically, the aura would gradually progress over the period of 5 to 20 minutes. Then it would disappear. This will be followed by headache. Sometimes patient get tingling and numbness in the hand as a part of aura. This is followed by headache. The headache is usually moderate to severe. As I said, it can be unilateral or bilateral. Unilateral can occur only in 60%. It is a throbbing headache which worsens with activity and improves with rest. The site can be anywhere. It can be temple, it can be forehead, it can be eyes, it can be back of the head. Headache in migraine can be anywhere on the head. Sometimes patient can get even pain on the face as well, or on the neck also. It is usually associated with nausea and vomiting, and it is because of this nausea and vomiting that it is thought that the headache is occurring because of acidity. So remember that the symptoms of acidity, the nausea and vomiting, are features of headache. So it is because of headache that these features occur. So giving them antacid is not going to help. There is always increased sensitivity to sensory stimuli. So patients do not like light, they don't like noise. Many of the times patient may have associated dizziness also. These will be the various features which would occur with migraine attack. The attack of migraine is usually triggered by certain factors. And the classic triggers which have been described in literature include dietary trigger like cheap chocolate, Chinese food, hormonal triggers. There can be psychological triggers. There can be sleep-related issues like change in the sleep cycle, excess or lack of sleep, hormonal triggers, physical triggers like certain smells, change in weather, fatigue, overactivity, trauma, etc. And in India, we have various other triggers: overcrowding in the festive seasons, application of henna, spicy, oily, fried Indian food, high pollution in India, educational system, the stress in the children, mosquito coils, where there are lots of smells, fasting practice in various different religions, hot climates in India, joint family stress and crowded traveling. These are all triggers in Indian patients. So we have seen various triggers which occur in our patients. We usually ask the patient whether एकच गोष्ट केल्याने सारखं सारखं डोकं दुखतं का? And patient come up with very fantastic and funny answers. As far as treatment of migraine is concerned, the treatment includes three things. Number one, patient has to change the lifestyle, because many times it is thought that migraine usually would mean that the lifestyle has become going haywire. The patient has to avoid triggers. Usually we give some treatment during acute attack. Many of the patients also require prophylactic treatment so as to prevent further attacks. So if you have to treat acute attack, the drug should be taken as early as possible during headache, because if the patient takes the pain medication 2 to 3 hours after the onset of headache, it is not going to help. It has to be taken very early, and usually it is given with domperidone or similar drug with it, because many times headache is associated with gastroparesis. The drug is not absorbed. So if you give drug like domperidone with it, the absorption of the medicine is better. And if the headache is not getting relieved, the drug can be repeated 2 hours after the first tablet consumption. The drugs that can be used are paracetamol. One can use various NSAIDs, and most of the neurologists favor naproxen as the medicine. Ergotamine is an age-old preparation, which is used less and less often nowadays because of its side effects. Triptans are various types of headache, migraine-specific medications. They are also being used by many physicians. Triptans are costly medicines, but one can use them sometimes in the practice. Drugs like sumatriptan, rizatriptan, zolmitriptan can be used. There are 7 or 8 triptans which are available in India. Many times migraine patients require prophylactic treatment. These usually are given if the headache attacks are frequent. So if the headache patient is getting once every 3 months, once every 4 months, he or she will not require preventive medicine. But preventive medicines are required if the headaches are more than 2 per month. And if the patient is taking abortive medicines on a frequent basis, then one would usually use preventive medicines. The preventive medicines includes beta blockers like propranolol, calcium channel blockers like flunarizine, tricyclic antidepressants like amitriptyline, antiepileptics like valproate and topiramate, and there are various newer drugs called CGRP antagonists which can also be used. Most of the physicians would be aware of use of flunarizine or propranolol in the practice. Neurologists favor a lot of use of amitriptyline and topiramate, also valproate in our practice. So these are 5 or 6 classes of drugs which we use. There are newer drugs which are called as CGRP antagonists, which have been used for the treatment of migraine. These are the newer drugs which are given as an injectable form once every month or once every 3 months. At present, these are costly medication, but they seem to work in certain patients where all these previous medications have failed. Episodic tension type headache is another kind of headache which is similar to migraine. It lasts anywhere between 30 minutes to 7 days. The pain here is mild to moderate, bilateral. It is non-throbbing kind of headache. There is no nausea, vomiting, photophobia in these patients. Usually it is treated by giving antidepressant. So in migraine, usually the pain is hemicranial, because of which it is called as hemicrania. It is in this area, tension type headache, the pain will be bilateral. And then there is this cluster headache where patient can get pain around the ears, around the eyes, which is called as periorbital pain, which is a rare phenomenon, a rare disease. It is even rarer than migraine. It is more common in males, unlike many other headache disorder. The headache here occurs in cluster. Each cluster lasts for 4 weeks. During each cluster, these people get very severe headache, usually at every time, same time in the day or night. Typically at night, around 2 a.m., these patients wake up with pain. The pain lasts for around 1 to 2 hours. It is very severe pain associated with lacrimation, rhinorrhea, and meiosis. So cluster is a very different kind of headache compared to migraine. And it is treated by giving oxygen. We give triptans. And during the cluster, many times steroids are used, and there are preventive medications which are used like verapamil lithium. So it's a different disease. It requires help from neurologists for treatment of cluster headache. Talking about short-lasting headache, these are the headaches which last less than 1 hour. Usually they would last for a few minutes. These are often primary headaches. Many of them respond to indomethacin. Patients say sometimes that there is something which is getting pierced in the head. These are the typically idiopathic stabbing headache or headache which come on exertions. These are called as exertional headache. Or there are certain headaches which are associated with lacrimation or rhinorrhea. They are called as trigeminal autonomic cephalgias. These are all headaches. Many of these respond to indomethacin, where we use indomethacin as a treatment in these people of short-lasting headache. These are again uncommon headaches. Talking about chronic headache, which are very common headaches, the definition of chronic headache says that if the patient gets headache for more than 15 days per month, for more than 6 months, or more than 180 days per year, then it is called as chronic headache. It is seen in 4 to 5% of population. And there are 3 important types of chronic headache. There is a chronic tension type headache. There is a chronic migraine. And there is a condition which is called as hemicrania continua, very uncommon condition. So important 2 conditions are tension type headache and chronic or transform migraine. Headache here usually is non-throbbing. It is an aching kind of pain. Usually it is associated with stress, depression, insomnia. Many of these patients have taken analgesic for a very long period. So analgesic overuse is a very common phenomenon in these people. Tension type headache is supposed to be one of the most common condition of headache. They rarely consult doctor. They keep taking self-medication. Headaches are bilateral, throbbing, associated with lots of psychiatric comorbidities. I'm not expert in tension type headache. There will be another special talk after this on tension type or headaches which are being associated with psychiatric disorder. They are usually treated by giving antidepressants and various behavioral therapies. Analgesics should not be used very often in these patients. Many of the patients also require help of a psychiatrist. And fittingly enough, this will be covered in the next talk by Dr. Govind Kulkarni. I would talk about chronic migraine. We know that migraine is an episodic disease, as I said, where a patient can get episodes of migraine once every 10 days, once every week, twice a week, etc. But over the time, the frequency keeps increasing and the headache gets transformed from an episodic phenomenon to chronic daily migraine. This usually would occur because of 2 things. It can occur because of excess use of analgesics. That is why in the myths, as I said, one should not use daily analgesics in the treatment of migraine or headaches. Because if you use daily analgesics, the headaches from an episodic phenomenon can get converted into a daily phenomenon, which is difficult to treat. And of course, stress can lead to episodic migraine getting converted to chronic migraine. Chronic migraine we usually treat by giving topiramate or amitriptyline. And sometimes we also use injection of botulism toxin in various points in the scalp muscle for treatment of chronic migraine. So it's again a difficult disease to treat. One type of headache which is worth mentioning is called as medication overuse headache. People keep taking these kind of medicines over the counter, analgesics or ergot preparations. We have seen people who take analgesics practically every day, 2 to 3 tablets a day for many months. These people get a different kind of headache. So here, the headache, rather than responding to medication, starts increasing if the medication level in the body goes down. It is like an abuse, something like an alcoholic patient. He or she stops drinking, then they start getting symptoms, and then he or she has to drink again. Similarly, if the medication level in the body goes down, the headache comes on. This is a headache which has classic features. This is a headache which worsens by physical or mental exertion, associated with nausea, irritability, giddiness, asthenia, fatigue. They are dependent on the drug, and the analgesic doses keep increasing over the time. And if you stop the analgesics in these people, there is spontaneous recovery in almost 15%, 50% patient of the headaches. But of course, it requires a lot of efforts, not just medication, but they also require counseling, etc. Treatment here, as I said, is stopping all the ergot or analgesic preparation. Immediate relief may be seen in some patient. They will require this prophylactic treatment. Many of these patients would require intervention, help of a counselor or a psychiatrist, and NSAIDs are used only with caution in these patients. So this is a different kind of headache, and I would suggest that this is probably the most important slide of my entire talk, that if you use analgesics for a very long period, patient can get a different headache, which is a very difficult headache to treat, which is called as medication overuse headache. Talking about progressive headache, the last headache category, this is the most dangerous variety. So these are the patient where patient gets headache, which is progressively worsening. And many of these conditions like tumors, abscesses, subdural hematoma, meningitis, venous thrombosis, glaucoma, etc. would present with these headaches. So progressive headaches are probably the most dangerous types of headaches. They would require careful history taking, careful examination. They will require investigation. Maybe we have to repeat the investigation. First investigation failed. So this is the headache which I don't like amongst all of these headaches. because these are the most difficult headache for us to diagnose as well as to treat. So when you're talking about this progressive headache, always remember this SNOOP that I told you, the mnemonic, which is SNOOP, which is important to know the types of complicated or the red flags in headache. Those who have probably not remembered this, I'll show it again. SNOOP means if there are systemic symptoms, if there are secondary risk factors, if there are neurological features in the patient, if the headache onset is very sudden, if the patients are elderly, and if the headache is changed its nature from the previous nature, then one has to investigate this patient. So if you have any of one of these 5 features, one should investigate this patient. Don't leave these patients. So to take home, common headaches are rarely caused because of sinusitis, acidity, and refractory errors, which is a common belief. The most common headaches are primary, and amongst the primary, the most important causes of migraine and tension type of headache. Acute headache has number of causes. So when you are doubt, please investigate this patient. First headache is a headache which often require admission in ICU and thorough investigation because it is a dangerous kind of headache. If you have seen patients who have episodic headache and chronic headache, do not worry, they do not require investigation, but they require proper treatment. If the patient has taken analgesic for a very long period, overuse of analgesic is one of the very common cause of chronic headache, and headache which starts beyond the age of 50 years would require investigation. Don't neglect these kind of headaches. And lastly, remember this SNOOP, which can tell you what are the headaches where you have to investigate the patient. Thank you very much. I would stop here and I would take if there are any questions. Thank you very much.
He has emphasized that how much important it is to differentiate the etiology of headaches to manage it properly. So now the platform is open for questions from audience, and question and answer should be question should be typed in the question and answer section box, and I will ask them on your behalf. So the first question is, a known case of migraine vascular headache developing daily patient developing daily headaches for 3 to 4 weeks. Should I evaluate or pass on the migraine as migraine?
So as I said, there are certain migraines which can get transformed from episodic phenomenon to a chronic phenomenon when it is called as transform migraine or chronic daily migraine. So the first thing that one has to look in these patients is see whether they are overusing analgesics or whether there is any stressor which has brought on this headache. Of course, I would start treating these patients with the standard migraine prophylactic medication. In the chronic phenomenon, normally the 2 drugs which are preferred by us are amitriptyline and topiramate.
Thank you, sir. Second question, when to suspect cortical sinus venous thrombosis clinically?
So then it's a different disorder compared to the headaches that are described, because these are the patients who may present with headaches. They may also have sometimes seizures or fits, and they may get sometimes focal weakness. So there can be a weakness additional as well in these patients. So if patient presents with an acute onset of headache, which is a progressive headache, and it is also associated with other symptoms like vomiting, like visual symptoms or weakness or seizures, then one would suspect cortical venous thrombosis. Of course, the classic situation is in a lady who has just delivered or she's taking oral contraception for a long period. Those are the scenarios where we'll suspect this disorder.
Thank you, sir. Another question. Can we use novel anticoagulants like dabigatran or rivaroxaban to treat CVT, or still prefer warfarin?
Again, there is no robust data of use of these drugs in patients of CVT. Still the drug that we use are warfarin. But then there were 2 trials done with rivaroxaban and dabigatran. The trial with dabigatran showed that it was as good as warfarin, if not better. And the trial of rivaroxaban was a smaller trial. So my take is we always use warfarin as a first drug. But if there is an issue with warfarin, INR is not raising, or patient probably is not going to come for regular follow-up, you are not sure whether he is going to do INR from a very lab. So those are the sites where probably I would use the NOACs in these patients. Not in all cases. So NOACs is my second drug of choice, not first.
Thank you, sir. Another question is a subset of questions actually. First is, what is the best drug to treat acute attack of migraine? Second is, when will you start prophylactic therapy in migraine? And third, any non-weight gaining drug for a prophylaxis of migraine?
Okay. Again, three standard questions. First is, of course, any analgesic would suit patient. People would like to take any analgesic, whichever they like. We have patients who have been taking arketamine preparation. We tell them that let's try now this naproxen or maybe some other drug. Patient says, no, I would be benefited only by taking combiflam or maybe just with nimesulide or my arget preparation. So every patient will have a different choice with which their headache improve. There are some patients where headache would improve only with 650 milligram of paracetamol. So every patient will have a different choice. Neurologist choice is usually naproxen sodium, but of course, every patient can take a different drug. As far as prophylaxis is concerned, as I said, prophylaxis we would start if the patient is getting more than 2 headaches per month. So, someone who has one headache once every 4 months, you don't have to give prophylactic treatment. So prophylaxis, if the headaches are more than 2 per month, and of course, if he's visiting the doctor, that means he's definitely disabled. He or she would require treatment. And as far as weight is concerned, yes, it's a pertaining question because many of these drugs are used in younger people who are, weight cautious. And we know that cybelium or flunarizine and valproate are the drugs which can cause weight gain. But topiramate is a drug which can cause weight loss. So, if I get an obese patient, we always use topiramate, which can help for weight loss.
That's the last picture. So another question is, does Botox help in migraine headache?
Yes. So we use it in chronic migraine, not in the episodic kind of migraine. So if the migraine has become a daily headache, it is lasting for a very long period. We have tried the oral medication which have failed. So that's where we use botulism toxin. We inject the botulism toxin in the various muscles on the scalp. The dose is around 200 units, 195 to 200 units. So big dose. Patient would require to pay around 30 to 40,000. And then we have to repeat this injection after 3 months. So, it is not, of course, going to be the first line treatment. It's a costly therapy. But there are those disabled patients, who lose their office job. They can't go to office. They can't work. They're taking analgesic daily. They have to visit emergencies or doctors or injectables on a routine basis. Those are the ones where we use Botox, and botulism toxin does help in these people. So we use it in judiciously in selective patients.
So last question, do analgesics useful in trigeminal neuralgia, and what are the new modes of treatment?
So trigeminal neuralgia is never going to improve with analgesics. No point trying analgesics in these patients. Neuralgia would require different drugs, and the drugs used in neuralgia are anti-epileptics. The first group of drugs that we use is carbamazepine and oxcarbazepine, and the second group of drugs we use is gabapentinoids, which is gabapentin and pregabalin. So one of these 4 drugs probably one would use. Carbamazepine usually would be considered a drug of choice. We would also use gabapentin on a routine basis in these patients. So don't use analgesic in these people. They would require different treatment options.
Thanks, Dr. Kulkarni, once again. So now moving on to the next topic, headache psychiatric perspective. Just now, Dr. Kulkarni enriched our knowledge about neurological perspective of the headache, but we know many times they are related to stress, depression, or anxiety. So it's equally important to know about its psychiatric perspective. To learn about it, we have another Dr. Kulkarni, our own IMA member, Dr. Govind Kulkarni. Actually, I know Dr. Govind much more than what his biodata says. He is my best friend, and we were together in one class since 3rd standard till 12th standard. We studied together in 11th and 12th and went on to become doctors. In school days, he was best in mathematics and chess. Still, his love with them continuing though. Both require abstract thought process, and probably that's why he had selected psychiatry, as it also needs virtue of abstract thinking. That could be the reason for making very successful psychiatrist. Now coming towards more formal introduction, Dr. Govind Kulkarni has done MBBS, DPM, DNB, Psychiatry from Vijay Medical College and Maharashtra Institute of Mental Health, Pune. He stood first in Pune University in DPM examination. Since 1998, he is in clinical practice and had been teacher for CPS diploma in psychiatry. DCGI approved Dr. Govind as researcher for clinical drug trials, and till date, he has conducted 5 phase 3 and many phase 4 drug trials. He also has been secretary of Deccan Psychiatric Association and gets invited as speaker to many psychiatric conferences. His extra professional facet is he has represented Maharashtra state in national chess tournament. So Dr. Govind, please.
Young girl, 17 years of age, referred to me by a neurologist, presented with complaint of headache since last 1 month. Headache was continuous with episodic exacerbation and her sleep was disturbed. There was no history suggestive of any organic etiology like head injury, convulsions, fever, loss of balance, loss of power, vomiting, or any history suggestive of possibility of migraine. There was no aura. No past history of similar complaints, no family history of psychiatric illness or headache. No specific event in the family which could be identified by relatives as a possible stressor. Prior to being referred to me, she was admitted under a neurologist. Her investigations were normal: CBC, liver functions, renal functions, electrolytes, thyroid, blood sugar, MRI brain. Her ophthalmological evaluation and ENT evaluation was also normal. CSF study normal. Even autoimmune disorder workup was normal. But the pain wasn't responding to analgesics. Refer to psychiatrist. How to approach? Well, this is my topic for the day: headache psychiatric perspective. Now, having said that, I will be speaking about the patients who come to OPD with complaint of headache and how we could approach these patients. Before we go ahead, I would like to tell something about the historical considerations. The relationship between headache and psychological problems. The relationship has been discussed far more, but relatively less studied systematically. In 19th century, Sigmund Freud, the father of psychoanalysis, associated concept of psychopathology to migraine. The post-Freudians continued with this concept till 1930. Between 1930 and 1940, Harold Wolff and his team systematically studied recurrent headaches and associated psychopathology. In fact, this was the team who put forth the possibility of vascular etiology to migraine. They in fact coined the term called migraine personality as well. Subsequently, a lot of work was done, and what was observed was specific personality factors associated with chronic headaches were not consistent. Some studies could associate these personality factors to migraine, and some failed to replicate. However, one thing was consistently observed, that there is definite association between certain psychiatric illnesses, certain psychiatric disorders, and chronic recurrent headaches. So this was a consistent finding across the studies. Now here's the list of psychological disorders which have been reported to have some kind of association with headaches. There's depression, panic, separation anxiety, bipolar, and many other disorders. Now the question here is, which of these disorders have more significant association with headaches, and how is this association? So firstly, let us see how could this association be. What is the possible relation? Here what I have done is I have changed the term psychological disorders to psychological phenomena. Now this is because, let us assume something like anxiety. Now anxiety can be a symptom, anxiety can be a syndrome, and anxiety can be a disorder as well. Now all these may have relation with headaches. So I have clubbed these three things together in psychological phenomena, and I'm talking about relation between headache and all these psychological phenomena. So what could that relation be? Firstly, it can be headache caused by psychological phenomena. So headache directly associated, directly related to psychological phenomena. Second possibility is there is already headache due to some cause which gets increased because of psychological phenomena. And the third possibility is headache itself can lead to certain psychological phenomena. Now, which are the disorders which may have more significant association with headache or headache as a presenting complaint? For this, we need to quickly go through the decision-making tree, diagnostic decision-making tree we follow in psychiatry. Now, this is what we follow. The first time patient walks in my OPD, the first question I need to ask myself is whether the patient has a problem or not. Now, technically, this sounds a stupid question, isn't it? The patient has walked in your OPD, so must be having a problem. But trust me, this is not a case when it's a psychiatric OPD. we get to see certain patients who have a problem and they are out to prove that they don't have a problem. In fact, many of them ask for a certificate of psychological fitness or a fitness stating that they don't have a psychological problem. That's one end. And on the other end, there could be a person who doesn't have a problem, doesn't have a psychological problem, but wants a certificate of psychological illness just to get some benefits out of that. Now, we must know that there are certain benefits of having psychological illnesses in terms of supposing the patient doesn't want to face the court of law, so fitness to stand the trial, you may need a psychiatric certificate. There could be certain, reduction in the punishment after a crime if the patient has got psychological illness and the crime has been done under influence of that psychological illness, so which is called as a diminished criminal responsibility. There can be some fitness related issues for the workplace and so many. So in psychiatry, we have to start here, whether the patient has got a problem or not. Assuming yes, the patient has got a problem, we can go ahead. The second important question which is asked is the problem due to organic cause? Now there are a whole lot of disorders which are medical and they present as psychological problem. For example, hypothyroidism, head injury, and a presenting complaint can be psychological. Now in this case, this lands up in liaison psychiatry. Psychiatrists may or may not be involved in the treatment of the case, but then it's a team of doctors which is treating it. So that is not pure psychiatry case in that case. So assuming the answer to this question is no, so now the patient is going to be under a psychiatrist. Now this is about reality testing. Reality testing in a very broad term is being fully aware of the surrounding and the things happening around. Now if the reality testing is impaired, then the patient lands up with a psychotic illness, and if the reality testing is intact, then we call this as neurotic disorders. Now, the neurotic disorders are the disorders which are more likely to be associated with headaches. Of course, there's an exception which I'll tell at the end of my presentation. Let us get back to the case where we started. This is the same case. I'll run through this. Everything normal, everything normal. Now, this appears to be the end of the road, isn't it? Because all investigations normal, but we are unable to give any kind of results to this girl. So what could this be? Whenever there is end of the road, what we should do is go back to the basics. So going back to the basic means what we'll have to do is get into detailed history from relatives and the patient. Relatives should be significant relatives and reliable relatives. Physical examination including CNS examination already done in this case by neurologist, and detailed mental status examination. So 1 and 3 I had to redo. The mask 1994, but this images of mask 2020, isn't it? COVID-19 started with masks 2020. Now I don't mean mask 1994. This is not. This is mask 2020. I'll show you what is mask 1994. This is mask 1994. This was a movie, The Mask, starring Jim Carrey. Now, in this movie, he played a superhero. He would be a superhero when he was wearing this mask. Behind the mask, he played a timid bank clerk who did not have any courage. But after wearing this mask, he was like he was a superhero. So what I mean to say here is, many a times patients come to us with complaints. Headache could be one such complaint, where it's like a mask. We need to go and check what's behind the mask. Behind the mask, that could be entirely different disorder. And how the disorders differ behind the mask of headache, that's what I'm going to highlight today. Coming to this case, I revisited the history. What was understood was this girl, patient, had a good childhood friend. That another girl was staying in vicinity, and both of these girls would meet together almost daily. Either of them would visit the other's home. In last 5 or 6 weeks, the schedule had got distorted. 4 weeks because of her illness and 2 weeks prior. What had happened was the other girl, who was a friend, had an old grandmother who died about 2 weeks prior to this symptom onset. So last 6 weeks, the schedule was distorted. Now this old lady was a nice old lady, was in one of the significant others for our patient. She was very much emotionally attached to that old lady. And this old lady was suffering from some kind of brain tumor and would have intense headache in her last days, bouts of intense headache, which this girl had witnessed, and she was quite upset about it. Now she was probably identifying with that old lady, and possibly this could be a kind of grief reaction. Now this was a possibility I needed to explore. So I just did that. I encouraged her to speak about her experiences, her memories of that old lady, and that worked. So we initiated professional grief counseling with a counselor, and I prescribed certain anxiolytics, low dose anxiolytics, and that grief counseling. Grief counseling is a specialized kind of psychotherapy. This all worked, and finally, this young girl was free from headache. Now, in this case, what was observed was headache was the mask, underlying headache was grief reaction. Let's go to the second case. This is case of 20 years old unmarried female, a student. She presented with complaint of headache in last 6 months. Headache almost daily for about 15 to 20 days a month, and her sleep was disturbed. Interestingly, she would at times get up and start having headache. So early morning, after getting up, the headache would start. The headache was felt as a tight band pressing around forehead and neck. It would start around neck and then move on and encircle the head completely. It was in the temporal region, both the sides, dull pain all the day. Occasionally, she would have nausea, but nausea wasn't a consistent association. Frequency and intensity was noticed to be more when she was stressed, particularly when facing like exams or preparing for the exams. The headache would be more, it would be worse, and duration would also increase. It would get temporarily relieved by analgesics, but after the effect was gone, the headache would return. Now, how do we analyze this? The headache was bilateral, unlike unilateral in case of migraine. There was dull pain, which was qualitatively little different than one has in migraine. It was felt as tight band around neck and head. It was worsened by stress, and there were no symptoms suggestive of aura, which was all in favor of tension type headache. Now, in tension type headache, we can have two different categories or two different presentations. One is episodic tension type headache, which we can say could be the earlier when it starts, probably it could be episodic. It's less than 15 days a month. Then early morning headaches are not there. After immediately after waking up, they are not there. The duration is lesser. And chronic tension type headache, which is called as CTTH. This case was of CTTH. In fact, in these patients, the paining area can be actually tender. So, just to go ahead with tension type of headaches, how do they happen? Now, this word tension has nothing to do with psychological tension. The term tension we use in terms of psychology. It's not that. It's about tension in the muscles. Now, these brown ones, I tried to draw an animation for this. The brown ones are the muscle fibers, and the red one is a blood vessel, and the flashing arrow indicates the blood flow through the blood vessel. Now, what happens is when the tension in the muscles increases, the muscles will start pressing the artery, which is pressing the vessel which is going through them, the muscle fibers. And as a result of that, there will be some vasoconstriction because of mechanical obstruction. It's not vasoconstriction because of the muscles in the artery wall getting contracted. It's external pressure on the vessel, and that leads to reduction of blood supply. Now, if this tension in the muscle builds over a period of hours, it goes on for longer duration, this may happen. This may result in temporary ischemic changes, and probably that's how it's even symptomatically different than migraine. In migraine, the headache phase corresponds to vasodilatation, whereas in tension headache, the headache phase corresponds to constriction of vessel due to mechanical pressure. Of course, this is one of the theories. Vascular theory is not the only theory explaining migraine. Now they are actually integrating lot of neuronal theories into that, and still it's ongoing. Dr. Rahul spoke about it. He's a better judge on that. So, but this is how it differs slightly in terms of quality and location. How do we approach? Symptoms relief can be achieved by anxiolytics and muscle relaxants. Now, anxiolytic, this term I'll be using a few times in my presentation. The best anxiolytic is alprazolam. Let me tell you very clearly, and I believe it's quite popular also. Many of us are using alprazolam. We psychiatrists recommend that we should not be using alprazolam. I mean to say, you should be using alprazolam if you are able to take the patient out of alprazolam. Quite often it happens that a doctor prescribes alprazolam to the patient and the patient keeps on taking it. Now, unfortunately, availability of alprazolam should not be OTC as per the law, but many patients in many places get it OTC and they just keep on taking it. And we induce an iatrogenic diagnosis of benzodiazepine dependence into the patient. So I always say that alprazolam using is like chakravyuha. You can enter the chakravyuha, assuming you know how to get out of it. So use alprazolam if at all you know how to take the patient out of alprazolam. Then what do I recommend? I recommend intermediate acting or long acting benzodiazepines. Now the long acting ones are the safest because they have the least addiction potential. So they have because they are benzodiazepines, but the least is with long acting. The long acting agents are chlordiazepoxide and diazepam. The intermediate acting you can say are clonazepam, nitrazepam and lorazepam. Again, nitrazepam has got reasonable addiction potential. Shorter the half-life, higher the addiction potential, that you can remember. So clonazepam is intermediate acting, fairly good drug from all perspectives, a nice sedative, nice hypnotic, nice muscle relaxant as well. A very good drug should be used. Or if you want to play very safe, go for age-old diazepam or chlordiazepoxide. Muscle relaxants can also help these patients. If there is associated anxiety, depression, can use antidepressants, SSRI, selective serotonin reuptake inhibitor, or tricyclics can be good drugs to use. Yoga, biofeedback, particularly EMG biofeedback works in these cases, and counseling, which treats the underlying anxiety, underlying stress, so that helps. Yoga also helps because that's a change in lifestyle, takes care of lot of stress. Move on to third case. It's 34 years old female, married, working as a clerk on temporary basis. She presented with complaints of headache, dizziness, backache, calf pain, intermittent pain in abdomen, weakness, body ache, intermittent nausea, vomiting since last 7 to 8 years. So many places and all pain, only pain. The illness was continuous, sleep was disturbed, frequent work absentees. There was again no history suggestive of any organic cause for her symptoms. She had been evaluated by multiple doctors. In fact, she had this bunch of files. She was insisting me to go through each file very carefully. No investigation showed significant pathology to explain even few of her symptoms. Forget about all the symptoms. Not even a few were explainable. She kept on saying that no doctor had been able to treat her. She was not diagnosed. She suggested that I should have some new investigation. I should search for new investigation to diagnose her. She had changed her doctors quite frequently. There was a lot of doctor shopping because she wouldn't stick to any doctor. Throughout the interview, she had focused only on symptoms. Her symptom list would not just end. You allow her to speak, she would speak about a new symptom every time. On examination, there were no signs supporting her symptoms. General examination and systemic examination were fairly normal. She had been extensively investigated. Actually, even in last week, prior week, when she came to me, she was well investigated. A lot of investigations done repeatedly. So further investigations were not needed. Now, how do we analyze this case? This case had multiple symptoms, multiple systems, respiratory system, musculoskeletal system, many, all systems involved, sort of. Not having adequate medical explanation. So multiple symptoms, not having adequate medical explanation. And the focus was on symptoms. This line is very important. Why? I'll tell you later. The focus was on symptoms. Insistence on further investigations, and there was abnormal illness behavior. Now, by abnormal illness behavior, what we mean is, if we are ill, we are given exemption from certain our day-to-day duties, and that's fair. But if you remain ill for a lot of time and year, you will get exemption for most of the time of the year. And that's what these AIB, abnormal illness behavior patients do. They just get rid of all the responsibilities, all the duties. And that's something she was doing. A female with symptom onset below 30s, chronic course more than 2 years, but interestingly, more or less stable symptoms. Now, remember, this lady had illness of 7 or 8 years, but no symptom had worsened. The symptom remained like it is. So there's no worsening in the symptoms. So the symptom profile remains stable. So that's very peculiar. This is a somatization disorder. Somatization disorder, females are likely to be affected more. It's a chronic course, usually more than 1 to 2 years. This lady had it 7 to 8 years. And it starts below age of 30, though you may see the patient in 40s because the illness is chronic. How to approach? These patients need a listening ear. They need somebody to listen to them. You have to view upon these symptoms as physical expression of their psychological distress. Unless you do that, the person who's listening to her will get irritated. So you have to assume that even if you are listening to physical symptoms, it's about psychological distress. So I encourage her to speak about her emotional aspects. Then it works a little better. Contracting and psychotherapy is important. Usually all kind of psychotherapy start with contracting. But here it is more important because these are the patients who do not get engaged into any kind of therapy because they change their therapist quite often. So this contracting is more important over here. Anxiolytics and antidepressants can help, have limited value. It's more to do with counseling, psychotherapy. But with all that, the symptoms may show partial remission. Complete remission may take a lot of time or may not be there. Even if the patient improves 70%, 80%, 90%, we should be happy. Coming to the next case, I got total 6 cases. This is the 4th case. This is of a 25 years old unmarried male. He was working as an engineer in a multinational company. He presented with complaint of headache since last 9 months. Headache almost daily, disturbed sleep, work absentees. No history again suggestive of any organic cause. He had consulted multiple doctors, had many reports of CT scans and MRIs. Headache had not responded to the treatment given. He was quite worried about some possible serious illness which could be causing headache. He said that headache was not very troublesome. He could tolerate headache. What was more distressing for him was the thought of possibility of serious illness like brain tumor underlying this headache. He said, doctor, I can tolerate this headache. Headache isn't a big deal. But what if I have brain tumor? I want to treat it early. And unfortunately, he felt that there was some illness, serious illness in head, which current investigations were failing to pick up. And so he felt that psychiatrist was a wrong person to handle this. He should have been to neurologist. In fact, he had been to neurologist and was referred by a neurologist only. So he had come. He was extremely upset about the serious illness issue and he wanted proper treatment on that possible serious illness as early as possible. Interestingly, some time ago, when he joined the same company, there was medical testing on the joining, which is usually there. And as a part of routine medical checkup, he was advised routine medical tests, routine blood tests. So at the time of taking out blood, he was to be pricked by a needle. And then he was almost convinced that he has had HIV because of that needle prick. And then also he had rushed to many doctors and this continued for a while. Subsequently, over a period of time with lot of HIV reports, he got convinced that he is not suffering from HIV. That's the history. Now analysis. This is a single symptom. It's a monosymptomatic entity, not having adequate medical explanation. But as compared to somatization, the difference here is the focus is not on symptoms. The focus is on underlying disease process. So the preoccupation is with the disease process, not with the symptom. Insistence on repeated investigation to know that disease is the characteristic of this disorder. This is hypochondriasis. How to go about it? Firstly, accept the concern. We should be accepting that, okay, I understand that you are concerned about having a serious illness. Let's see what we can do. You have to view here as symptoms as expression of his health anxiety. These are people who are extremely anxious about their health. Evaluation of comorbid anxiety, depression, and treatment of the same might just be needed. You have to look at possibility of anxiety, depression, treat that with medications, counseling, psychotherapy, whatever is needed. Cognitive behavioral therapy for this does help. Here, the behavioral therapist can utilize the past history. Actually, CBT therapist can utilize the past history. When he felt that he had HIV, he actually did not have HIV. That's something which can be used therapeutically over here. Now, this hypochondriasis male to female ratio is more or less equal. They do recover with good kind of cognitive behavioral therapy and some psychotropics. The fifth case is of a 34 years old male married executive in a company presented with complaint of headache, irritability since last 2 years. Continuous illness, the sleep was disturbed. Now, here is the difference. The prior cases had no specific event which could be having temporal association with the onset of pain. What I've tried to do here is, except for the last case, the sixth one, all these are anxiety disorders, but they differ from each other in a shade, and the presenting face, the mask of all these could be headache, but the underlying disorder differs, and how do we reach that underlying disorder, that I'm trying to highlight. Here, there was a car accident about 2 years ago, few days prior to onset of the headache. He has had a collision with another car, which was head-on collision. But then there was no history of unconsciousness, vomiting, or ear, nose bleeding after accident. But the rear view mirror inside the car hit his forehead and got a lacerated wound. Interestingly, his pain, his headache was located around the site of injury. CT scan done on the day of accident, he had no brain injury. He was treated with analgesic, pain persisted. Even a month after accident, the pain persisted. In fact, he noted that now he's getting more and more irritable. The change in medicines did not help. The change in doctor did not help. He got MRI brain done because now it was 1 month. So nothing, it was normal. At about 6 to 8 months after accident, he got frustrated. He thought, let me try alcohol. Let us see if alcohol gives me relief. So he tried alcohol. There was no pain relief. Pain persisted and his drinking frequency increased. So when I saw him at about 2 years from the accident, the pain was persistent around the injury site on forehead. There was no relief in symptoms by any analgesics. Some symptoms of anxiety and depression were definitely there now. And now the alcoholism had increased, amounting to harmful use. In alcohol, we use 3 terms. One is alcohol use, which is not a problem. Then harmful use or abuse. And the third is dependence, which is when we have to admit the patient. Even harmful use can be dangerous at times. CT scan, MRI brain done a few times were normal. Analyzing this case, this was a single pain symptom, only one pain, which was out of proportion of the injury sustained. Now, this out of proportionality can be in terms of intensity, can be in terms of duration. It was not relieved by conventional treatment. Comorbid anxiety, depression, and substance abuse was noted. This was somatoform pain disorder. Now, how do we treat this? We treat comorbid anxiety, depression, and substance abuse first. For alcohol, we use lorazepam or oxazepam because they are safe for liver. We get liver functions evaluated because alcohol is likely to have liver function impairment. We treat anxiety. Now, incidentally, if we use lorazepam or oxazepam, that takes care of anxiety as well. For depression, we can use selective serotonin reuptake inhibitors, or in such cases, actually, we can use SNRIs also, serotonin norepinephrine reuptake inhibitors like duloxetine, venlafaxine, desvenlafaxine, milnacipran can be of use. Antidepressants, this SNRI category is better for these patients. Anxiolytics, again, as I said, since it was alcohol here, I would prefer oxazepam or lorazepam. Psychotherapy helps. With this, the pain does reduce a bit. Coming to the last case of the day, this is different than the previous cases. This is of a psychotic spectrum case. 20-year-old male engineering student presented with complaint of headache. That's it. The patient had only one complaint, and that was headache since last 2 months, as reported by him. Relatives reported a completely different range of symptoms. The relatives said he's suspicious, he's behaving oddly, he doesn't sleep well, he's seen muttering to self, laughing to self, he's irritable, he's not studying. There was again no history of head injury, fever, seizures, unconsciousness, no past history or family history of similar complaints. There was history of failure in examination in the recent past. We don't know whether it was cause or effect of the illness. CT scan done by the relatives prior to reaching me was normal. On evaluation, what was noted was patient looked afraid. He was constantly looking around with suspicion. In fact, while the interview was going on, he twice went to the door, just tried to check if anybody is listening to us, tried peeping out of window a few times. He wasn't ready to trust me. He asked whether I was a headache expert. Then I said yes. Then he asked me, could I remove implants inside his brain? And I said, why do you want to remove implants? And he said, I have one which needs removal. He felt that there was a chip fitted inside his brain to control him. He felt that there is a group of persons spread all over the world. They operate from different countries. They have this inserted this chip because he's a special person. So they want to control him. And the chip is operated from multiple locations. When they want him to have pain, he has pain. So the key of the pain is with some other people. Even in fact, he felt that they can control his behavior also. When they want him to laugh, he laughs. When they want him to raise his right hand, he raises his right hand, or something like this. So his every action is controlled by these people. And he felt that so the removal of this chip was the only thing which could be done. And so he needed to go to a neurosurgeon to get that chip removed. Note, this was a young male, classical psychotic symptoms, delusion of persecution, somatic passivity sensation, bizarre delusion. Quite a few of them are Schneiderian first track symptoms, which are very prototype of schizophrenia. So this young boy was suffering from paranoid schizophrenia. Now, firstly, we need to have very effective communication skill to engage these patients in treatment, because they don't trust anybody. They don't trust their treating doctors as well. But we need somebody whom this person trusts. So if I'm the treating doctor and if I get into his trust, then it's simple or easier to treat. We have to give him antipsychotics, something like second generation antipsychotics, risperidone, olanzapine are good. But for these overtly or floridly psychotic patients, at times we need first generation antipsychotic. They are still useful. Something like haloperidol still works, still needed in clinical practice, despite all the side effects it has got. If we use haloperidol, we need to use anticholinergics. We can use benzodiazepines for activity control as well. If required, we need to give modified electroconvulsive therapy for this patient, which is electroconvulsive therapy with use of anesthesia, general anesthesia, propofol or pentothal sodium with succinylcholine. Now, the other part which I said initially, about which I won't be speaking today, is depression, panic, separation, anxiety, bipolar, insomnia, adjustment disorder, substance, dementia, ADHD, conversion, schizoaffective personality disorders, phobias, and OCDs. Many of these have headache as a symptom, not all throughout, and may not be prominent, but it can usually accompany many of these disorders. But we did not speak about that. Neither we spoke about headache causing a few of anxiety depressive disorders. So we come to the end of the presentation, the take home message. Let me change the background before the take home. This is better. So certain psychological illnesses may present with headache being the most prominent complaint. Many psychological illnesses may have headache as one of the complaint, though it may not be the main or prominent complaint. Headache may be the presenting phase. This is very important. Headache may be the presenting phase of underlying psychological illness. We need to go behind the face. We need to know what is behind the face. That's most important. Chronic headaches may lead to secondary anxiety depression, which may warrant attention and treatment. Treatment with anxiolytics, antidepressants, and psychotherapy does help in chronic headaches if used judiciously. So we may have to treat headache patients with anxiolytics, antidepressants, and psychotherapy. And that's it. I thank you all. I thank President and Secretary of IMA Sangli. I thank Scientific Committee of IMA Sangli for giving me an opportunity to talk to you. I'm stopping my screen share now. I will be here for answering if there are any questions. Thank you so much.
There are a lot of questions actually. You have given a different aspect about headache, and so now the platform is open for question and answers. I have received a few questions. I will go one by one. You mentioned about benzodiazepines having addiction potential. Are there any other options to treat anxiety other than benzodiazepines?
Right. Benzodiazepines are supposed to be very good anxiolytics. They are very effective. But all of them have addiction potential to more or less extent. Now, the other options which can be used without probable addiction potential, one is a sigma receptor agonist named opipramole. Opipramole is available. It's in formulation of 50 mg tablets, and you can use. You can start with 50 mg BD and go up to 300 mg a day. That's a very effective anxiolytic and sort of general purpose anxiolytic. Irrespective of any kind of anxiety disorder, you can use it. It's been studied in GAD. In fact, that was one of the phase 3 trials I conducted. I think it was in 2010. That's one option. Second option is we have a non-sedative benzodiazepine. It's a strange entity, right? Benzodiazepines are usually sedative, but there is a benzodiazepine named topizopam. There's a family of benzodiazepines which are non-sedative benzodiazepines. These are called as 2,3 benzodiazepines. They act in a different channel than other conventional benzodiazepines. So that's a family of topizopam, nerisopam, and girisopam, out of which topizopam is available in India. So that's option number 2. And a third option I would suggest is bispiron. Bispiron is another anxiolytic which is available in 5 mg tablets. You can start with 5 mg, 1 tablet TID, and it's completely different from benzodiazepines in terms of side effects. So that's another effective anxiolytic. So these are 3 options. Occasionally, you can use very low dose antipsychotics if the anxiety is reaching psychotic proportion. So these are the options which are non-habit forming. We can use some low dose antidepressants as anxiolytics. So these many options are there as anxiolytics in addition to benzodiazepines.
Yeah. Another interesting question. Are these patients really having headache or they are maligning? Ask this because in all of these reports are normal.
Right. The reports are normal. This is a very interesting question. Even we get a consultation, I get a consultation of convergent disorder. Usually the relatives or even a few of treating doctors, they feel that patient is acting, patient doesn't have symptoms. But these are the patients who actually genuinely have symptoms. Like the cases particularly the first 5 cases were all neurotic spectrum cases. They do have symptoms. They feel the symptom. The symptom is real for them. The last case which I spoke about was psychotic. In fact, that boy also had headache, but he was misinterpreting the cause of the headache. So in all these patients, the headache is actually real. Now, there are other entities like this somatoform patients, they do feel the symptom, whether it is chest pain, whether it's pain in abdomen, whether this is conversion amnesia or seizures because of pseudo seizures, they all feel that symptom. Now, beyond that, coming to symptom genuinity, there are two more entities. The next one is in lesser symptom genuinity, factitious disorders. In factitious disorders also, they create symptom. And the last category is malingering, where they actually do not have the symptom. Now, this last two categories, the first category where they have genuine symptom, they do get illness benefit. That is something which is called as secondary gain. But the primary gain they have is because of symptom, they feel a relief from the basic psychological stress. So that is primary gain, getting rid of the psychological stress. And coming to the secondary gain, yes, they do have secondary gain. They get relieved from their responsibilities. But in malingering, there is no, the primary gain itself is getting rid of responsibility. So these are the patients coming to the question. Yes, these are the patients that they really feel that pain. That pain is there.
But then how to treat the patients who are coming with psychosomatic disorder, presenting with headache?
Yes, these were the cases who come as psychosomatic disorders and presenting with headache. In somatization, as I said, it's not only headache, there are multiple aches and pains. If it is only headache, then it can be somatoform pain disorder or it can be hypochondriasis. So you need to go beyond the symptom and try to analyze the patient's perspective about the illness. So that is very important here.
Yeah. Another question. What are the commonest causes of functional headaches? How will you suspect functional headache? And will you evaluate before labeling it as a functional?
Right. Firstly, evaluation before labeling it functional is extremely important, because these somatoform disorder or psychosomatic disorders, what has been observed is, if we study these disorders or these patients beyond 5 years, at the end of 5 years, 30% of them turn out to have a medical cause which could explain their initial presentation. So there is a high chance of possible non-functional organic cause behind their complaint. So before labeling anything functional, we need to be extremely sure. That's why I showed the diagnostic decision making tree in the psychiatry. So evaluation is important. Now, assuming the problems, the evaluation does not suggest any problem, or evaluation suggests some problems which is completely out of proportion with the symptom profile, then we have to think about psychosomatic illnesses. So psychosomatics are is a very common chunk nowadays.
Right. Another question: headaches without any organic cause and not responding to any treatment, how to manage?
Right. The cases I reported were all in the same category: headaches without any organic cause. Again, when we have no option, as I said, end of the road, you have to go back to the basics. We are missing something. So go back to the history, go back to the mental status examination, and most importantly, go back to the patient's explanation about his own illness. You know, every patient has got his own explanation, whether it be a medical case, whether it be a psychological case. They do have their own explanation about their illness. It's worth, getting into that, worth knowing their own explanation. We never get time to go to that level. Knowing, you can ask the patient, what do you think? What do you have? So many a times you'll find the answer there. You need to know patient's perspective about his or her own illness. That works quite often. You get at least some clue. So then you evaluate, and then further probing could give you a direction.
Yeah, thanks, Dr. Govind. Presentation and nice discussion. Dr. Manohar Inamdar has done MBBS in 1974 from Government Medical College, Biraj, and MD Medicine from the same college in 1979. He started practicing in Akluz district, Solapur, a very interior part of the Maharashtra, in 1980, where even lead ACG was not possible that time. And now he is doing almost 60% of the practice in cardiology in both OPD as well as IPDs. He developed cardiac care in rural hospitals since 36 years and now has good 46 beds ICU with color Doppler unit, ABP, Holter monitor, and even MRI and CT scan. He established cardiac cath lab since November 2004 and has performed personally more than 15,000 procedures, including coronary angio, pacemakers, IVC filters, and about 7,000 angioplasties, including 2,000 PAMI. He established cardiac OT as well and coordinated number of open heart surgeries. He is a regular speaker at national and international conferences on the subject of critical care in the rural area and received prestigious IMA Maharashtra State Selfless Service to Rural India Award in Mastekon 2005. He has been president for Akluza IMA 3 times and received IMA Solapur late Dr. B.B. Mule Oration Award 2010-2011. He has received prestigious Parkar Foundation's Lifetime Achievement Award in 2010 and received Achievers Award in Mapicon in 2019. So he has also received He has received fellowship of American College of Cardiology, received fellowship of the Society for Cardiovascular Angiography and Interventions, received fellowship of Indian Society of Cardiology, received fellowship of Euro-Asian Academy of Cardiology. He has been life member of Cardiological Society of India, CSI, and he has been life member of Academy of Echocardiography as well. Also, he has done a lot of social service to rural India. In COVID pandemic, he initiated COVID community center as well and treated almost 1,600 patients with 90% recovery. He's a mentor for many, has a passion for flying and owns an aeroplane too. So now I request Dr. Inamdar to deliver both the lectures.
So I'll start again. Definition and types of chest pain. Generally dull aching but occasionally sharp shooting pain causing discomfort to the patients. It may be heaviness or tight compressive sensation in the chest. There may be radiation to the jaw, left side or right side of jaw and to the right or left arm. It may be sharp and repetitive. It may be retrosternal burning. It may have change in intensity during respiration. It may be severe tearing or ripping type of pain. It may be variable. It may be variable according to emotional situation of the patients. So evaluation of the chest pain, this I have already talked. So there are pitfalls where you can, in your primary physician's consulting, you may get little wrong information on the patient's this and you may do it wrong. So for the correct diagnosis, there are some pitfalls which I will tell you. At a primary physician level, most commonly misunderstood conditions are reflux esophagitis for coronary artery disease or coronary artery disease for reflux esophagitis, vice versa. Sometimes patient can get referred pain in chest from abdominal conditions like cholecystitis and appendicitis. I have seen many patients diagnosed after angiography, which is normal, and then diagnosed as a reflux esophagitis, or endoscopy is done, everything is normal, and then ECG is taken, which shows there are STT changes and there are enzymes are elevated and patient has chest pain. So it is commonly misunderstood. And simultaneously, many abdominal conditions like acute cholecystitis, appendicitis can sometimes get a referred pain. The rare occasions proper diagnosis of reflux esophagitis is done very, very late. Anterior wall changes in ECG are very common in normal female. That is one thing very usual. In our day-to-day practice, if you see a normal ECG of a normal female patient, it may be showing anterior wall changes and they should be always kept in mind. And further investigations will be limited if you consider this fact. Don'ts in chest pain. As a primary physician or general practitioner, you must take care of some important things. When a patient comes to your clinic, first see his general condition. Any associated symptoms like diaphoresis, restlessness, difficulty in lying down, this mimics that it is, or this indicates that it is a severe condition and you have to act very fast. Always see pulses of our fold ribs. That will rule out many conditions. Means if you do a dorsalis pedis examination or palpation of a dorsalis pedis and tibialis posterior, many conditions will be ruled out, like dissecting aneurysm. Don't start treatment before you come to some conclusion. Every doctor should have an ECG machine in his clinic. Now tele-reporting is very, very common, very, very easy. Even on WhatsApp, you can send the ECG and you can get an important message within a minute or so. So you can come to a conclusion very fast. please never give injections or any medications before you explain to the patients. I have seen in my practice many times, patient goes to general practitioner, patient without seeing anything, chest pain, patient gives, doctor gives some injection of diclofenac or some other analgesic, patient gets ventricular fibrillation simultaneously, not because of injection, but it's a part of myocardial infarction. And always relations tell that this is because of your injections, and then the problem starts. All medical legal, at least in my 40 years of practice, I must have seen 15 to 20 patients coming like this with a hurry. And that's why it's very important that you should, before giving any medication or injections, you should always think of further complications. And that's why I explain everything. If patient complains of chest pain, see pulses for longer time, for 1 minute, at least for 1 minute, so that arrhythmia can be ruled out. If there is a multiple chest pain with multiple arrhythmias, multiple ventricular ectopics, you have a clue that this patient has a myocardial infarction. If you have ECG machine, then immediately take a ECG and diagnose the condition. There are many ECG machines which give report, ready report, but please don't rely upon that, because that's so many times because of earthing problems or because of many other problems, the reports are not correct and you may do a mistake there. I had seen one patient who was sent to me for acute ventricular tachycardia because of not properly fitting the wires. Patient had a earthing problems and patient had a Bazari picture, and that's why he was actually, patient was absolutely normal. So proper diagnosis by doing ECG and sending it to your friend physician and getting it diagnosed is a very easy but very important thing. If ECG diagnosis is confirmed that patient has a myocardial infarction, then before sending this patient to physician or some nearby hospital, you can give LMWH after telling the patient that this is very important drug. This has nothing to do with chest pain or this, but this will dissolve the clot. And you can give LMWH or unfractionated heparin 5000 intramuscular or IV till patient reaches to a hospital. Please select the hospital where some good facilities are available, like cath lab facilities are available, because so many times time is money. And if you get these patients very early in a hospital where all facilities are available, patient's life can be saved very easily. And if delay is there, then patients come in a problem. And then everybody says that this should have been done, this should have been done, patient should have taken to cath lab immediately. So instead of that, you should send it a patient nearby where every facility is available. Always explain the relatives about risk of ventricular fibrillation or arrest, because that is a myocardial infarction. If you get an ectopics on 1 minute pulse examination, then you are sure that patient may get ventricular tachycardia, ventricular fibrillation. So after doing all this, I will come to a etiology of chest pain. What are all causes of chest pain? Coronary causes and non-coronary causes. Coronary causes, acute myocardial infarction, that way is almost 40%, but stable angina, unstable angina, crescendo angina is almost constitute to 60% of patients. And these conditions where patients usually ignore the things, and then the disease worsens and patient so many times come in acute myocardial infarction. Non-cardiac conditions, it may be aortic stenosis, aortic dissection, pericarditis, pulmonary embolism, pulmonary hypertension, pneumonitis, pleuritis, esophageal reflux esophagitis, sometimes esophageal spasm. Sometimes it may be in Mallory syndrome, forceful vomiting, and the lower esophageal sphincter is torn, and that's why patient gets some severe retrosternal burn. Patient may get peptic ulcer pain, and it may be referred to upper abdomen. Gallbladder disease, as I told, that cholecystitis can cause this, or a musculoskeletal disease. Patient has intercostal myalgia, patient has some fractured rib, patient has some spontaneous fracture of vertebrae, and patient can get a shooting pain. Herpes zoster is one more condition where you can miss so many times the diagnosis. Everything is done because pain starts 2-3 days prior to eruptions. and then afterwards eruptions come. So before eruptions, everybody is misled. If it is a intercostal myalgia on the left side, then usually it is diagnosed for myocardial infarction. So that should be kept in mind. And so many times a functional cause, that means a female of a young age coming in the evening with a chest pain, hyperventilation, you surely know that this is an hyperventilation syndrome and anxiety. This is usually because there is some tension in the family. Whole day husband is not there. Patient accumulates all symptoms, and when husband comes, the symptom starts, or a malingering starts, or the hyperventilation starts, and then patient is brought in a hurry with an dire emergency. But actually this is a functional case. So characteristics of ischemic cardiac pain, if you see, it's a characteristics of the pain, site of the pain, radiation of the pain, provocation of the pain, onset of pain, and associated features. They are very important to diagnose an myocardial infarction or a coronary artery disease. So usually characteristics of pain is dull, constricting, choking, and heavy. Squeezing, crushing, burning, or aching also is there. So many times it is to a particular site, but sometimes it is all over the chest. Patient can get breathlessness because of transient left ventricular failure, and patient also may get a discomfort more than a pain. So site of the pain usually it is at the chest, or it is to the neck and left side of the left hand or left arm. This is almost in 75 to 80% of cases, but sometimes it may be, site may be misleading. The derivation of the nerve supply to the heart and the mediastinum is from T1 to T5. So you can get pain to the neck region, pain to the right arm, pain to the left arm, pain in the center of the chest, sometimes backache. As I told that patient, the pain radiates to jaw, upper arms, left mostly, sometimes right. Occasionally the site may be back or upper abdomen, and it can mimic cholecystitis or acid peptide disease, which is actually so many times misleading one. Provocation of pain, angina pain during exertion and promptly relieved by rest. Pain may be exacerbated by emotions or a large meal. If patient takes a large meal, the deviation of blood supply to the stomach causes a relative deprivation of blood supply to the heart, and patient gets in postprandial angina. Crescendo type of angina, similar pain can be precipitated by exertional exertion, and patient can get pain again and again. Decubitus angina, so many times patient is at rest, lies down, gets a venous return, preload is more, and then patient can go into an ischemic pain. Onset of myocardial infarction, pain of myocardial infarction takes several minutes to or more to develop, but sometimes. Hello, can you hear me? Hello? Hello,
yes,
can you hear me?
Yes, sir.
So it's a longer duration of this. Sometimes it comes in a minute. Sometimes it can be days together, and it is sometimes mistaken for some other pain. So angina pain builds up gradually in proportion to the intensity of exertion or emotion. It is intermittent at times, and sometimes it may be non-repetitive, or reproducibility is not there. Can get aggravated by physical or psychological unrest. Sometimes with a viral fever, it can get aggravated. Associated features are autonomic disturbance. Patient has severe myocardial infarction. Sweating, nausea, vomiting, occasionally confused state, or unconsciousness if the patient has right ventricular infarct or RCA block. Breathlessness, pulmonary congestion from a transient ischemic left ventricular dysfunction may be there. Patient may go into a transient LVF, and the patient has to lie on a proper position. So management at primary level. After this, I'm dealing with because most of the audience will be in general practitioners, and for them what is very important is absolutely required till patient reaches to a bigger hospital. After confirmation with the diagnosis, expedite the thing. Nasal O2 should be applied from 2 to 5 liters per minute flow. If you feel arrhythmia is a major issue, then you can give 2% of the Halocan intramuscularly or IV without adrenaline, of course, and so that patient's arrhythmia temporarily can be relieved. You can give up to 5 cc intramuscularly if the arrhythmia is very severe. But everything after explanation that this is an assisted treatment for myocardial infarction till patient reaches to a hospital. Give LMWH 0.6 milligrams or 5,000 units of unfractionated heparin, IV or intramuscularly. If patient is hemodynamically unstable, put an IV saline, normal saline, give 30 to 50 ml per hour drip, and you may infuse sometimes in a larger way, for example, in a fast 100 ml or 150 ml per hour. If there is an infemoral infarct and patient is in a shock, right ventricular infarct is there. Refer the patient to a higher center, preferably to a cath lab center. For example, if you send it to a primary, again to a physician, he will see it, he will thrombolize it. Patient may get a good thrombolysis, patient may not get good thrombolysis. Be a loss of cardiac muscle function, and then patient may go into a stunned myocardium or this. So it's better to get this patient to a cath lab center where early primary angioplasty can be done. This is very important. Last almost 10 years, we have hardly thrombolized many patients, except this COVID period, where if the COVID test comes positive, then we cannot take him in a cath lab, and that's why you have to thrombolize, and then after the test is negative, you have to take this patient to cath lab. So earlier the better. Primary angioplasty is a very good option for this. Attend the patient personally in ambulance. If patient is very agonic, you can go along with the oxygen cylinder, some injections along with him, so that it's always relate to the relations, and you can help him if patient arrests or goes into ventricular fibrillation by doing massage and resuscitation. You can help the ambulance people. So it's always duty of a primary physicians to reach this patient to hospital. So differential diagnosis of chest pain. Anxiety, I have put it up, emotional anxiety, because as I told that female patients, younger female patients, they get this type of symptoms, which are always fallacious, and you may come in put in a trap so that you can think that this is myocardial infarction, but it's not. So this is one of the most common differential diagnosis. And if the ECG is taken, female patients usually anteriorly there are severe depressions, and then again it is a misleading. Cardiac pain, then aortic chest pain, esophageal pain, lung and pleura causing pain, musculoskeletal muscles or ribs causing chest pain, neurological chest pain, spine and ribs causing chest pain. So anxiety and hyperventilation syndrome, this is most common most common in young females, usually evening time. Nowadays, because of this software engineers and this, they also come in a lot of so many times with anxiety and hyperventilation syndrome. Evening time, if they come, usually it is diagnosed, prima facie diagnosis of anxiety neurosis only. Common cause of atypical chest pain, no relation to exercise. It all of a sudden starts with their thought. It starts provocation of some thoughts can give provocation of this type of pain. Then some receiving bad news patients, female patients can get hyperventilation syndrome. Some patients coming in OPD repeatedly. For example, I treat this patient of hyperventilation syndrome with anxiolytics and beta blockers. Patient goes home again after 2 months, same condition. There is recurrence of pain, and in same conditions they can come. So you can diagnose easily that this is nothing to be worried. And ECG, if I tell, as I told you that if ECG changes are there, it is still more worrisome because you are in a fix, whether it is an organic or functional. High sensitivity troponin test will always help in this condition. Please take high sensitivity troponin and get it done. This will always help you. This most sensitive test, and if it is from myocardial infarction, it will usually on the rise. Treatment in small doses of beta blockers and anxiolytics is the treatment for anxiety hyperventilation syndrome. Non-coronary cardiac pain, second variety is myocarditis, pericarditis, mitral prolapse. Pain felt retrosternally to the left sternum or to the left or right shoulder. This is again, it mimics like a myocardial infarction, but it is because of myocarditis. Intensity varies with movement, phase of respiration. Sharp or catchy pain will be there on inspiration. Coughing or lying down, it will aggravate the pain. And it exactly mimics the pleuritis sometimes. And sometimes it can exactly mimic the myocardial infarction. Occasionally, history of prodromal viral illness is there. Patient has a viral fever and then goes into a pleuritis, and then pleurodynia is there, and patient gets some catchy pain. Diagnosis is made on echo and other lab tests. If there is a pleural or pericardial rub or collection, you can diagnose it at the earliest. Treatment depends upon etiology. Antibiotics and steroids will always help. Then one more very important condition is mitral prolapse. Patient has young patients coming with a chest pain, anxiety, palpitations. And these patients, if you see, there is a click on auscultation. And these patients, most of the time, have mitral prolapse. And this mitral prolapse can cause a little bit of tachycardia, and patients' symptoms are aggravated. Treatment will be a small dose of beta blockers along with anxiolytics. Aortic causes of chest pain. When I was a student, I was always thinking that this is a very, very rare condition and we will not get in our practice. But nowadays, every year I see about 8 to 10 patients of dissecting aneurysm and dissection of aorta, where it is again a catastrophic this. If you diagnose it early, if it is a limited dissection, then you can refer this patient to cardiac surgeon and patients can be saved. In my career up till now, I must have saved at least 10 patients with a proper diagnosis and early referral to a cardiac surgeon. Pain is severe, sharp, tearing or ripping type of pain, continuously this. Somebody is tearing your chest skin, pain is like this. Penetrating to the back, it is always abrupt in onset. Suddenly it happens. Patient coughs, patient does exercise, patient moves, patient lifts weight, and then it automatically or all of a sudden it starts. Pain follows path of dissection. As the dissection goes down, patient pain also will go down. Importance of palpating the dorsalis pedis and tibialis posteriorus is utmost. That's why I tell that when patient comes to you, you must always palpate the dorsalis pedis and tibialis posterior. This is a teaching of my teacher, who always sees the dorsalis pedis or tibialis posterior bilaterally and then neck vessels. On this first primary 1 minute diagnosis, 1 minute examination, you can come to almost many, you can rule out many conditions. In this condition, echo diagnosis or MR and cytoangiography is the standard diagnosis and you can diagnose it. Treatment is surgical, very expensive, mortality is very, very high. If aortic wall is involved, then you have to repair whole of the aorta till it has a dissection. And the cost may be replacement of aorta and wall. The cost may go up to 7 to 8 lakhs. And in many centers, it is not possible. So this is one of the conditions where if it is a stable one, not dissecting further, hemodynamically stable, you can still do some justice to the patients by sending him to a higher center. Then non-cardiac pain is esophageal pain. This is very, very common. Always patients comes by just a fear that they have myocardial infarction and myocardial infarction is so deadly. They have seen their relations and this. That's why they come in this. And there is retrosternal burn. Sometimes vomiting is there with a bloody stain. This patient starts to vomit forcefully, and there is a lower esophageal rupture is there. So that's called as Mallory-Weiss syndrome. There is a pressure pain, tightness, burning retrosternally, mimics angina very closely. Sometimes precipitated by exercise. Again, if you do exercise, it may be it may aggravate, and then you feel again it is angina pectoris. And sometimes relieved by nitrate because there is little vasodilatation and the flow, the bleeding is little less, and you may get relief with nitrates. And that's why again you can mislead saying that it is a myocardial infarction. Illicit history of chest pain, surprise posture, or eating or drinking, or esophageal reflex. If your patient is very alcoholic, has consumed very large quantity of alcohol, patient has eaten very spicy food, and then patient starts vomiting. He vomits 2-3 times normally, and then blood vomiting, and then that can cause, that is sure that patient has gone into Mallory-Weiss syndrome. If patient is chronic drunkard and patient has already symptoms of liver cirrhosis, then it's still more worse conditions, that if the Mallory-Weiss or the tear is in the esophageal varices, it may be very massive and sometimes catastrophic. Radius to the back so many times. Endoscopic diagnosis is must, absolutely. Once you feel that patient has a esophagitis or reflux esophagitis, put a scope. So a 2-minute procedure, you can come to a conclusion. Treatment depends upon severity. If it is very severe, then you may have to give, if the bleeding is there, you may have to stop it. Head elevation is always done. Soft bland diet is required. Cold milk also is a preferable. Proton pump inhibitors or H2 receptor blockers is a mainstay. Raft forming antacids are very important. So that will form a raft and it will heal. The wound will be healed properly. Pain originating from lungs or pleura. So the pulmonary infarct, pneumonia, tracheitis, pneumothorax, malignancy, pulmonary embolism, tuberculosis, this all can sometimes cause a chest pain. In their course, they can cause sometimes chest pain. And this is to be diagnosed very properly. Bronchospasm sometimes can cause a chest pain. It's a reversible airway obstruction. Exertional chest tightness is there. That is relieved by rest. Difficult to distinguish from ischemic tightness or ischemic chest pain so many times. Pneumonia, pleuritis, and pulmonary embolism, or the pleuritic pain. These are one of the very common chest pains you come across. So pain originating from lungs or pleura. Diagnosis of pulmonary embolism is a difficult one, but in this era of COVID, last 2-3 years, every physician is aware of this, or every physician always thinks of this. Previously, it was not at our back of mind, and you might have missed so many things. But nowadays, pulmonary embolism or DVT and causing pulmonary embolism is very, very common in this COVID era. History of leg pain is always there. On ECG, you can get very typical S1, Q3, T3 pattern, or sometimes you may get RBBB, or you may not get any symptoms. So 30%, almost 33%. 33% patients you can get S1, Q3, T3 pattern. ECG may be abnormal, like RBBB in 33% of patients, and even in massive infarction, 33% of ECGs will be normal. So you don't have to think that patient has severe shock, chest pain, and ECG is normal. So the pulmonary embolism is ruled out. No, you have to take bedside echo and immediately do an echo and find out that patient has pulmonary embolism or doesn't have pulmonary embolism. CT pulmonary angio is a gold standard investigations, and it can be detected very nicely. Urgent thrombolysis or sometimes mechanical crushing of the thrombus is required. So cardiologist's opinion is always required if it is pulmonary embolism. Thrombolysis is done with the tenecteplase, usually up to 0.5 milligram per kg body weight. 40 milligrams maximum dose you can give. But in some patients, if the thrombus load is very high, if all of the thrombus from the leg goes and sits in the main pulmonary artery, so it's like a saddle block, and there the 40 milligrams of tenecteplase may not be useful. With the taking risk of hemorrhage or bleeding, you have to give a second dose. I have given in 2 patients 80 milligrams of tenecteplase, and patients survived after good thrombolysis. So if the burden, clot burden is very much, you have to give higher doses of tenecteplase. Pain originating from lungs or again pleuritis and pneumonitis. This is radiological diagnosis is very important. Symptoms are more or less same, catching with respiration, sometimes coughing, sometimes talking, sometimes laughing, you get a pain, and that is pleuritic pain or a pneumotic pain. On clinical examination, definitely you can get diagnosis with breathing sounds and this. X-ray is a standard investigation, and CT thorax will add more information correctly. If bronchial breathing is there, you can definitely diagnose it clinically. Pathological diagnosis depends upon hemogram, sputum culture. So many times other secondary infection can be seen on a pathologically on this, and you can treat accordingly. Treatment again remains IV fluids, antibiotic, bronchodilators, mucolytes, antipyretics. But sometimes patient's condition may worsen, and you may have to put him on a non-invasive or invasive ventilator. It's a very vast topic, so I am covering it in a short this. So musculoskeletal pain, osteoarthritis, rib fracture or injury to the rib, costochondritis, intercostal myalgia or intercostal neuralgia, this can cause chest pain. Aching is related to respiration. If a deep inspiration is taken, patient gets more pain. Then usually it is in either pleuritis or a costochondritis. Vary with posture and movement of the upper body. If you move little bit on this side or that side, you can cause so much of pain. Usually it is either in the spine, or it is in the ribs, or it is in the intercostal muscles. Injuries related to everyday activities or a viral infection. So this can be precipitated with some injuries, or sometimes with a viral infection, you can get a precipitation of musculoskeletal pain, and you can have this type of pain. Sometimes secondaries in the ribs are more common, on the spine, that can cause severe pain during movements or respiration. Diagnosis with radiological investigation is very important, or ultrasonography you can find out. Treatment with analgesics, antipyretics, and proper cause of the treatment. Proper treatment of the cause is very, very important. So neuralgic pain, you know that prolapse intervertebral disc can sometimes cause thoracic, upper thoracic PIDs are very common sometimes. T12 prolapse also is very common. And that time you can get an shooting pain or radiating pain, which mimics myocardial infarction. And this should be ruled out. Only thing that this patient cannot lie down properly. Patient has pain more with the movements, that can rule out the myocardial infarction. Then thoracic outlet syndrome can be there. And very important cause is herpes zoster, as I told, that it starts with only pain, and the pain patient cannot describe. The pain usually is such a variable. It may be dull aching, it may be sharp shooting, it may be radiating from posterior to anterior, and that's why it's sometimes very difficult. On examination, there is no positive finding is there. Third or fourth day, you get eruptions, and then you can come to a conclusion that this is an herpes zoster. So this should be always kept in mind. And this is very important day-to-day condition where you can misdiagnose it, or you can miss it. A good physician also can miss this on first day 1, day 2. Third day, he will recognize that this is the herpes zoster. This already I have covered. So conclusion, define chest pain first, very important. If you define the chest pain, you can come to a conclusion. If you define properly, then only on history taking, you can come to almost 50% of cases will be diagnosed properly. Then types of chest pain. What types of chest pain it is? Where it is having a respiration relation with the movement, relation with the walking or exercise, relation with the emotional this you can find out, and then you can come to a conclusion. Characteristics of cardiac pain or non-cardiac pain. Typical heavy pain on the left arm, so many times to the jaw, so many times to the right arm. Invariably, it is myocardial infarction. And then think of all differential diagnoses, and then you can come to a proper conclusion. Thank you. Thank you very much. Hello.
Hello.
Yeah.
Hello, sir.
Yeah.
You can continue next lecture, or it is combined.
Oh, it's combined. I had combined it. I told you that this is very difficult. Non-cardiac and cardiac pain. It's very difficult to. So I have taken all together.
Right. It is combined. Okay. Sir, few questions I would like to ask. Thanks, sir, for the this very informative lecture. And I would like to ask few questions on the behalf of the audience.
Yes.
Just a minute. After what time post MI troponins are detectable, and what about CPKMB? Not required.
No, troponins are elevated immediately. So, for example, high sensitivity troponin, if you do, the enzymes rise within 2 hours. After first 2 to 3 hours, it starts increasing. It can remain there for 3 days almost, and then it starts declining.
Okay.
But elevated enzymes are always will remain there for 15 days.
Okay, sir. Then HS trop 1 versus trop T, which is better, and when to test it?
Of course, HS troponin is better because where the cardiac work is done maximum, usually they will rely on HS troponin, and this comes positive within a shortest period of time. If it is not positive, if patient comes to you within half an hour, 1 hour, if it doesn't show indication of rise in a troponin, then you can repeat it after 2-3 hours, and then there will be a serial rise of enzymes.
Sir, another question. What is your experience in those years about the doctors coming with the chest pain?
Doctors coming with the chest pain.
Themselves coming with the chest pain. So they are more anxious, or
medical persons coming with the chest pain. They are more anxious so many times. And as I told, that functional chest pain is more common amongst medicos. Right. Always. Because suppose my technician works with cath lab or my cardiac department, and then every day he sees the patients, and then sometimes some chest pain, he will feel that it is a myocardial infarction. Anxiety gets aggravated.
Okay. It was very nice presentation, sir. A lot of years of experience behind it. And we are very much thankful to you, sir, for presenting the lecture in our CME. Thanks once again.
Actually, most of the audience will be general practitioners. So I just wanted to tell, because
yes, exactly.
There are many problems I have seen in last 40 years. Many general practitioners coming with a dead body. Patient has actually, doctor has given some diclofenac, nothing to do with that myocardial infarction. But it is his bad luck that he has given diclofenac and patient has ventricular fibrillation. And the patient's relation will say that you have given an injection and this has not happened. So I have to tell situation is very terrible. I have to explain it is not this. If the relations are very aggressive, so many times I advise this postmortem just to save the doctor.
Right,
because once it comes myocardial infarctions, that doctor cannot be tortured. So it's very important. So what should be done and what should not be done is very important. Explanation that this could be a myocardial infarction, because nowadays every general practitioner can have a machine and he can communicate it with WhatsApp or any other modality to a physician. He can come to this.
Right. Yeah. Thanks once again, sir.
Thank you very much.
Thanks once again to all the speakers for giving your valuable time and inputs. And very much thankful to all the delegates too for keeping interest throughout all the 8 lectures. And at the fog end of the day also, there were more than 400 participants.
460
yes, more than, yes. And we are very, Yeah,
Thank you very much for calling me here. This is very wonderful. This offline lecture would have been much better, but it will
Yes.
start soon. We can
So-
enjoy this.
Yes, sir. We are very much grateful to MMC observer of the CME, to Dr. Nitin Patil, and special appreciation of the efforts taken by Mr. Piyush Kale and Vaishali Madam of DigiShield for making CME successful online. Now, coming towards the end of the program, I would like to invite Secretary of our IMA, Dr. Suhas Joshi, to deliver the vote of thanks. Thank you.
Good evening, all. It was a fantastic CME today. We have all the renowned faculties today. Dr. Lakshman Jasani, Dr. Mahesh Mohite, Dr. Roy Sunil Patankar, Dr. Parimal Lavate, Dr. Rahul Kulkarni, Dr. Govind Kulkarni, and Dr. Manohar Inamdar. On behalf of IMA Sangli, I am thankful to all the national faculties who have enlightened us in today's CME. The different approaches towards fever, acute abdomen, headache, and chest pain related things have been discussed widely today. I am thankful to the organizing team of DigiShield, Dr. Udgavkar and Dr. Malani, as well as the participants and the discussion leaders in today's CME. I am thankful to Dr. Sanjay Kulkarni sir. I am thankful to Dr. Srivastav sir and all the concerns for attending today's CME. I am thankful to our president, Dr. Mrs. Madhavi Patwardhan, for her great contribution in today's CME. I am thankful to the team DigiShield as well as all the registered participants, delegates for their immense support during registration as well as during attendance. This was a day-to-day clinical points which were discussed, and we have got many new thoughts or new concepts during this discussion. Thank you all. On behalf of IMA, I extend my warm thanks to all of the participants as well as the faculty members. Thank you.